Good morning, guys. Are we ready to get started?
Good morning, council member. We're ready when you are.
Great. Ashley, are you ready?
Ready.
Awesome. Okay. Good morning. I'd like to call this public hearing of the Committee on Health to order. Today is Thursday, July 11th, 2024. The time is 9:30 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. This is a virtual hearing with public and government witnesses testifying virtually. Today, we will consider 2 nominations to the Board of Dentistry within DC Health and 3 bills before the committee. Bill 25-0696, the Advancing Range of Reproductive Options for Washingtonians Amendment Act of 2024. Bill 25-759, the Child Behavioral Health Services Dashboard Act of 2024. And Bill 25-692, the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. We will start with the 2 nominations before the committee. PR 25-840 nominates Dr. Eric Bradshaw to the Board of Dentistry for appointment as a dentist licensed in the District of Columbia with a term to end November 30th, 2026. Dr. Bradshaw is a general dentist with advanced training in implant dentistry, cosmetic dentistry, and Invisalign. Dr. Bradshaw operates his private dental practice, Mint Dental, in the district. He earned his doctorate of dental surgery from Howard University, and he is a Ward 4 resident. PR 25-841 nominates Dr. Janelle Anamalici to the Board of Dentistry for an appointment as a dentist licensed in the District of Columbia with a term to end November 30th, 2027. Dr. Anamalici, apologies, doctor, is a board-certified pediatric dentist and the CEO of Children's Choice Pediatric Dentistry and Orthodontists. She earned her doctorate of dental surgery from the University of North Carolina, and she is a Ward 5 resident. I don't see any of my colleagues, but if they join, we'll certainly turn to them for opening statements. So I'm going to go straight ahead to the nominees. So if Dr. Bradshaw, if you could also turn on your camera. I need to swear you both in before you begin your testimony. So if you could raise your right hand in the screen so we could see. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
I do.
Great. Okay. Dr. Bradshaw, when you're ready.
Thank you. Good morning, Chairperson Henderson, members of the committee, and staff. My name is Dr. Eric M. Bradshaw. Thank you for the opportunity to testify before you today, and thank you to Mayor Muriel Bowser for nominating me for this appointment to the DC Board of Dentistry. I'm grateful for the opportunity to share my testimony. I am a native Washingtonian, a proud product of DC Public Schools, and a practicing general dentist. I own and operate dental practices in both Northeast and Northwest DC. I received my MBA from Southeastern University in 2001, my Doctor of Dental Surgery degree from Howard University College of Dentistry in 2009, and I subsequently completed a 1-year residency in advanced education in general dentistry in 2010. In my personal time, I am deeply committed to community service. I've participated in domestic and international outreach programs aimed at increasing access to dental care for underserved populations. I've been on dental mission projects as near as DC, Maryland, and Virginia, and as far as Jamaica and Tibet. I am passionate about dental health and education. Volunteering my time for this board is a natural extension of my commitment to improving oral health in our community. My professional experience has provided me with a greater understanding of the challenges and opportunities found in dental practice. One of the challenges facing the district right now is the licensed professional to licensed support staff ratio. Ensuring that we have an adequate number of dental licensed dental assistants and hygienists is critical to maintaining high standards of care and improving provider capacity to serve the public. Additionally, maintaining consistent quality of care is essential. As a business owner, I've implemented rigorous quality control measures and continuing education programs to ensure that my team stays current with the latest advances in dental care. This experience has equipped me with the knowledge and skills necessary to promote best practices and uphold high standards for the benefit of the district. If confirmed, I would like to focus on the issues surrounding adequate licensed support staff ratios. I look to collaborate with educational institutions and professional organizations to attract and retain dental professionals, ensuring a robust and capable workforce. Additionally, I will advocate for initiatives that support additional professional development in the district. I'm committed to contributing positively to the DC Board of Dentistry and to the health and well-being of our community. I believe my experience and dedication to high-quality care and problem-solving will be valuable assets to the board. I thank you for your consideration of my nomination, and I'm happy to answer any questions you may have.
Thank you so much, Dr. Bradshaw. Dr. Anamalici?
Good morning, Councilperson Henderson and members of the committee. I am Dr. Janelle Anamalechi, and it is my pleasure to receive your consideration for my nomination to serve on the Board of Dentistry. I am grateful for Mayor Bowser for nominating me and honored to have this opportunity to serve the residents of our district. I have practiced pediatric dentistry for 18 years and served the district for 12 years, beginning in oral health policy, director of a nonprofit dental center in Southeast DC, then to academia at Children's National Hospital and Georgetown Law, and private practices in Northeast DC and New Carrollton, Maryland. I've wanted to be a dentist since I was 5, and I've had the opportunity to locally, nationally, and internationally do this. And my work as past president of the American Academy of Pediatric Dentistry DC chapter, and my current work for the American Academy of Pediatrics DC Oral Health Advocate, I am pleased that I take a role in continuing to push forward the practice of dentistry for the protection of patients and as a health service to our community. Being a part of the Board of Dentistry continues to elevate my commitment to my profession, the District of Columbia, and the people we serve. This board has been working diligently to make significant changes and clarifications that help reframe dentistry, its scope and quality assurance, and its practice in the district. I am passionate about making sure our community has access to the most highly trained and competent health professionals, and as we make decisions around how we do this in core competency to deliver quality for our dentists and allied dental professionals. I am dedicated to making sure this is done in a fair manner that serves the consumer and the professional. I have experience working with this in my service with the Maryland Dental Action Coalition, Maryland Oral Health Policy Committee, and the Scion Committee. As a new member of the board, I hope that I can serve with fresh eyes and ideas that are relevant to dentistry and continue to bolster its face in our community. We can serve as a model for other health professional boards in the district and throughout our country. Thank you, Chairperson Henderson, for the opportunity to testify before this committee. I will be happy to respond to any questions you may have.
Thank you so much. And thank you to both of you. I want to say at the offset for your willingness to serve. We have 19 professional boards under DC Health, and we have it's a lot. This is an additional thing on top of your regular practice and your regular work. So we appreciate you serving not only district residents, but also your fellow colleagues on this. I do have a few questions. Dr. Bradshaw, you mentioned in your testimony you wanted to look at staff ratios. Can you say a little bit more about that?
Yes, I did a quick Google search on the Bureau of Labor Statistics and found that the national average for dentists to, dental assistants to dentists is about 3-to-1. So there are 3 dental assistants nationally for 1 dentist. And in the district, we don't have that ratio. At last check, about a year ago through the DC Dental Society, that ratio is more like 2 dentists to 1 assistant. And so we're backwards in that regard. And I think there's room for improvement there.
Okay. In general, do you feel like there is a path for someone who is a dental assistant to go to dental school and become a full dentist in the same way that someone could, I often say, like, there's a path if you are a certified nurse assistant or a home health aide, there's a path into nursing and sort of a career ladder growth, if you will. Do you think that types of career ladder also exists on the dentistry?
Yes, I do. In fact, I speak with my staff about that regularly. Yeah, it just takes education. I'm a huge proponent of education, and moving beyond high school into uh, undergraduate is going to be the path for that. And so I speak with my staff about that frequently.
Right. Dr. Anamalechi, I want to bring you in on this conversation. So as I understand it, there are 62 pediatric dentists that are licensed to practice in the district, but there are only 37 who do. What do you think the reason is for that discrepancy?
I think some of it is the saturation of DC and the ability to practice within the scope of DC. We have a lot of private practices. There are a lot of dentists that want to come into the area, but the opportunity to do so, space to do so, the length of time that it takes to get licensed is one of the deterrents to doing so. And so a bigger also in a lot of our dental contracts, there's also limitations on scopes of practice once you leave, and DC is only 10 square miles. So you have to leave DC sometimes if you're getting out of a dental contract within the district.
Interesting. Okay. In terms of your own experience getting licensed in the district, how long did it take?
12 years ago, so it took 3 to 5 months. And then after that, I had to get licensed under the insurances, which took another 4 to 5 months. So I had the opportunity. I was in North Carolina at that time applying to get into DC, but you have to generally wait for your state license to then get your insurances if you're accepting insurances in the practice. And that scope, especially being licensed under Medicaid, took a long time.
Okay. Dr. Bradshaw, did you have a similar experience of 3 to 5 months waiting?
I did. I was licensed first in Maryland, and so I was practicing in Maryland, and then waived into DC. However, that did take about 3 to 4 months to get that license for DC.
Okay. I hope that as when you all are confirmed, this is something that you can work on. We often hear, not just from the dentistry practice, but all of our health professionals, that they prefer to be licensed in Maryland or Virginia because their processes are quicker than ours. Now, Virginia is a little bit different because they don't require a criminal background check, which does take a little bit of time. But we have, or at least since I've been chair of the committee, I've been trying to try to better understand from our boards, particularly at DC Health, what takes us so long in comparison to Maryland. Why? Why does it take 3 months for you all to review paperwork? Is it staffing?
It's staffing. I think
Is
it's
it
staffing.
something else? I don't know. You want to say more about that, Dr. Anamalechi?
No, I was just saying, I think it's staffing. I think it's the ability to handle the amounts of applications that are coming through, because within the district, we have Howard University that's, putting out a lot of new graduates. A lot of them want to stay in town, but that's an overflow at certain periods of the year, and we have to be prepared for that, which I don't think we are prepared for staffing wise at the highest point of applications throughout the year.
Yeah, I imagine there is an ebb and flow around graduation versus not. And yeah, this is something I'm going to keep pushing on because I just don't understand it. Nor do I understand, right? Like how I could track a pizza, but I can't track my application. Right? Like I hear from folks like they apply and then it essentially goes into a black hole. You don't really know where you are in the process. You don't know what's holding it up. And when you call, you may or may not get an answer, for a couple of weeks. Whereas if I want to know where my pizza is it in the oven or did the person pick it up? Like there's a tracker, and I just don't understand why we can't sort of do that. Dr. Bradshaw, as an adjunct faculty at Howard's Dental School, you established and operated a grant-based dental clinic at Dunbar Senior High School. Can you speak more about that experience and whether or not you feel like something like that is scalable?
Sure. That was in conjunction with Howard University Hospital. And I was asked by the dean of the College of Dentistry at the time if I would assist with that effort. And so basically there was, Dunbar was revamped, or a new school was built. There was a dental clinic as well as a health clinic in there, and I was asked to be a general dentist. And I was there for about a year and a half and helped to grow that clinic and treat students. I did not work on the grant side of that. That was someone at the hospital who did.
Mhm.
However, I was there day to day with that process.
Did you find that providing or having the clinic in the school led to more students using it, or can you talk about the utility piece of it?
Certainly. Yes, there were a number of students that used the facility, and the healthcare staff that were in that suite would actually go around into the classrooms and basically recruit students to come and be seen. So I didn't have to do any of that recruitment like I do in my own private practice.
Mm-hmm.
However, there was support staff that helped with, as I said, the grant writing process, the acquisition of patients or recruitment of patients, and I was there to help and make sure that the clinic had everything it needed so that we could treat those patients.
Yeah. I talk to some parents and they don't realize that the dental form is required, or it's supposed to be required. Like, your kid's supposed to go get their checkup every 6 months. Y'all the dentists, y'all let me know.
Oh.
I
Yep.
I just took both of my kids, so
It's 6
I know
months.
when they tell me.
That form is required annually. However, yes, checkups are required or should be encouraged every 6 months.
Mhm.
Yes. But folks like sort of fall off on this front, and also not realizing, I think, that infections of the mouth can impact other parts of the body. And so where do you both sort of see the board's role in helping DC Health elevate messaging around preventative care and the necessity, particularly as it pertains to teeth?
Mhm.
I think one of them starts with potentially being able to have an electronic version of the dental health form that can be completed, because I think where it falls off is our nurses are already understaffed. And so to look at that, I don't think the form gets looked at. And I think we miss an opportunity to serve our kids of the district. And so if the form was potentially electronic, then we could run that data and look at the kids that need help and target the kids that need help. But looking at a paper form and having a person looking at that paper form, those kids they're not being, I know they're not being by, because I track the ones that we send and see if we're going to get a remark back from any, of our school officials.
Dr. Bradshaw?
I'm not sure where the board would facilitate that. I really think that's at the private practice level to be able to educate the public. I'd have to look at that more, to be
Okay.
frank. Yeah.
Understood. Okay. Dr. Bradshaw, you talked about wanting to additional professional development being something that you want to work on,
Mhm.
if confirmed. Can you talk a little bit more about that? Is talking about like continuing learning requirements or something different?
Well, I'm a huge believer in continuing education. So we obviously know that 30 hours of continuing education is required every 2 years to renew a license. At this last renewal, I calculated mine. I had 126 hours. That's because I love to learn. Okay. So I go above and beyond, and that's for my own personal benefit as well as patients' benefit. And so I'm just a believer in education and being able to at least have something that is very relevant to private practice. And so, no, I'm not saying that maybe we should increase the 30 hours to something else. What I'm saying is maybe there should be more transparent communication about here's what's required to renew a license, and then here's some additional professional development opportunity that may be helpful for the community we serve.
Got it. Yeah, sometimes if you make it not available to folks, they'll know. Dr. Anna-Malici, if you wanted to add, do you want to add on that?
No, I agree with that. And I also agree to extending that within our allied health professionals, because, in private practice and even in the hospital setting where I'm at, we want to make sure that those that work with us, our hygienists, our assistants, are equally as competent. And they're also required to have a rigorous continuing education program that allows them to bolster themselves. So as you were talking about that tracking to next level, or dental school or such, having exposure to those types of things gets you more interested in potentially doing that. And I think that's where we fall short, is on that allied health level of bolstering them to a level of competency alongside the dentist and the dental hygienist.
Great. So you both are new appointments. Have you had conversations with DC Health around the time requirement for serving on the board? And are you confident that you can give time to this?
Yes and yes.
Yes, I asked about it, and yes.
Okay. Well, I don't have any other further questions for you. Is there anything that I didn't ask you that you want to make sure that you get on the record?
Councilperson Henderson, I'd like to hear a little bit about what your goals for us would be as we step onto the board.
Oh, wow. Okay. I want our boards to be the most high functioning that they can be in terms of meeting the needs of the workforce. I think one of our biggest challenges that we've heard, like the number one thing that I hear from providers, is around the time it takes to get a response back from the board, or the time it takes for an application to be processed. And so in any ways that we can help reform that process to make it more streamlined, or modernized, and using some of these online technologies to be able to do that, that's what I'm hoping for from the board. And then, of course, there are the other delightful duties of the board, which is, when you all have to hear complaints about your colleagues or unprofessionalism, et cetera. And, our expectation is that you all review those unbiasedly and, make the best determination and judgment on behalf of residents and with patient safety in mind.
Thank you.
Great. All right. Well, I want to thank you both for your willingness to serve again. If any members of the public would like to submit statements on these nominations, the record will remain open until this afternoon at 1 p.m. on July 11th. I know it's a very quick turnaround, but we are voting on these nominations today. Or we would like to vote on your nominations this afternoon. So folks can submit their written statements via the council's hearing management system site at dccouncil.gov/hearings. Thank you, Dr. Bradshaw, and thank you, Dr. Anna Malici, for your time. Really appreciate it.
Thank you.
Thank you, Councilor. Take care.
Okay, we will now move on to considering Bill 25-0692, the Advancing the Range of Reproductive Options for Washingtonians Amendment Act of 2024, also known as ARROW. I introduced this bill along with council members Anita Bonds, Janice Lewis-George, Brianne Nadeau, and Brooke Pinto on February 14th, 2024. The bill would require private insurers, Medicaid, and the DC Health Care Alliance to cover vasectomy procedures and services and impose no cost sharing requirements on these services. It was jointly referred to the Committee on Health as well as the Committee on Business and Economic Development. The responsibility of pregnancy prevention should not fall solely on the partner with a uterus. A vasectomy is one of the most safe and effective kinds of birth control, and yet it is severely underutilized in the United States. Vasectomies are almost 100% effective at preventing pregnancy. It's very low risk and are up to 6 times cheaper than the female sterilization procedures. Yet only 5% of men ages 18 to 45 have undergone the procedure in the United States, a much lower rate than Canada and the United Kingdom, which is at 17% and 22% respectively. In contrast, almost 20% of women in the United States have undergone a comparable procedure, tubal ligation. There's an increasing interest in vasectomies in the United States and in the districts since the Supreme Court issued the decision Dobbs versus Jackson's Women's Health Organization in June 2022, overturning 50 years of court precedent, protecting the constitutional right to an abortion, and returning the power to regulate abortions to the states. Planned Parenthood of Metropolitan Washington saw such a significant increase in vasectomy requests that they started a new practice focused on this line of service, where they have seen patients pay up on average of $600 out of pocket and $425 in deductibles for these services. Yet in the district, there is no requirement that private or public insurance plans cover vasectomy services and require no cost sharing. This legislation would align the district with 9 other states that require health insurance plans to cover vasectomies at no cost to the patient. The bill exempts nonprofit organizations who qualify for religious exemptions and enrollees of high deductible healthcare plans to align with federal requirements. I will note that although this legislation covers DC HealthLink plans, the Health Benefit Exchange Authority opted to not submit testimony, but they did communicate in its analysis that the financial impact to the Department of Insurance, Securities, and Banking, who will testify today. I will also note that DC Medicaid has communicated to the committee that vasectomies are covered at no cost sharing under Medicaid. So I expect that Department of Healthcare Finance's testimony today to be brief to confirm that for the record. I don't see any colleagues, so I'm going to go to our witness, Dr. Serena Floyd, who is the Chief Medical Officer for Planned Parenthood of Metropolitan Washington, D.C. Dr. Floyd, when you're ready.
Wonderful. Thank you very much. Good morning, and thank you for the opportunity to provide testimony on this very important legislation. As you mentioned, my name is Dr. Serena Floyd. I use she, her pronouns, and I am the Chief Medical Officer at Planned Parenthood of Metropolitan Washington, D.C. I am a board-certified obstetrician gynecologist and have been providing reproductive health care for over 20 years. I also have an MPH in maternal and child health from the School of Public Health at the University of North Carolina at Chapel Hill. I'm the former chair of the American College of Obstetricians and Gynecologists Committee on Advancing Equity in Obstetric and Gynecologic Healthcare. And I am the immediate past chair of the National Medical Committee of Planned Parenthood Federation of America. PPMW is a longstanding provider of reproductive health care and annually provides healthcare services to nearly 30,000 patients in the DC area. I am testifying today in support of Bill 25-0696, advancing the range of reproductive options for Washingtonians Amendment Act of 2024, also known as the ARROW Act, as we've already heard. And I thank you, Councilmember Henderson, for your leadership in introducing this bill and bringing it forward for a public hearing today. I also would urge Councilmember McDuffie to do the same in his committee when the council returns from recess in the fall, so this bill can be passed before the end of this year's legislative session. I also want to thank the other council members who have signed on as sponsors. The ARROW Act, as was mentioned, would require private insurers in the district, DC Medicaid and the DC Healthcare Alliance to cover vasectomy services with no cost sharing for enrollees. Unlike contraceptive methods that are controlled by partners with a uterus, which have not required cost sharing since implementation of the Affordable Care Act beginning in 2012, vasectomies are not subject to the same protections. A vasectomy at our affiliate costs on average about $600 out of pocket, but can cost up to $1,000 depending on where a patient is seeking care. And the fees, excuse me, a combination of deductibles, additional fees, and just the cost of the procedure can make this very cost prohibitive for the average patient, which means that it can put the procedure out of reach and leave the less effective contraceptive choice of condoms as the only option for partners with a penis if they want to be responsible for birth control. All forms of contraception should be subject to the same coverage and cost-sharing protections so that those who rely on them do not have to make tough choices between paying for their birth control versus paying for other necessities. PPMW began the new practice of offering vasectomy services at our DC Health Center just a few months after the Dobbs decision in 2022, and this was in direct response to strong community demand. That demand continues to be strong. And it is likely that even more people desire the option of vasectomy, but are unable to access the procedure because of financial constraints. We want to ensure that a person's wallet does not dictate their method of contraception, and the ARROW Act will help make that possible. The ARROW Act would put DC in good company with the 9 other states who have already mandated vasectomy coverage with no cost sharing, and thus have expanded access overall to contraception in their states. Washington, D.C. definitely should join their ranks. Thank you again to Councilmember Henderson for your leadership in sponsoring these important bills and for holding this hearing. I again urge the committee to move quickly in passing this bill, and I also urge Councilmember McDuffie to schedule a hearing on this legislation and his committee as soon as possible when the council returns from recess this fall. I am happy to answer any questions from the committee. Thank you all very much for your time today.
Thank you, Dr. Floyd. Ashley, can you put me on a 5-minute clock just so I can stay honest? Excuse me, to myself. Dr. Floyd, thanks so much for your testimony. I was wondering if you could talk a little bit about the volume that you all are seeing or what you might be hearing from your other colleagues across the district and the region around an increased request or demand for these services.
Yeah, so I mean, for our affiliate, since we started our procedures in November of 2022, we've seen a significant increase in the overall percentage. We generally hold a clinic for our vasectomy services about once per month. And over the past couple of years, for various reasons, we've had some months where we've had to defer the clinic. But essentially from the very first month that we completed the procedures in November of 2022, where we did 2 that first visit, we've done as many as 15 in the past couple of months in one day session, like a single 1 day session in a month. So per month, I should say. So yeah, so we're seeing, we've seen a pretty significant increase in the demand, and we've even had to institute at times a waiting list so that because our templates will only allow us to do so many procedures in a day, and we only have it once a month. And so we've had to implement a waiting list for those patients who desire to have a procedure in the event we have a cancellation so that we can try to get them in. And I think just in general, across the country and among my colleagues, we're seeing the demand rise so much so that there are those who are seeking out training to be able to perform vasectomies who had not previously been performing them, but to be able to expand their offering of contraceptive services to their patients. They want to be able to add this to the service mix. And that's for multiple reasons, not the least of which is that vasectomy is a pretty easy, straightforward procedure. An individual comes in, it takes about 10 to 15 minutes, and then they're able to go home the same day. Very, very different than when you're someone with a uterus and tubes is undergoing permanent contraception, the procedure for permanent contraception in those instances. And so post-Dobbs, again, with everything that everyone is facing, and really an increase in the desire for partners to take more ownership over contraception in the relationship. All of these are reasons why we're seeing upticks in the demand.
Thank you. And like you said, this is not a new procedure, but change in political circumstances and knowledge base, right? Folks are trying to seek out other ways to either, protect themselves, protect their partners, et cetera. Do you feel like this change in insurance policy might help? Let me back up. Let me ask you sort of 2 questions. In your experience, whether for any contraception, what's the number one reason why someone doesn't necessarily move forward with it? Is cost up there in terms of if it's not covered?
Sorry to interrupt. Yes, cost is definitely a factor. I mean, it can be multifactorial, right? Like cost can be an issue, but access can be hindered by more than just cost, but cost is hands down a major contributor to why individuals are not able to access the chosen method. And when we talk about methods like permanent contraception or the long-acting reversible methods, which tend to be have the higher cost associated with them, that cost can be the thing that will put that particular method out of reach for a patient. And so it's like I said, there can be multiple reasons why there are challenges and multiple barriers that people face. Access to providers that are able to, for example, provide that method, especially when it comes to methods that require a certain skill set, like vasectomy and long-acting reversible methods. But cost is a definite factor.
Okay. And just for, I didn't go to med school, so I'm just curious, for these types of procedures, is this not something that is covered generally in med school, or is this a specialty practice?
No, it's not. Well, so it not in medical school. So this is something that folks generally will learn when they're in their residency training. So medical school is just kind of general. Everybody kind of learns the same information. It's like the book side of it. Residency is when you learn the hands-on side of it, and you become proficient and competent in that skill delivery. And depending on the type of residency program you participate in, it may be part of the training. Traditionally, urologists have been the ones who have done vasectomies, and it is part of their standard training. It is not routinely part of the standard training for other types of subspecialties, although some individual programs may incorporate it into their training. For example, some primary care programs may. But even if it hasn't been part of your training that you went through prior to becoming independent practicing provider, there are absolutely places where people can go to become trained after the fact. And that's what we're seeing is, there are primary care providers, there are OBGYNs, there are even advanced practice clinicians who are learning this skill so that they can be able to offer it because the demand is increasing in the way that it is.
Right. Is there more that we can do to reduce the stigma or misinformation around vasectomies?
Yeah, I mean, I think unlike some other forms of contraception, like there may not be as a great an issue with the misinformation side of it. Well, let me not say that because certainly there is information out there that can cause folks to have fear and anxiety about what will happen subsequent to undergoing the vasectomy procedure, in addition to concerns about things like pain and things like that during the procedure. But really, it's, as I said before, it is a very straightforward procedure that is very effective, has very low complication rates. That is, as I said, much easier for an individual to undergo than it is for sterilization or a permanent contraception procedure to occur for someone with a tubes in a uterus. So I know in conversations we have with patients, we definitely, since there are really no other options for contraception for those with a penis other than condoms, right? And between condoms and vasectomy is it's again permanent as well as significantly more effective. And so for someone that really wants to take ownership over contraception in their relationship, they've got those two options. And one is, much less ideal than the other. For vasectomy, really just encouraging and putting the information out there about the safety of the procedure, about the effectiveness, and really promoting that it is an option that allows that other partner to take more control and to be more of an more actively involved in preventing pregnancy.
Yeah. It's so funny. This is now 2 days. We had a hearing yesterday and we were talking about misinformation from folks who were purporting to be nutritionists or dietetics, right? On TikTok or Instagram saying like, oh, use this pill or use this. And it's the same in sort of the conversations, right? The misinformation that is out there. I just wish like, do not get your information from the internet. Call a health professional.
It's it definitely has been a problem, particularly with TikTok, around various contraceptive methods. And yeah, if there were a way to regulate that, that would be wonderful, because it certainly does deter people from seeking options that really could be a great option for them if they weren't, scared out of it by information that's completely inaccurate.
Yeah. All right. Well, thank you so much, Dr. Floyd. We did some research. So on this particular bill, we only need one hearing. And so we're going to work with Councilmember McDuffie to try to get this moving forward. But we appreciate you being here and for the ongoing, not just services that Planned Parenthood Metropolitan Washington provides district residents, but the advocacy work that you all do on behalf of the patients that you serve each and every day. So thank you so much.
Thank you.
I'm going to call our government witnesses, Philip Barlow, who's the Associate Commissioner for Insurance with the Department of Insurance, Securities, and Banking, and Wayne Turnage, who is the Deputy Mayor for Health and Human Services, as well as the Director of DC Department of Healthcare Finance to provide committee testimony. Before we begin, I need to swear you all in. So Mr. Barlow and Director Turnage, if you could raise your right hand. In the screen. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. All right. Mr. Barlow, when you're ready.
Thank you. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Philip Barlow, and I am the Associate Commissioner for Insurance at the Department of Insurance, Securities, and Banking, or DISB. DISB regulates insurance, securities, banking, and other financial services in the District of Columbia. Our mission is threefold. First, to cultivate a regulatory environment that protects consumers and attracts and retains financial service firms into the district. Second, to empower and educate residents on financial matters. And third, to provide financing to district small businesses. Thank you for the opportunity to testify today on Bill 25-0696, the Advancing the Range of Reproductive Options for Washingtonians Amendment Act of 2024, also known as the ARROW Act. The Arrow Act would enhance health insurance coverage provided through private insurers, Medicaid, and the DC Healthcare Alliance to ensure coverage of vasectomy procedures and services without cost sharing. As of 2024, at least 9 states require state-regulated health insurance plans to cover vasectomies at no cost. Please note that under existing law, the district already includes coverage for vasectomy and vasectomy reversal in individual and small group health plans due to its coverage in the Essential Health Benefit Benchmark Plan termed voluntary sterilization and surgical reversal of voluntary sterilization. But they could require cost share. A change to cost sharing for individual and small group plans would not be considered a new mandate, so the district would not be impacted from a federal defrayal perspective. This would, however, be a new requirement for large group plans, but there are no nuances to implementing the coverage in the large group market. The ISB supports the proposed bill with the following recommendations. We recommend the council clarify whether the surgical reversal is covered without cost sharing in addition to the vasectomy itself, or the intention is for procedures and services to broadly include reversal, since reversal is often excluded from coverage. Another point to note is that insurers will need time to update plan documents and form and rate filings to address the change to cost sharing. We recommend an effective date of January 1st, at least 6 months after the law becomes effective. We are available to work with the committee to help incorporate our recommendations. The department is fully supportive of the council's efforts to increase access to care and hope that we have offered information and valuable suggestions today. Thank you for the opportunity to testify on this bill, and I'm happy to answer any questions that you may have.
Thank you, Commissioner Barlow. Director Turnage, I don't know if you have a statement.
I do not have a statement beyond my confirmation that Medicaid covers vasectomies with no cost sharing. Thank you.
Director Turnage, I feel like this is a record. Okay, let me get into some questions. So thank you so much again for being here. Director, so you're confirmed that DC Medicaid already covers vasectomy procedures and services with no cost sharing. Related to Commissioner Bartlow's last point about surgical reversal, how does coverage work for that?
We cover reversals as well.
Okay, all right. We want to try to do parity and equity. So if we're going to do, if that is how it is covered for Medicaid, then to Mr. Barlow's point, then we might need to make some clarifications there on the other side of.
And you're not asking me, should we cover reversals? You're just saying whether we cover it or not, correct?
Right. I was just asking whether or not it is covered. That's all. I'm not making any other judges statements. That's all I'm asking. So Commissioner Barlow, you mentioned in your testimony, and I just want to confirm again for the record that you all have talked with the Health Benefit Exchange Authority, and they've communicated to you all about their estimated defrayal costs, which they said there shouldn't be a defrayal.
So the determination of defrayal is something that falls under our authority. So we have evaluated the current essential health benefit plan for the district, which includes the requirement. So it gets a little bit complicated. You know, it's not a requirement previously in district law, but because it was in the original essential health benefit plan that was adopted by the district, then insurance companies in the small group and individual market had to cover it. So this is not a change to add a new benefit to the coverage. It's just a change with regard to cost sharing, and that would not require defrayal.
Okay. Does DISB have any data on the average cost sharing requirements for vasectomy procedures under current private insurance plans?
We don't have that information. We could you know, if you want that information, we could reach out to the insurance companies to provide that.
I think it would just be helpful for us as we move forward to just better understand. Dr. Floyd talked a little bit about the average, but that was sort of a nationwide perspective of how much it can cost. It would be, I think, helpful for us to just understand what's happening with the insurance offers here in the district, to just better understand that. Okay. Mr. Barlow, you mentioned one of the recommended changes was that we changed the effective date to January 1, 6 months after the effective date of the bill. What year?
So whatever year. So again, you know, there are kind of two things happening here that kind of rely on that. One of them, it takes insurance companies about 6 months to develop new forms and rates when a new requirement is added to a plan, and get those filed and approved by us and get their administrative system set up. So generally speaking, you know, in an ideal world, we give the insurance companies 6 months. The other thing that's that has come since the Affordable Care Act is that plans, the individual and small group plans sold through DC HealthLink, we review their rates and forms just once a year. We are currently reviewing the rates and forms for 2025 right now. And so, you know, so we will approve them in the next couple of months for 2025. And so if the implementation of this happens like in the middle of 2025, we won't have the ability to align the language in the forms and the individual small group markets.
Yep.
You know, we can still enforce the requirement if it becomes law at a different time. So, you know, there's nothing that prohibits it from becoming effective at an earlier time, but it would not be identified in the policy forms, particularly for, you know, the individual small group plans on DC HealthLink until the following January. So that's just the consideration.
This is part of the frustration of insurance policies. It is 2024 of July. We're having a hearing on this bill, and doing the calculations of what you just talked about. This bill it won't be fully, you're essentially saying January of 2026.
Well, again, that would be, you know, that's in the perfect world if we could wait that long. If you wanted to make it sooner, you know, again, we would enforce the requirement when the law became effective. But the problem is, again, there would be inconsistent information in the policy forms, particularly those for the individual small group, until we had the opportunity to update them, the insurance companies and us had the opportunity to update them for 2026. So it would just lead to, you know, the requirement would be there, but it just would not be as clear in the policy forms that the insureds had.
Okay. All right. Well, I don't have any further questions for you all. Is there something I didn't ask? Well, I feel like if there is something I didn't ask that we need to clarify, we could certainly do that offline as we sort of work through the process over the next few months on this. But that's all I have on Arrow. So thank you, Commissioner Barlow. Thank you, Director Turnage.
Thank you. And we will work to get you the information on the average out-of-pocket cost for the
Yes, that would be helpful. Thank you. Okay, so we are going to move to the public witnesses for the Child Behavioral Health Services Dashboard Act of 2024, as well as the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. I'm going to do the public witnesses for this together because the government witnesses are the same for both bills. And so we could just have a single conversation with them. At the offset, I will say for any of our public witnesses who have not joined us for a hearing, you will need to affirmatively accept our invitation to become a panelist, but I'm going to tell you a little bit about these two bills, and then we'll get to it. So Bill 25-692, the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024 was introduced on February 5th, 2024, it was introduced by me, along with council members Nadeau, Parker, and Bonds. This legislation aims to strengthen the district's mental health processes regarding involuntary and voluntary commitment procedures, as well as aspects of competency determination in criminal proceedings. Involuntary hospitalization, also known as involuntary commitment or civil commitment, is the legal process that mandates an individual to enter a hospital or psychiatric facility without consent temporarily for mental health evaluation and treatment. According to the Office of the Attorney General for the District of Columbia, in 2022, there were 2,493 FD-12 petitions filed and 2,930 filed in 2023. Involuntary hospitalization is typically pursued when there is a concern that the individual poses a significant risk to themselves or others due to significant risk to, Involuntary hospitalization is typically pursued when there is concern that an individual poses a significant risk to themselves or others due to severe mental health condition. Involuntary hospitalization provides a legal mechanism for an emergency response, facilitating the rapid assessment and admission of individuals in need of immediate mental health care. Involuntary hospitalization policies include safeguards to protect the rights of individuals and contribute to the overall well-being of the community by addressing those mental health concerns that, if left unattended, may lead to emergencies or cause potential harms. As introduced, the legislation has a variety of different reforms, including broadening the pool of those who are authorized to initiate the involuntary commitment process, extending the time for emergency observation and diagnosis, clarifying that individuals have the right to voluntarily agree to remain in inpatient status until the appropriate discharge plan can be implemented, and require the Department of Behavioral Health to develop some online training modules for both healthcare professionals and laypersons on this issue. Bill 25-759, the Child Behavioral Health Services Dashboard Act of 2024, was introduced by Councilmember Zachary Parker on March 24th, 2024, along with Councilmembers Freeman, Robert White, Allen, Bonds, and Gray. I co-sponsored that legislation as well. District children and their families are facing enormous pressures today, which manifest themselves in countless ways. Among the most alarming statistics are the high rates of truancy and absenteeism in district public schools. This troubling trend is a symptom of a larger issue, the difficulty of many children and families that they encounter in assessing behavioral health services to which they are referred. Despite the availability of resources, delays and barriers do persist. Most providers maintain their own websites where they regularly post information, updates, and resources. However, these websites are often designed for a broad audience and may not be user-friendly for families or for youth. Navigating these sites can be challenging, and crucial information about service capacity and availability is frequently unclear or missing. This fragmented and opaque system exacerbates the stress on families already struggling to find timely and appropriate care. To address these issues, the legislation would mandate that that the Deputy Mayor for Health and Human Services develop and maintain a publicly accessible dashboard of behavioral health services available in the district. The centralized dashboard will provide comprehensive, up-to-date information on available services, making it easier for families and youth to find the help that they need. By consolidating resources in one easily navigatable platform, the district aims to create a more efficient and transparent system of care that supports the well-being of children, youth, and their families. Like I said, we're going to now call the public witnesses for these two pieces of legislation. Now, witnesses representing an organization will have 5 minutes to speak. Witnesses representing their own behalf will have 3 minutes to speak. There is a clock on the screen. I hope that all of our public witnesses can be very conscientious of your time, and I will give you a nudge when your time has expired so that we can preserve sufficient time for all witnesses who would like to speak. I'm going to call panel of, hold on. I'm going to call a panel of 7 and see where we get. All right, Salim Adolfo, who's the ANC commissioner in Ward 8. Leah Caslas, who's a policy attorney at Children's Law Center. Brenda Richardson, who's the coordinator of Anacostia Parks and Community Collaborative. Isaiah Timoney. Joshua Miller, from Open City Advocates. George Membrino from DC Action. And Gail Avent from Total Family Care Coalition. Again, you will need to affirmatively accept our invitation to become a panelist for you able to join us. So I'll just give it just a minute. Okay. All right. I don't see Mr. Adolfo, but I do see Leah. Leah?
We'll get started. Good morning, Chairperson Henderson. My name is Leah Caslas. I'm a policy attorney at Children's Law Center and a resident of the district. Thank you for the opportunity to testify on the Child Behavioral Health Services Dashboard Act of 2024. At Children's Law Center, we want our clients and every child in the district to be able to access the appropriate services, treatments, and programs to meet their behavioral health needs. For this to happen, there must not only be a functioning behavioral health system with a full continuum of services and adequate capacity to meet the needs of the district's children, but also ways to navigate and access the continuum of services. In short, parents and caregivers seeking supports like therapy for their children need to be able to quickly figure out available services and make connections. Children's Law Center supports the Dashboard Act, which requires the district, specifically the Deputy Mayor of Health and Human Services, to make available and maintain an online, user-friendly, publicly available dashboard of behavioral health services in the district. Interestingly, there are a number of government agencies that have started to create pieces of what is needed for a dashboard, including DBH, DC Health, CFSA, and DHCF. For example, DBH has the Access Helpline, which is a 24-hour, 7-day-a-week telephone line that is staffed by behavioral health professionals who can refer a caller to immediate help or ongoing care. In addition, various district agencies have created no less than 5 additional navigational and reporting requirements that all should be integrated into the dashboard. These include 1, DBH's website network of care, which helps district residents navigate the behavioral health system. 2, DBH's requirement that the vendor of the District of Columbia Mental Health Access and Pediatrics DC MAP to maintain a comprehensive resource and referral guide for behavioral health providers in the district. 3, DC Health operation of LinkU, a referral platform that is powered by findhelp.org. LinkU is also used by several other government agencies to simplify navigation of resources in the district, including behavioral health. CFSA, as part of their 211 Warm Line initiative, has switched to utilizing LinkU. 4, DC's managed care organization's requirement to have accessible and navigable directories for their user. And 5, the Department of Insurance, Securities, and Banking requirement that all insurance plans operating in the district submit annual reports with similar measures, including providing a current directory of providers and wait times for accessing these providers. Currently, none of these navigation tools or reporting mechanisms are integrated. Providers, residents, the government, community-based organizations are not aligned on a single system. This causes an immense amount of confusion. A simple question, who provides this service that is available now, becomes a labor-intensive task that often leads to disconnect with the behavioral health system. An unnavigable behavioral health system prevents children, youth, and their families from accessing appropriate treatment services and behavioral health supports. The difficulty in navigating the services often means our clients do not access services in a timely manner or at all. In our experience, delays in finding the right provider ultimately disconnects clients from accessing needed services. We hope by that requiring the deputy mayor to work with key stakeholders to integrate systems, the district may improve navigation of and access to timely, appropriate behavioral health services. The council is acting at an opportune time. First, the Center for Medicare and Medicaid Services released new rules requiring states to maintain a single webpage that is readily identifiable identifiable to the public, easy to use, and requires information for public transparency. Additionally, the district is working towards a carve-in of behavioral health services to Medicaid and an 1115 waiver renewal application that hopes to improve care coordination and access to quality behavioral health services. Finally, CFSA has soft launched the 211 Warm Line initiative, which is set up to connect children, families, and community members to DC government systems of care and community-based services. The dashboard is a necessary answer to support these current opportunities, as well as to ensure that we address the piecemeal approach to navigation. We have a clear window of opportunity to ensure integration that supports navigation and improves access. The time is now to leverage existing investments, bring together key stakeholders, and ensure integration that allows for an easy, user-friendly experience. My written testimony further discusses implementation considerations for the dashboard. While there is more work to be done to truly transform the district's behavioral health system, the creation and maintenance of a public-facing functional dashboard would be transformative to access. We ask that the council pass and fund this legislation, as well as provide continued oversight of the eventual dashboard to ensure effective implementation and easy utilization for district children, youth, and their families. Thank you for the opportunity to testify today. I welcome any questions the committee may have.
Thank you so much. Ms. Richardson?
Thank you. Good day, Madam Chair Henderson. My name is Brenda Lee Richardson. I am a Ward 8 resident and coordinator of the Anacostia Parks and Community Collaborative. I'm here today in support of the Child Behavioral Health Services Dashboard Act to look at the children's behavioral health, and so happy to see Director Turnage here. He really cares about our community. I was hoping that you will be able to look at this dashboard, and I hope that you will look at climate change and its impact on children's behavioral health in disfavored communities. Extreme heat effects on physical health are well established, but it also leads to worsening symptoms and more emergency room visits for people with mental health disorders. Studies show intense heat affect our moods, is often linked to feelings of anger or anxiety, and even makes children more likely to perceive others' behavior as aggressive or violent. Extreme heat and poor air quality are also external stressors that can harm young people's mental health, raising their risk for a variety of behavioral and developmental issues like depression and ADHD. Even some widely prescribed psychotropic medications can affect people's heat tolerance and make them more vulnerable to heat exhaustion or heat stroke. But it is not uncommon for patients taking these medications to know about these particular risks. That is why APAC supports the Child Behavioral Health Services Dashboard Act by creating a one-stop resource with up-to-date information about the district's behavioral health services. Residents will be better informed about available treatments and therapies, preventive care, and other health services that have been out of reach before for their children. The dashboard will be especially helpful if users can sign up to receive notifications alerting them to information or updates about specific services or issues that most interest them. We would also like to see language added to the bill to clarify how often the dashboard's information will be updated. We are optimistic that the creation of the dashboard is not the end goal, but a starting point that encourages more departments and agencies that provide critical public services to find new and innovative ways to connect to more residents and especially our children. Thank you, Madam Chair.
Thank you so much, Ms. Richardson. I don't see Asaya, but I do see Joshua Miller. Mr. Miller?
Good morning, Chairwoman. My name is Joshua Miller. I am the Research and Advocacy Director for Open City Advocates, which provides legal representation and holistic advocacy to youth who have been committed to DYRS. Like others, I'm here to testify about the Child Behavioral Health Services Dashboard Act. Robust community-based behavioral health services must be a vital part of any successful juvenile justice system, and the lack of access to such services is a major reason why ours is currently failing. Inadequate provision of services in the community means that more children turn to substances and to delinquency. It means that more of the children who are committed to DYRS languish in secure facilities like the Youth Services Center, decompensating rather than returning to school and the community to receive the services they need to flourish. And it means that more of our children end up shipped out of state to treatment facilities that are unnecessarily carceral at a much higher cost and much lower efficacy than what we could do in the community. This is a human crisis, but it's also a fiscal one. Our over-reliance on secure facilities for children adjudicated delinquent can be directly tied to the fact that our community-based services are overwhelmed. Building and staffing these secure facilities then weighs down our budgets at a much higher cost than similar services in our neighborhoods, and there is a mountain of evidence that incarceration is deeply harmful and non-rehabilitative for children. I've been working in carceral and reentry spaces for many years, and I've frequently found that it is difficult for those who most need behavioral health care to access it. Those suffering from mental health crises are asked to tackle gargantuan bureaucratic hurdles, and when they fail, their failure is often criminalized. It requires an absurd amount of expertise and an actively maintained database to find services for people in need. Although it's a little absurd that we need legislation to create a website, we do need the dashboard described by this bill, and we apparently do need this legislation to order the interagency cooperation required to make this dashboard a reality and to support other efforts like the 211 warm line. So this bill and the dashboard it provides can help visualize the gap between the need and the provision of services, and it empowers the deputy mayor to coordinate across agencies and with private providers. It will give council, DBH, and providers a real-time sense of the desperate needs going unfulfilled. We have a few very small recommendations, and I'll just run through them very quickly and save time for others. I think it's important that we not replicate existing resources, but build a no wrong door system. The goal should be to get real-time reports on systemic accountability measures like available beds and time to treatment, and to provide case managers and providers with information about where capacity exists for referrals. This will help save those seeking services from having to diligently call every provider only to be turned away or ignored again and again. I'd like to think of this as a digital adjunct to the warm line and the Access helpline. We'd really like it if the bill could clarify the types of beds available for inpatient services. This legislation currently requires DBH to provide real-time information on the number of beds available for behavioral health inpatient treatment services, but not all the beds are created equally. What treatment modalities does the institution provide? Does the institution accept children who are just as involved? These and other such questions should be addressed in order for the dashboard to be maximally useful. Because we know that DC providers have refused to treat young people who are just as involved, we would recommend that DC and DBH institute a no reject, no eject policy for all DBH contracted providers of psychiatric facilities. One state that has dealt with this tension effectively is New Jersey. Providers there who accept Medicaid must implement a no refusal intake policy so that no young person is ever turned away from the care they need, and that no matter how difficult things get, they're still entitled to assistance. So I have more to say about oversight and things like that, but I just want to end here. I'm happy to answer any questions and happier still to work with you towards full home rule in a future that is equitable, fair, and compassionate towards our children. Thank you very much for considering my testimony.
Thank you. Mr. Membrino, excuse me.
Hi there. Hello, Chairperson Henderson, council members, and staff of the Committee of Health. Thank you for the opportunity to address the committee today by providing testimony regarding the Child Behavioral Health Services Dashboard Act of 2024. My name is Jorge Membrino, he, him pronouns. I'm the Director of Youth Advocacy at DC Action. DC Action uses research, data, coalition building, advocacy, and racial equity lens to break down barriers that stand in the way of all kids from reaching their full potential. We're also home to DC Kids Count, an online resource that tracks key indicators of child and youth well-being. First, thank you to Council members Parker, Allen, Bonds, Fruman, Gray, Henderson, and Robert White for your sponsorship of legislation to make information about behavioral health services for children and youth more widely available to district families. We appreciate that the legislation will build on the current DBH network of care for behavioral health online resource directory. There are a few areas where additional or clearer definitions in the legislation could maximize its impact, specifically language accessibility and identified competency in working with specific populations. The new dashboard should be fully multilingual for individuals and families whose first language is not English. It should also identify which programs have staff who speak other languages other than English. In all languages, the content should be user-friendly, which means plain language accessible at a 3rd to 5th grade reading level, limit use of acronyms, so spelling out every agency and explain technical behavioral health terms, make sure key resources are available on the homepage so we can reduce the click rate that you need to get to a specific resource, use visual cues to indicate whether services are in person, telehealth, or in the community, and then use visual cues to also indicate the type of service, such as icons to delineate crisis services versus individual counseling, LGBTQ plus or domestic violence survivor, culturally competent providers, etc. In addition to the language accessibility, the dashboard should also identify whether it has competency or expertise in working with specific populations, such as victims of crime and or gun violence, survivors of domestic violence, individuals struggling with addiction or substance use, individuals and families experiencing homelessness, and LGBTQ children, youth, adults, or the elderly. Additionally, when using the phrase system of care for children, youth, and their families, we recommend explicitly defining that this includes services for youth ages 18 to 24, akin to the definition of youth used in the district's homelessness services continuum of care. Finally, we requested the Council and the Department of Behavioral Health work directly with providers to build a system of real-time wait and capacity identification that is not cumbersome to the providers. Having been a clinical supervisor at a core service agency, I can tell you that wait times and capacity are based on a model baseline service day, and those model or ideal days are few and far between. Staff must prioritize responding to the dynamic needs of the center, making it potentially difficult to provide accurate real-time waits or inpatient service bed availability. The launch of a user-friendly resource dashboard should not be delayed by the more complex process of building out a real-time serviceability navigation tool. That work must be closely coordinated with providers and shouldn't rush at the expense of creating more burden on providers or providing unrealistic or inaccurate information to the public. These revisions would help maximize the benefit to children, youth, and families of this important legislation. Thank you for your time and consideration.
Thank you, Jorge. Gail?
Good morning, Councilman Henderson and members of the Health Committee. Thank you for the opportunity to provide testimony today. My name is Gail Avent. I am a mother, a grandmother, and the CEO and founder of Total Family Care Coalition, referred to as TFCC, a not-for-profit family-run organization. I am a resident of Ward 7, and TFCC is located in public housing, Potomac Gardens in Ward 6. Our organization was formed by parents and caregivers who are looking for community-based services for our children in the community. We are one of the leading providers of family advocacy and support of parents and children and youth with serious emotional disturbances in the District of Columbia. We work closely with families to help overcome obstacles. We provide holistic services to families and children. Our mission is to keep families together for a better and safer community. While I have reviewed the proposed legislation of creating a behavioral health service dashboard, I reflect on great ideas of the past that did not implement as the blueprint described. My question to this committee is, has the Department of Behavioral Health and its mission of developing, managing, and overseeing public behavioral health system for adults, children, and youth and their families become outdated? Over the years, I have collaborated with DBH, including the director, to understand how to improve the current system of care. Will the shift in responsibility provide resources and tools for families and youth to be used for the betterment of their lives? Research showed children, youth, and families do better when families heal together. I know from personal perspective how systems with their best intention can be devastating to families. My staff and I hear daily how parents want their children to be productive members of society, to have a future of dreaming past daily challenges of fear, pain, and loss of loved ones. We help families, one family at a time, as best as possible under the circumstances. TFC's greatest accomplishment with families is the ability to build trusting relationship without shaming and blaming them for not knowing what they should know, rather support them on using their voice to get what they need to be successful in the community. Furthermore, we are strong supporters of understanding system of care. Enhancement can take time. And we want to remind policy makers to include our voice when making system changes. In other words, nothing about us without us. Again, I encourage parents and youth to have a voice in the development, review, and the usefulness and accessibility of navigating the dashboard. Finally, I hope the creation of a children's mental health dashboard clearly states that the dashboard is created with the input of families and youth in the District of Columbia. Thank you for allowing me the opportunity to testify, and I am available to answer any question you may have.
Thank you. Thank you to this panel of witnesses for your testimony and your thoughts and feedbacks on this piece of legislation. I just have a couple of follow-up questions. So Ms. Kaslas, I wonder if either you or Mr. Miller you both work with folks who might be seeking care for their families, can talk a little bit about what the system looks like now. Because I feel like I've had this conversation with Department of Behavioral Health a number of times at hearings where they say, well, families can call and they can get a list. And then essentially, like, you have to call through the list yourself to determine whether or not there's availability, as opposed to here's a list of 5 places where we know has availability. It's better instead of going through 20. Can you talk a little bit about that?
Absolutely. I'll get started, and then Joshua, if you want to fill in anything about your experiences too. I'll just share a quote that one of our guardian ad litems, so our attorneys that are representing children in the child welfare system, shared with me as we were assessing this, which I think kind of exemplifies what you're getting at, Councilmember Henderson. So the GAL has shared that tracking down the service can be an ordeal for my clients. Imagine a teen trying to wade through the bureaucracy in the midst of a major life upheaval to get services they may or may not want. The majority of our clients and caregivers start off by referring to DBH community service associates via the Access Helpline, and then they're getting told to go back to CFSA, and then they're being told to search through Medicaid. So I think, to your point, they're being told that they should go to this list, and then when they go to that list, it's like, oh, you should go reference this list, and then go reference this list and spend all day. We have investigators who help support our guardian ad litems. But they're spending sometimes their full day just calling places, trying to find an available bed or an appropriate service provider that is culturally competent to work with children that have foster care experience or are seeking certain type of treatment. So that is our current experience right now.
Mr. Miller?
So I would sort of echo all of that. I include a couple of anecdotes and footnotes in my testimony, but one instance that jumps out at me during the pandemic, I had a young woman who came to classes at Georgetown with going through a schizophrenic episode. She couldn't sort of articulate herself well. She was engaged. She had like glossolalia or word salad. She was clearly in distress and really was willing for the first time in a while to seek treatment. We ultimately tried to get her to K Street at DBH's clinic. It was too late. So she and her caregiver had to come back the next day. And the whole process was sort of asking this person who's having trouble sort of making sense of the world and making sense to other people to navigate sort of very difficult bureaucracies. And I think ultimately the state of services in that moment led to her no longer being able to participate. That's the kind of thing that we see a lot. I mean, I have, other instances where somebody's getting bounced back and forth between agencies and nonprofits who are saying, go down the street because you sound like you might be bisexual. And then the other group is saying, well, we don't have a referral, so we can't take you. Things like that I think are really problematic. And I think that we're like 50-60% of the way towards addressing all of that, and this dashboard will help a lot. I do want to emphasize that the thing that I'm most excited about in this bill is that we start to get data about the gap, because there is a gap between the number of beds, providers that are needed and the demand. And what I'm really hoping that you'll do is that you'll put DC government in a position to know, like, we need 1,000 social workers, or we need like 300 psychiatrists, and we need to fill that demand somehow. Whereas now we just know the gap is great. We know wait times are increasing, but we don't know exactly how much.
Yeah, I mean, I think even just sort of putting a number on that, I can't tell you it will never be 100% accurate, because it doesn't capture the number of people who like just went to the website and then kind of gave up, if you will. And I kind of think of, I don't necessarily know what a perfect solution is, but I do know that, for instance, if I go to my health insurance, I have private insurance. If I go to my health insurance website and I'm looking for a new dentist, you're able to see like new dentist. You could do a filter for who's accepting patients. That's literally like the biggest one. Are you taking new people? Because if you're not, that's fine. But like, I don't want to call you, stay on hold for 5 to 10 minutes only for you to tell me that you're not accepting new patients. And then the other biggest one is like, do you accept my insurance? Those are like the two biggest questions that if we could like get those over the hurdle, I think that we could help a lot on those things. Mr. Membreno, I want to sort of bring you in on this conversation as well, because you mentioned in your testimony that real time might not come first, but we need to focus first on user-friendly. Can you say more about that?
Yeah, sure thing. So, you go to any DC government website, and I think we can all attest to this. You've got to click around a good few times before you get to the resource that you need. So making it even graphically accessible to folks, you can simplify it as much as the icons on an iPhone to know exactly what service is available and when is it available once you click on it. I think that will reduce, number one, turn away from when you log onto a website and try to access services, but then also it'll show you right up front what's accessible to me, what's not accessible to me, where can I find it? Is it coming to my home? Is it in the community? And so that kind of simplicity, I think, will also increase access for folks.
Okay. All right. Well, if we don't have a copy of your written statement, if you can certainly provide that for the record. Mr. Miller, it sounds like we need to check some of the footnotes of your statement. And that's usually the case with Ms. Caslas as well. So thank you again for your testimony and for being here. I'm going to call the last 3 public witnesses for this bill that I have, and then we'll turn to the next piece of legislation. So Eva Richardson, Rebecca Lindhurst, and Kristen Ewing from DC Appleseed. Give it just a minute. Again, if you are here, you need to affirmatively accept our invitation to become a panelist. And I see Ms. Richardson in the waiting room. Okay, there we go. All right, Ms. Richardson, when you're ready.
Good morning, Councilmember Henderson and members of the Committee on Health. My name is Eva Richardson, and I'm a staff attorney at Disability Rights DC at University Legal Services, the designated protection and advocacy program for people with disabilities in the District of Columbia. Pursuant to our federal mandate, DRDC represents hundreds of individual clients annually, with many more benefiting from the results of our investigations, litigation, outreach, education, and advocacy. DRDC appreciates the opportunity to submit this testimony regarding the proposed Child Behavioral Health Services Dashboard Act of 2024. a publicly available online directory containing information about currently available behavioral health services and screening and treatment services would certainly be a beneficial addition to the district's youth behavioral health system. More transparent and up-to-date information about the services that are available, the capacities of different providers, and other important features of providers will hopefully allow youth and their families to make more informed decisions when getting connected to behavioral health services. However, the proposed bill raises some concerns when placed in the context of the district's struggles to provide effective and responsive behavioral health services. In my testimony today, I will be focusing on existing issues youth face when getting connected to behavioral health services and how they relate to the proposed dashboard. My written testimony also includes questions about what information the dashboard will track and how that information will be generated and maintained. Many youth and their families struggle to access behavioral health services in DC. When new to the system, they frequently lack sufficient information about selecting a core service agency or other provider, even when leaving institutional placements, in which case the placement is required to ensure that the individual is connected to services upon discharge. People too often receive delayed or inadequate services to follow up due to inadequate discharge planning. As DRDC has seen with our clients as well, it can take weeks and even months to get first appointments with providers and even longer to start receiving treatment services. Compounding these difficulties are significant changes in how the district has been getting individuals connected to behavioral health services. Until recent changes, the Access Helpline was a 24-hour 7-day-a-week telephone number through which district residents could get connected to services provided by the Department of Behavioral Health. Callers could speak with behavioral health professionals who could make referrals to emergency psychiatric care or provide callers with information about ongoing mental and behavioral health services, which providers had availability, and how to actually get connected and help with that process. Last year, DRDC learned that DBH had started encouraging individuals seeking services to reach out directly to providers on their own with the aim of dedicating Access Helpline to crisis response. For now, people who call Access Helpline looking for assistance with selecting and enrolling in a provider or transferring to a new provider or navigating the system more generally are instructed to leave a voicemail and they'll get a call back. While the proposed dashboard would certainly provide some useful information to help families select a provider, many families require far more support navigating the behavioral health system. Though the Access Helpline has had its own challenges in the past, it provided direct assistance with getting connected to services at all hours. It is deeply concerning to DRDC that DBH intends to get rid of this assistance and instead rely on individuals reaching out to providers, as has been discussed. DBH is still allowing people to leave voicemails with the Access Helpline for now, but this does not provide the same kind of support that was once available, and DBH has indicated that it eventually intends to get rid of this option. DRDC urges the council to work with DBH to ensure that families are given more than just a list of providers, the services offered, and whether they have availability. The proposed dashboard has the potential to be a valuable tool for children, families, and advocates navigating the system. But in order for this to happen, the district must provide more personalized support and guidance for children and families and make it clear on the dashboard itself, the website, how to access that support. Thank you again for this opportunity to testify today.
Thank you, Ms. Richardson. I don't see Rebecca, but I do see Kristen.
Good morning, Chairperson Henderson and staff. Thank you for the opportunity to testify on the Child Behavioral Health Services Dashboard Act of 2024. My name is Kristen Ewing, and I am Policy Counsel at the DC Appleseed Center for Law and Justice. My testimony today will outline our support for this bill and provide several suggestions we believe will improve the bill and the dashboard. We have long known that parents, caregivers, and families struggle to access crucial behavioral health care for district youth. Navigating health insurance policies and provider databases can take copious amounts of time and patience. Only some have this capacity due to daily and ongoing responsibilities and obligations, and language and technology barriers, as well as network adequacy issues, can make these challenges insurmountable. DC Appleseed applauds Councilmember Parker and the 6 co-introducers and sponsors for introducing this bill. We know that providing a single database to access accurate and up-to-date care and treatment options will allow more district youth to receive care and receive it in a timely fashion. We also appreciate the bill requires collaboration among all of the related district agencies. Meeting the behavioral health needs of our youth will require breaking down silos and working across agencies, providers, and nonprofits to improve efficiency, efficacy, and outcomes. However, we want to ensure that creating this database is not the finish line for providing adequate care, but instead the starting line as the district continues to improve the quality, ease of access, and affordability of behavioral health care for our children. This database will offer more accessible real-time information to youth, families, and caregivers, but it will not fix underlying infrastructure issues in our behavioral health care system. However, this dashboard could be leveraged to provide critical data about gaps and weaknesses in our system, including provider wait time, capacity, location issues, insurance coverage, and parity issues, cost, or other service gaps. With this in mind, we would like to put forth 5 suggestions to strengthen this bill. First, ensure school-based behavioral health program information is provided. As members of the Strengthening Families Through Behavioral Health Coalition and strong supporters of school-based behavioral health, we want to ensure that school-based providers are included on the dashboard. We know meeting youth and families within their communities is a great starting point for providing behavioral health care, and the school is a great place to make this initial connection. This information may be contemplated in the proposed bill, which requires several agencies, including DBH, to provide links to behavioral health services they currently offer. Still, we want to ensure this information is explicitly required since community-based organizations and not DBH mainly provide this care. Second, we want to include more community members in development and implementation. Section 4 of the proposed bill requires the Deputy Mayor of Health and Human Services to consult with several entities to inform the website creation and support continued implementation. This list includes several health agencies and associations, as well as explicitly community members and advocates with current or past experience navigating health services in the district. We propose also adding community members with no current or past experience navigating health services. If we truly want this dashboard to be accessible to all, it should be user-friendly to even the most novice users of technology and health services. Third, ensure easily accessible feedback options. We want to ensure the bill requires robust user feedback options. A novice user should easily be able to provide feedback on all aspects of the dashboard, from technology and ease of access to inaccurate information or gaps in care or providers. Fourth, require data collection and reporting. We encourage the addition of data collection and public reporting requirements to this bill. Information should be collected across numerous data points, including which types of services are being searched for, and if there are any providers or adequate providers for these services, average wait times, where available services are located, where searchers reside in the district, which services are covered by health insurance, and which insurers are providing a robust network of providers. This data can be utilized to identify gaps and barriers to care and provide resources to ensure all district youth can access quality, affordable, accessible, timely, and holistic behavioral health care. To ensure this data is collected and utilized effectively and efficiently, the bill should name the agency or agencies responsible for collecting, interpreting, and reporting this data, and delineate when and how it should be reported. Last, we want to ensure a comprehensive rollout and education campaign. Even the most robust, comprehensive, and user-friendly dashboard will only increase behavioral healthcare access and utilization if families, caregivers, parents, and youth are aware of its existence. To ensure a well-planned and effective dashboard rollout, the bill should explicitly require an education campaign and designate an agency to handle it. This campaign should be far-reaching to ensure parents, caregivers, family, and youth, and all entities and agencies supporting them know of this tool. Thank you for your time, and I'm happy to answer any questions you may have.
Thank you so much, again, to both of you for testifying and for your ongoing partnership and work with us on these important issues. I just have a couple of follow-up questions. Ms. Richardson, can you say more about what you've heard about the changes to the Access Helpline? My understanding from DBH is that it would function as always. Hadn't heard about this message system that you referred to. Can you say more?
Yeah, this is based on our understandings gathered from public forums for stakeholders and our experiences calling the helpline over the past several months as well. But my understanding is that it was there were changes being implemented gearing up for the transition to managed care as part of the gap period prior to that transition happening, with the intent of dedicating Access Helpline to crisis response instead of its traditional role of being a 24/7 service for people getting connected to services and navigating what services are available and all of that. And then there was a period of time when it was serving both that role and then allowing individuals calling to leave a voicemail they called it the Access Helpline Administrative Line. And I go into more detail about this in my written testimony as well. But where they could leave a voicemail with their information and receive a call back to go over services and get that assistance that was used to be available directly. And so that was set to expire at the expiration of the gap period protocols in anticipation of the integration. But when that got paused, it's our understanding is that that option to leave a voicemail has been prolonged, but it's unclear for how long and to the extent to which that'll continue to be available. So it's been in flux.
Okay, that's helpful. You also talked a little bit about wanting families to have more than a list and advocating for some personalized support. What do you envision that looking like?
I mean, we envision it looking like what Access Helpline used to provide for families. So some sort of one-stop phone number available around the clock at all times that was, easy to disseminate and get on people's radar, to call and get that support directly one-on-one, and somehow integrating that with this dashboard, or just making sure that that is still an option in conjunction with this information provided by the dashboard, so that it's not put on families to make these calls as has been discussed, go down the list of providers and make calls and get turned away, or encounter barriers, and that can be quite difficult to navigate. So
for Ms. Ewing, how have you all been providing feedback to DBH regarding some of the concerns that you raised with regard to accessibility?
I don't think we've directly raised these with the current system. These are things that we're looking forward, with the website. I do think we see a lot of the same issues, with, like has been mentioned before, you call, you get a list. You're not provided support. Maybe it's not in the right language. Maybe you have technology barriers trying to go on and search for these, look for the location. So I think a lot of the same issues exist, but we have not explicitly been communicating those with DBH.
Okay. All right. I think from, the witness is very clear, just in general, and I've had this conversation with Octo, right? Need a complete overhaul of the DC government websites. Some agencies have sort of taken on their own reins and, have updated and changed. But I think, as someone mentioned before, they're not really user-friendly. But as we also move towards the website redesign process, we've been asking Octo and the agencies to ensure that they're doing actual user testing, using actual regular people to see if they can navigate the sites to find what they're looking for. So we'll ask some follow-up questions about that, but I don't have any other further questions for you all today. If you haven't uploaded your testimony, please do so, and we'll certainly follow up if we need more. So thank you guys so much. We're going to go to the next panel, which is on the Enhancing Mental Health Crisis Support and Hospital Amendment Act of 2024. I have, again, I'm going to do a panel of 7. Emily Bell, Sasha Williams, Jacqueline Werner from Disability Rights DC, Kimberly Walker from the Office of DC Long-Term Care Ombudsman, Mary Fisher, Shannon Walsh, Pathways to Housing, and Lori Davis. I'll give it a minute. Again, if you're joining us, please make sure that you have to affirmatively accept our invitation to become a panelist. Okay. Got some folks coming in. I see Lori Davis in the witness room. Okay. I see Miss Bell. Miss Bell, why don't you go ahead and get started?
Good morning, Honorable Chairperson Henderson and distinguished council members of the Committee on Health. My name is Emily Bell. I've been a registered nurse for 19 years and a psychiatric mental health nurse practitioner, or PMHNP, for 15 years. I've experienced in outpatient clinics, inpatient units, integrated psychiatry and primary care, psychiatry consultation within emergency departments, caring for patients across the lifespan. While practicing in Florida, I was honored to be a part of the Florida Coalition of Advanced Practice Nurses, serving as their subject matter expert on PMHNPs when the state updated its Mental Health Act, as well as when the Nurse Practice Act was changed to allow nurse practitioners to prescribe controlled substances. I was recently working in a DC hospital providing psychiatric consultation in an emergency department and came to better understand local mental health laws. When starting this position, I was shocked to learn that PMHNPs had no ability to initiate a psychiatric emergency examination despite having full practice authority. This missing signature authority is having dire consequences, negatively impacting access to care during mental health crises for residents of this great city. There is a critical shortage of behavioral health providers that is projected to become significantly worse over the next 12 years, including for both psychiatry and psychology. Moreover, DC has been designated as a mental health care professional shortage area by HRSA. According to the American Nurses Credentialing Center, the number of PMHNPs has more than doubled in the last decade. But for this missing signature authority within the Mental Health Act, the Code of the District of Columbia states an advanced practice registered nurse, or APRN, can perform the following authorized action. They may sign all documents that require a signature of a physician in place of a physician, provided it's within the scope of their authorized practice. Emergency psychiatric evaluations are within the scope of practice for PMHNPs, but it is not within the scope of practice of other APRNs. We're specifically trained to perform emergency psychiatric evaluations during graduate education. So why not use these highly qualified providers to provide to their full scope of practice within a critical shortage area? Removing this arbitrary barrier inhibiting a significant pool of providers would increase access to care and relieve a major choke point in the Washington, D.C. healthcare system that results in patients often waiting days to receive psychiatric treatment. The lack of access to psychiatric services is considered an outlier within hospital emergency departments, averaging up to 23 hours to determine a patient's next steps for care. Their excessive wait times reduce access to the emergency department for more acute medical presentations and lead to poor outcomes for psychiatric patients. I recommend this committee amend the Mental Health Act by including psychiatric mental health nurse practitioners as qualified nurse practitioners alongside physicians and qualified psychologists as providers able to initiate emergency psychiatric examination by signing an FT form petition when an individual presents themselves with complaints of imminent danger to self or others due to mental illness within Washington, D.C. In summation, a relatively minute adjustment to existing verbiage can have a dramatic impact for the residents of D.C. that are in need. I have submitted a more thorough, detailed written testimony for the committee's review and urge the committee to amend the statute without delay. Thank you for this opportunity to testify on this important and pressing issue.
Thank you so much, Ms. Mel. I don't see Ms. Williams, but I do see Jacqueline.
Good morning, Chairperson Henderson and committee members. Thank you for this opportunity to testify on the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. My name is Jacqueline Werner, and I am a supervising attorney at Disability Rights DC at University Legal Services, the designated protection and advocacy program for people with disabilities in DC. I am also a Ward 6 resident. DRDC has serious concerns about this bill. While we appreciate this committee's work to attempt to address significant issues with the district's behavioral health system, we do not agree that many of these amendments will result in DC residents receiving better access to quality treatment. Instead, many of these changes will likely do nothing more than cause individuals to be involuntarily detained for a longer period of time than necessary with little to no supportive treatment, will subject individuals with disabilities to an increased likelihood of abuse and neglect, and will most greatly negatively impact low-income Black and Brown residents living with disabilities. DRDC does not support the proposed amendments that would criminalize persons with disabilities by allowing the issuance of arrest warrants. We discussed this in more detail in our written testimony. The remainder of my testimony today focuses on the proposal to extend the emergency observation period. Extending the detention time for emergency observation is inherently harmful and will have devastating consequences for district residents living with disabilities. This bill proposes to extend the emergency detention period from 7 to 15 days. In addition, this bill proposes to extend the time frame during which a probable cause hearing must be held. Overall, these changes together could result in an individual being detained for at least 21 days without having the ability to challenge this involuntary detention at a probable cause hearing. First, this implicates serious constitutional due process and liberty interest concerns, and these proposed changes are not in line with the historical intent of this act. Second, this change to the law is unnecessary in that the law actually already allows for the extension of the detention time for further observation and diagnosis. Third, and with great emphasis, there is a total lack of data that supports that forced treatment is effective. The publicly available data simply does not support that the district should be increasing the length of time of forced treatment, and instead the district should be focusing on investing in and creating better quality, accessible, voluntary, community-based treatment options that people want to seek for assistance. Through our clients' experiences and our observations when we monitor facilities, we know that individuals in crisis receive little to no treatment and programming while admitted to acute inpatient psychiatric units. If the district fails to improve discharge planning services, community-based behavioral health services, and fails to provide adequate housing support to individuals living with mental illness, extending this period will likely do nothing more than cause people to sit in the hospital for longer, continuing to not receive the help that they need. What's more, interaction with forced treatment often discourages people from wanting to voluntarily seek treatment in the future. Most individuals who are involuntarily admitted in the district are admitted to the Psychiatric Institute of Washington. Not only do many people complain about the lack of meaningful therapeutic treatment at PIW, but individuals admitted there are not safe. DRDC has placed the district on notice for years about the conditions inside of PIW. In our third report in 3 years, which we just released yesterday, DRDC found evidence of continued staff abuse and neglect, including sexual assaults, assaults resulting in fractures and other serious injuries, staff neglect, and over-reliance on seclusion and restraint. In addition to the serious harms and re-traumatization described above, there are also other collateral consequences to involuntary inpatient treatment, including negative impacts on employment, housing stability, and parental rights. Finally, but not less importantly, the council must consider that given all of the above, these changes will be most likely to negatively impact low-income Black, Indigenous, and other people of color living with disabilities. The priorities of the providers, attorneys, and non-local advocates with whom the council consulted when drafting this bill, who are all in positions of power, should not be placed above the perspectives of those DC residents whom these changes will most directly impact. The district is obligated to serve individuals with disabilities in the most integrated setting in accordance with the Americans with Disabilities Act integration mandate. In Olmstead v. LC, the U.S. Supreme Court held that states have an affirmative obligation to provide services to persons with disabilities in the most integrated setting appropriate to their needs, and that a state's failure to do so constitutes discrimination. Forced inpatient treatment in lieu of adequate access to voluntary community-based services is not in line with Olmstead and the ADA's integration mandate. The concern that individuals in need of behavioral health support need more time to receive forced treatment is reflective of failures in DBH's current system of care. Our written testimony goes into details about the ways in which CSAs and ACT providers are continuing to fail to provide quality and appropriate community-based services. Furthermore, the district and providers are failing to adequately address the housing needs of individuals with disabilities. Our written testimony goes into detail about this as well. Rather than focusing on involuntarily detaining consumers for a longer period of time, the council should instead place increased focus on investing in community-based services, affordable housing, and holding DBH, DHCF, and behavioral health providers accountable to their obligations under the law. Thank you again for this opportunity to testify, and I welcome any questions.
Thank you. I don't see Kimberly Walker. I see her in the witness room. Ms. Walker, if you can accept our invitation and become a panelist, we can promote you so you can provide your testimony. I'll go on to the Mary Fisher. I don't see Ms. Fisher. I do see Shannon Walsh. Shannon?
Chair Henderson, council members, and council staff. My name is Shannon Walsh. I'm a Ward 8 resident, a licensed independent clinical social worker, and the clinical director of the Court Urgent Care Clinic. The Court Urgent Care Clinic is a partnership between DC Superior Court, the DC Department of Behavioral Health, and Pathways to Housing DC. The Court Urgent Care Clinic provides same-day mental health and substance use assessments and treatment connection to individuals regardless of insurance regardless of insurance, DC residency, ID, legal status in the country, or involvement in the court system. Our office often works with clients who have recently been released from St. Elizabeth's after being restored to competency that need to be connected to long-term mental health treatment. We have found that these clients have not always been connected to long-term mental health providers, or if they have, the clients are unaware of that connection. Our clients would benefit from the option of remaining in voluntary hospitalization until appropriate care can be found for them. This would allow continuity of care and likely cut down on emergency and homeless services and rearrests. It is also important to acknowledge the shortage of mental health providers, not only in DC, but throughout our country. Psychiatric nurse practitioners are specially trained medical professionals who can provide medication, diagnoses, and have a deep understanding of mental illness. Allowing psychiatric nurse practitioners to complete FD-12 assessments can assist in immediate care being rendered to our most vulnerable neighbors. I thank you, Chair Henderson, for conducting this hearing and for passing the fiscal year 25 budget with funding for the Court Urgent Care Clinic. I am available to answer any questions that you may have.
Thank you so much. Ms. Davis.
Sorry. Good morning. My name is Lori Davis. I've been a resident of DC since 1976. I'm also an attorney who worked in the mental health law field for over 3 decades as general counsel to the now Department of Behavioral Health and at the DC Public Defender Service, representing well over 7,500 individuals subject to civil commitment proceedings. As general counsel, I drafted amendments to the district civil commitment law, commonly referred to as the Irvin Act, to modernize it in 2002. I also drafted the district law on competence to proceed in criminal cases, enacted in 2005. I understand the system from both sides, and I appreciate the opportunity to share my views on B25-0692, which would amend both of these laws. According to a recent newspaper article, this bill was introduced in response to an especially troubling incident that occurred in the district last year. However, the law was not the problem. Perhaps the focus should instead be on the service providers who made decisions not to use the law to ensure treatment was provided in a timely manner. In short, I oppose 3 major components of the bill: proposed modifications of the timetable related to emergency involuntary hospitalization, proposed use of warrants in civil commitment cases, and the proposed requirement that a competence evaluation order require a minimum hospital stay. Because of time limitations, I ask the committee and council members to review my written statement, which explains more fully why I oppose this bill. I was appointed as the first general counsel of the DC Department of Mental Health, now known as DBH, when it was established in 2001, and my top priority was to modernize the Irvin Act. Before drafting a word, I immersed myself in the legislative history of that, conducted a survey of every state's civil commitment laws, and sought input from a wide variety of stakeholders. The result was the Mental Health Civil Commitment Act of 2002. At no point in the process of re-examining the Irvin Act was there thought to be a need to alter the timetable for emergency involuntary detention, notwithstanding episodic news reports over the years about people with mental illness falling through the cracks in the district's mental health system and on occasion committing a crime that might not have occurred if treatment had been provided in a timely manner. Nor was there any suggestion in 2002 that warrants should be used at any time to enforce court-ordered treatment and civil commitment. The provisions in the legislation being considered today that would make those changes are antithetical to the goals of the Irvin Act and are unnecessary. To understand why the proposed changes are unnecessary, it also helps to understand how the statute actually works. The Irvin Act easily allows for the emergency involuntary detention of a person for months or more. The proposal in this bill that would allow an initial detention based on untested allegations and a paper review for 15 days instead of the current 7 days is not necessary and is not consistent with due process, nor is delaying a respondent's access to a court hearing. Going from a hearing within 24 hours of a request to one that could happen 3 to 5 days later compromises the constitutional rights of a person involuntarily hospitalized and does so for no apparent reason. In my experience, clinicians have ample time and opportunity to evaluate an emergency involuntary patient under the existing timetable, as well as time to start treatment, which is required to be provided under the current provisions of the Irvin Act. This view was shared by stakeholders who weighed in on the Urban Act amendments in 2002. The law should not be modified for the convenience or preferences of hospital staff or doctors who might appreciate not having to rearrange their schedules to attend a hearing on 24-hour notice. Pressure on clinicians today are not really any different from those in 2002 or even in 1964 when the Urban Act became law. The number of civil commitment cases has fluctuated over the years, and the law need not be changed as a result of a year or two of increased emergency involuntary hospitalizations. The other major flaw with the proposed changes to the Urban Act centers on the use of warrants in mental health cases. These are civil cases, and the individuals receiving court-ordered treatment pursuant to the Urban Act are not criminals. The use of warrants would be a first step toward criminalizing mental illness. Moreover, warrants as used in criminal cases often lead to the detention of individuals in jail or cell block settings, and respondents in mental health cases may not be so detained, according to the law. The Urban Act framers anticipated the need to hospitalize a person involuntarily without the use of warrants at every stage of the commitment proceeding, and the 2002 amendments expanded on this. I've detailed these in my written testimony. The last of my criticisms of the bill being considered today is the amendment proposed to the Incompetent Defendants Criminal Commitment Act of 2004. Please see my statement for written details, or see my written statement for details why I oppose this. Thank you for allowing me to testify and to submit a written statement. I would like the opportunity to amend my written statement in response to the written statements that I saw submitted today from the Department of Behavioral Health and the Office of the Attorney General. I urge the committee and all members of the council to vote against passage of this bill as it is written. Most of the provisions in this bill would not enhance mental health crisis support. Instead, this legislation would harm individuals who are being deprived of their liberty as emergency involuntary psychiatric patients. Thank you.
Thank you. I do see Ms. Walker now. Ms. Walker?
Greetings, Chairperson Henderson and members of the Committee on Health. I am Kimberly Walker, Long-Term Care Ombudsman Specialist with Legal Counsel for the Elderly. Thank you for the opportunity to provide this testimony on behalf of approximately 9,000 DC residents receiving long-term care services and supports in nursing homes, assisted living residences, community resident facilities, and in their homes through DC Elderly and Persons with Physical Disabilities Waiver. As an advocate and resource, our mission is to educate and empower individuals to be self-advocates and to exercise their rights for quality of care. I ask that my written testimony be included in the record. I am here today to focus on the following 3 important points. First, the need for more qualified healthcare professionals, specifically to initiate the application for emergency hospitalization. Sometimes core service agencies are not able to initiate this process in a timely manner for MHCRF residents due to their own staffing concerns, which results in their authorized staff being occupied with an assigned caseload and other unexpected crises that requires their immediate attention. So more authorized professionals will help decrease long response times to crisis situations, allow the authorized professional to see the person while they are experiencing a mental health crisis, and help to meet the person where they are in the community to initiate the application for emergency hospitalization. Next, the need for extending the time for emergency care is needed to ensure medical/medication stabilization. Currently, residents are being hospitalized on an FD12 to CPAP and are being released back into the community within 72 hours, or are sometimes being sent to PIW. There is often a lack of continuity of care coordination during this process. As a result, the residential providers, case managers, guardians, and sometimes DBH are unaware of what treatment the resident received as CPAP or cannot reach clinicians at PIW for updates on treatment being provided. In addition, residents have been discharged from the hospital with no discharge meeting and have returned to their MHCRF without the residential provider being notified of discharge instructions. An extension for emergency care will allow more time for residents' treatment and better care coordination amongst the residents' treatment team. Providing quality of care should be the focus, so the resident has more time to stabilize and the treatment team has more time to coordinate and ensure appropriate supports are in place upon discharge back into the community. And last, doctors need to have the ability to make involuntary admissions. We advocate for the rights of residents to receive appropriate care and supports to be able to live independently and with dignity in the community. We believe these supports should include the doctor's ability to make involuntary admissions when appropriate which would be helpful for those residents who need more stabilization regarding medication management or psychiatric intervention. In addition, this will allow more time for the residents' treatment team to coordinate community supports to prevent homelessness and reduce the risk of harm to themselves or others. Representatives from the Office of the DC Long-Term Care Ombudsman meet and communicate regularly with DBH to work on individual cases and systemic issues. We welcome this continuing collaboration to ensure quality of care and quality of life for all MHCRF residents. Thank you for this opportunity to testify.
Thank you. And thank you to this panel of witnesses. I do have some follow-up questions. Ms. Bell, you centered your testimony around psychiatric mental health nurse practitioners being able to initiate these evaluations. In your experience, this is the case in other jurisdictions, yes?
Yes, ma'am. Within the state of Florida, where I worked previously before moving back to the DC metro area, psychiatric nurses were one of the mental health providers that did allow for the specialists within the APRNs to initiate the involuntary examination or the emergency psychiatric evaluation. Recent review of statutes indicate that approximately 10 or 11 other states outside the District of Columbia have implemented this within their statute, recognizing a nursing professional, whether it was a signature of a registered nurse or an advanced practice nurse being either a clinical nurse specialist within psychiatry or a nurse practitioner specializing in psychiatry.
Okay. I'm sort of smiling a little bit because we just finished this ongoing conversation about APRNs. Not a conversation, it was like a debate, where frankly, the Medical Society of DC didn't want to see any expanded scope of practice for any APRNs, which is kind of general, I guess, in sort of the division between nurse and versus doctor. But I don't actually see any of them who've testified here, so we'll follow up with them on that particular point. Ms. Werner, thank you so much for your testimony. And I just want to give you an opportunity to clarify, because this is what I'm hearing from you, is that Universal Legal Services or Disability Rights DC at Universal Legal Services doesn't think that any involuntary treatment can be effective. That's what I heard. Is that what you meant?
So my internet connection is not great right now. I'm here. I think I heard you ask that our office, Disability Rights DC, thinks that no inpatient ever. What you?
Oh, hold on. You broke up.
Let me video off. Let me see if this helps.
Okay.
Did this help?
You got to say something so we can see if we can hear you.
Is this helping?
No, it did not. Okay. So I'll come back to you. Okay. Ms. Davis, thanks so much for your testimony. I pulled it up. If you could label which version when you submit the next version. There's a lot there, 13 pages for those who haven't taken a look. And there's a lot of interesting things there. And I think you have a wealth of information, particularly a history and sort of background on some of these things. And so I want to ask a couple of questions as I sort of took a look. So first off, in terms of the timeline, it seems as though you're suggesting that the timeline that exists or the timeline that's in place allows for hospitals to request the extended time, but they just aren't doing so.
The way the law works is someone is held for 48 hours on an application without any court review. Then if the hospital wants to hold the person longer, they have to file paper in court. A judge has 24 hours to review that. And then the judge authorized extended hold for 7 days. If any of those times or any other deadlines throughout the statute end on a holiday or a weekend, the time is extended to the following day. So right off the bat, most hospitals have authority to hold someone for 10 days. If the Department of Behavioral Health or a hospital chooses not to petition for a 7-day order, even though they think the person has a mental illness, and might be a danger to self or others, I can't explain why they would make that decision. Clearly, they're not making that decision often if they're filing over 2,500 cases a year. Those cases, the judges in at least 95 to 99% of the cases grant the extended 7-day hold. What the department is asked, or what the legislation today proposes, is changing that from 7 to 15 days. I submit that is unnecessary, because if a hospital wants to hold a person beyond that initial 10-day period, which might be actually longer, they just have to file another piece of paper in court called the petition for commitment. And my understanding is the Department of Behavioral Health actually, with the OAG, files those petitions for private hospitals. All the private hospital has to do is submit a brief certificate from a doctor, which they submit, I believe, to the department either by fax or electronically. I'm not sure how it's done now. It was by fax in my era. And it's less than a paragraph on which the doctor says, this person continues to exhibit signs of mental illness and I believe needs ongoing treatment to prevent him or herself from being a danger to self or others. That paper triggers continued detention automatically. Nothing more needs to be done by the hospital. And that detention will last for at least 21 more days. That detention lasts until the court schedules a hearing before the Commission on Mental Health. That hearing is usually at about the 21-day mark, assuming that the government and the respondent, the patient, don't push off that hearing, which happens quite frequently, where they'll put it off for another 3 or 4 weeks, during which time the person remains hospitalized. It is not at all uncommon for that hearing to be delayed by 1 or 2 months. So now we're looking at the potential to hold someone in the hospital and provide treatment, not just for 10 days or 21 days, but really for months. If the Mental Health Commission conducts a hearing and says a person needs to remain inpatient, the detention continues. So to say that the hospitals have to release people before they can start treatment, I submit is wrong. It's just false. Treatment begins when someone is admitted on an application. The statute explicitly requires treatment to begin when someone is admitted to make medical and physical treatment.
The tension, I guess, is that you're saying hospitals have more than enough time. And then I have hospitals who are saying we don't have enough time. And so I'm trying to, as the policymakers, we're trying to figure out these pieces here. And so let me ask you this. If not the timeline, then where's the breakdown in the system? Or do you believe there is a breakdown in the system?
I do believe there is a breakdown in the system.
Okay.
I do think they have the time. Someone's being held for 48 hours and another 24, then another 7. If they haven't been evaluated by a doctor, there's something amiss, but they have to be evaluated by a doctor. It's required by the law. And in fact, they are evaluated. And in every one of the cases I was ever involved in, by the time I got to see the client, which would have been on day 4, 5, or 6, after the court had signed the 7-day order, every one of my clients was being treated. They were being medicated. That's the primary form of treatment. They maybe were participating in some discharge planning or some groups on a ward, but they were being treated, and most of the time it was with medication. The doctors, the clinician, the social workers, others did have time to evaluate them. Where I think it's breaking down is a lack of bed space and a lack of professionals within the institutions to provide as much care as they might, or to spend as much time as they might prefer to spend. There's no question, even 20 some years ago, and even before that, the doctors felt rushed. and wards were crowded then and wards are crowded now. I don't think the problem is in the timetable. I also would note, and I think one of the other witnesses talked about this, the disconnect between inpatient treatment and outpatient treatment and planning for outpatient treatment. That has been a long-standing issue in the District of Columbia. It is what gave rise to a federal lawsuit called the Dixon case that started in, I believe, the 70s, when the inpatient was run by the federal government and the outpatient was run by the district government. When those two systems merged in the 80s, unfortunately, the disconnect continued. To come out of the federal court receivership in that case, the Dixon case, that's why the Department of Behavioral Health, or then Mental Health, was created. I don't know that the department, to be honest, has ever been successful in fixing the conversation or communication problems between inpatient and outpatient. I don't know that the outpatient programs have been adequately staffed or funded. And I think housing, someone mentioned housing is one component. I think that has been a constant challenge for the District of Columbia. It was a challenge in 2001 when I was at DMH, and I am sure it's even more of a challenge today, having seen the changes in the District of Columbia. I'm also, just so council members, so you understand, I'm very involved with an organization called the Washington Legal Clinic for the Homeless, and I'm very up to date on homeless services. So I know that there are overlaps between some people who are experiencing homeless in DC and having mental health issues. It is certainly not all of them. But I think, again, housing is at a premium. It's a real challenge. It's a challenge for people with mental illness. And the communication between inpatient and outpatient is often broken, as are the inadequate services. I don't think the problem is in the inpatient detention provisions or the inpatient hospitalization, because most people are put on medication, they are stabilized relatively quickly, and then it's a matter of where are they going to go? And that's a problem that's not solved by changing the statute and extending emergency detention from 7 to 15 days, because really the hospital could hold the person beyond 15 days with a simple piece of paper. So,
Ms. Davis, we're going to follow up with you when you send us your new testimony.
I just want to respond to some of the remarks that I saw in written testimony. So,
okay. But you did bring up something I think that Ms. Walker brought up around need for better care coordination on the discharge part. Ms. Walker, if you're still with us, and I know I've gone over my time, but I'm chairing this hearing, and I think this is important for us to get on the record. So I'm going to keep going. Ms. Walker, can you talk a little bit about that in terms of, I mean, I would say that's probably one of the second largest complaints that we get is around discharge and lack of coordination, or I'm being discharged and I'm not being connected with a provider. I may be handed a list of people that I have to call through and figure that out, or work through those issues. You want to say more about that?
Well, yes, specifically for our MHCRF residents, care coordination is so critical when they're being released from a hospital. We've had complaints in our office regarding residents being released from a hospital and they're going without their medications for like months, weeks and months at a time. And then they start spiraling and start going into a mental health crisis because they're not getting their meds, or they're not being connected with community resources that they need to get connected to. So we are concerned about that, because all of the case managers, even DBH, need to be involved in care coordination. All parties need to be at the table. All parties need to be talking about what this individual needs. They need to be going over discharge instructions. They need to be updating treatment plans and making sure that those treatment plans are being implemented on behalf of the resident. And then follow-up needs to happen there. There needs to be some level of accountability there, because at the end of the day, the resident is the one that is kind of left out there and then we lose them in the city. If they're not on their medications, then they leave the group home, and then case managers are on the hunt with trying to find them. And then, you know, they may be able to see them in the community somewhere, but then they don't want to come back because they've now started participating in recreational drugs. So then we have to start back from point A and try to see if we can get them, get the case managers to get them into some type of rehab so they can get stabilized to get back into the community and be successful. So just bringing case managers to the table, appropriate clinicians to the table, DBH to the table, that's critical. We need all parties at the table to discuss the residents. And we need to make sure that those treatment plans are updated. Treatment plans need to be updated. The direct care staff need to be trained on those treatment plans, and they need to make sure that they are communicating with the case manager, and the case manager is taking the initiative to call a meeting to discuss, the best action, a plan of action, and including the resident also. I mean, oftentimes the resident is left out of the planning process. So we need to try to get back to some person-centered planning here to try to include the resident as much as possible. But I think that just trying to connect with the hospital's case management department, I believe that case managers are the responsible parties for initiating that. But the problem now that we're experiencing is that there's a high turnover in case management. So staff are coming and going. And so one case manager may be here one day, next week the resident has a totally different case manager, and they're not even being made aware of when they're getting new case managers. I've had residents who've called me about a concern. I'm like, have you talked to your case manager? And they're like, yeah. And they called the case manager and they said, I've called several times and I can't reach my case manager. And then I do my follow-up as the advocate. And then I find out, oh, you have a new case manager. I'm asking, how come no one let them know, So those are some of the issues that we're experiencing on our end.
Thank you, Ms. Walker. Ms. Walsh, you have your hand up. You wanted to jump in?
Yeah, I just want to echo what Ms. Walker is saying. We find this a lot in our clinic where we have clients who, whether they're being released from St. Elizabeth's, they've been released from a hospital. Like Ms. Walker said, our clients don't know what they've been diagnosed with. They don't know what medication they were prescribed. They didn't get their discharge paperwork. And so we kind of go in blind. And especially with our clients who have been released from St. Elizabeth's, it is not smart to just go ahead and start medicating someone who has already been found incompetent to stand trial when you know they're on some kind of psychiatric medication, but you don't know what. So we find it challenging to get in touch with St. Elizabeth's, get in touch with the jail, even when clients have been released from the jail with medication or have been released from St. Elizabeth's, then to the jail, and then out into the free world, where we just can't. That communication, the coordination of care is just really, really challenging. And what we end up doing is just kind of waiting until we can get a response from somebody, whether that's with our partners at CSOSA or pretrial who have access or who have more availability to have access to those places. So that's just something.
Are they just not responsive, or are they responsive and say, we can't share that information with you? Because those are two different things.
Not responsive.
Okay,
so we can get clients to sign releases of information, but the contact information that we have isn't always effective or efficient.
Okay. All right. Ms. Davis.
I just want to note that the problems that the other two witnesses described about turnover, discharge without medication have been problems that have existed in the District of Columbia for quite a long time. And that without an individual having an advocate who really can help them navigate the system and push to make sure when they're discharged that they're actually given enough medications to tide them over until their first outpatient appointment, that's a problem that's not going to be solved by changing any timetables. It might be a problem that the Department of Behavioral Health needs to really have a hard look at its processes and its monitoring of these connections between in and outpatient.
Okay. All right. Well, thank you so much to this group of witnesses. We'll certainly follow up with you all. We're going to go on to the next panel and then try to get to the government witnesses just for the timetable. We have another meeting after this at 3 o'clock. So I'm trying to push myself here for us to stay on time. But if you haven't submitted your written testimony for the record, if you can please do so, that will be great. Okay. Adelaide Robb, who's the Chief of Psychiatry and Behavioral Sciences at Children's National. Justin Palmer from DC Hospital Association. Joshua Drumming from Washington Legal Clinic for the Homeless. Corinne Mayer. Yavar Mogimi from Amera Health Caritas. Shannon Lott from PIW. And we'll stop there. And then we'll have one more panel after this. Oh, and I just want to acknowledge we've been joined by Councilmember Zachary Parker from Ward 5, who is a member of the committee. All right. Ms. Robb, when you're ready.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Adelaide Robb, and I'm the Chief of Psychiatry and Behavioral Sciences at Children's National. We have been serving the nation's capital since 1870, and we're proud to be named among the top 5 children's hospitals by U.S. News and World Report. Thank you for the opportunity to provide testimony in support of B25-0692, Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. Children's National has a longstanding commitment to strengthening the behavioral health system for children and adolescents in the District of Columbia. Our Division of Psychiatry and Behavioral Sciences provides specialized care for children and teens with behavioral health symptoms and emotional and developmental disorders. As the head of the Division of Psychiatry and Behavioral Sciences, I lead a robust team of child and adolescent psychiatrists, physicians who treat a variety of psychiatric conditions, including depression, anxiety, ADHD, eating disorders, substance use disorders, and psychotic illnesses. While many of these children and teens can be treated in an outpatient setting, some are evaluated in our emergency room when they are having a mental health crisis. And some of these children require admission to an inpatient psychiatric unit to provide adequate treatment and stabilization. In many cases, the children in our emergency department with psychiatric emergencies have a guardian available to consent to necessary care. However, in cases where children experiencing psychiatric emergencies do not have an available guardian to consent, Children's National works with the Child and Adolescent Mobile Psychiatric Services, or CHAMPS, to have them assess the patient for risk of harm to self or others, requiring inpatient psychiatric stabilization. We strongly support the B25-0692 Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024 because in cases of acute psychiatric emergencies, time is of the essence. Unlike adults, children and adolescents often lack legal provisions for involuntary commitments, leaving them vulnerable when they are in acute psychiatric distress. We see patients in our emergency department who could benefit from admission to our adolescent psychiatry or child psychiatry units. If members of our Children's National team could complete the assessment for involuntary admission to our 2 psychiatry units, this would decrease delays in the initiation of needed psychiatric care while asking an outside clinician from CHAMPS to come to our hospital to evaluate the patient to initiate the inpatient hospitalization. We also support the idea of widening the pool of providers able to complete the FD-12 evaluation, as this would improve access to much needed emergency psychiatric care. Finally, having access to DBH-approved online training modules would be very helpful to make sure new team members are trained efficiently and accurately. In addition to supporting B25-0692, Children's National applauds the Council for the introduction of B25-0759, Child Behavioral Health Dashboard Act of 2023. This legislation continues to focus on children's behavioral health needs, seeks solutions to support children and families in accessing care, and aims to improve the transparency and cohesiveness of behavioral health systems of care in the district. We are supportive of these goals, and it is an imperative that we continue to take meaningful action to improve child and family behavioral health outcomes. However, we have concerns about the feasibility, capacity, and resources required to successfully implement the proposed legislation, particularly components related to real-time status of service availability across the outpatient continuum of care. Children's National proposes considering other avenues to improve accessibility of services and enhancing the transparency and accuracy of behavioral health resources. Children's also supports additional dialogue on tracking inpatient bed availability for children and teens in the district, as this would be more achievable. We recommend making this provider-to-provider communication for better program management. We will be submitting more detailed written testimony and welcome the opportunity to partner with the committee on this critical area. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you, Dr. Robb. Justin?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Justin Palmer, and I am the Vice President for Public Policy and External Affairs at the District of Columbia Hospital Association. I appreciate the opportunity to present testimony on the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. The District of Columbia Hospital Association and its members support a robust and comprehensive mental health crisis support system in the city. The legislation before us today is essential as we examine what is working and what needs to be improved as we seek to modernize the crisis support and involuntary hospitalization process. DCHA and our members have been pushing for a modernization of the Urban Act for many years to ensure the care delivered to patients in the civil commitment process makes sense for today's world. During the pandemic, the district joined many other jurisdictions by deploying telecourt to support the involuntary commitment process. To our knowledge, there were no issues over the 3-year period that disadvantaged patients, deprived them of their rights, or kept them from a fair hearing. Unfortunately, we have begun backtracking to in-person probable cause hearings that require hospitals to transport patients, staff, physicians to the courthouse, often with less than 24 hours notice. This not only requires patients to be removed from a therapeutic environment, but places them in danger as well. Prior to the implementation of telecourt hearings during the pandemic, there were several cases of elopement of patients from the courthouse. In one situation, the patient was located after several hours by railroad tracks in the district. Luckily, in this case, the patient was unharmed. Additionally, in-person hearings remove resources from other patients as one of the main reasons more hospitals do not take involuntary patients. When staff and physicians are required to leave the hospital for an unspecified period of time, it impacts the ability of the facility to provide equitable care to all patients. For smaller psychiatric departments that may have only one attending physician on duty, this would limit their ability to leave the hospital and maintain care for other patients. We strongly urge the committee to default all hearings to telecourt unless there are circumstances that require an in-person hearing determined by the judges. We understand that the need to preserve the dignity of our patients and protect their rights, and our members welcome a discussion of what needs to be in place for telecourt hearings that may not have been available during the pandemic. If telecourt is not the default, we urge the committee to move the system to a mobile court, or at minimum, ensure that there's at least 48 hours notice prior to hearing commencing to allow time for continuity of care. Additionally, we recommend the district provide transportation between the hospital and the courthouse. The current system travels often in an Uber or taxi. We strongly recommend the district join the 35 other states that have longer custody periods than our current 48 hours. An extension to 72 hours would bring us in line with other states. In our network of voluntary and involuntary hospitals, the 48-hour limitation can be a barrier to getting patients transported to the right facility, especially if they present at or are accidentally taken to a non-FD12 facility. This recommendation is not to make it easier to detain individuals or to provide, but to provide more time to stabilize them. Currently, there are reports from our members that it is taking longer for patients to be placed in involuntary beds from voluntary hospitals. This, on occasion, can run up against the 48-hour time frame. In one recent occasion, this meant that a non-FD12 hospital unfamiliar with the process did have to go to court in order to protect the patient because they were unable to be transferred in time. Finally, we strongly support the training provisions of this legislation, ensuring that all aspects of the mental health system, including MPD, understand the involuntary commitment process is essential for making sure patients are able to receive the care they need in the most appropriate setting. We firmly believe we can honor the rights of patients and treat them with the dignity that they deserve while providing the stabilization and world-class care they need. Thank you for allowing me to testify, and I'm happy to answer any questions.
Thank you, Justin. Mr. Drumming?
Hello, I'm Joshua Drumming from the Washington Legal Clinic for the Homeless. Since 1987, the Legal Clinic has worked towards a just and inclusive community for all residents of DC, where housing is a human right and where every individual and family have equal access to the resources they need to thrive. The Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024 proposes dangerous enhancements that will further disadvantage DC residents. This legislation was crafted without consultation from DC advocates and legal service organizations that serve and represent the community members most impacted by the bill, which may have helped lessen the concerns we testify about today. Longer detention periods, expanded pool of authorized personnel who can initiate FD12s, the reduction in evidentiary standards, and the increased risk of exposure to the criminal legal system for people with mental illness. The most alarming provision of this bill allows DC residents to be hospitalized against their will for longer than the currently allowed statutory period and beyond what is medically necessary. The emergency detention period for assessment and observation would extend from 7 to 15 days, and the probable cause hearing time period would extend to 72 hours after receipt of the request, no earlier than 24 hours after the hospital or facility where the person is detained receives written notice, except requests on Fridays, as those will be addressed no earlier than the following Tuesday. Cumulatively, these changes could result in an individual being detained for at least 21 days without being able to challenge their involuntary detention at a probable cause hearing. This provision ignores fundamental rights, establishing a system that denies individuals their freedom without a timely determination of whether such an action is constitutionally permitted, potentially exposing DC to unnecessary and unavoidable litigation. Current law already affords the chance to extend a detention's duration if a doctor believes that the patient is still mentally ill and likely to harm themselves or others. No data supports that mandatory detention improves treatment outcomes or reduces rehospitalization rates. Increasing the duration of detention only inflicts additional and avoidable trauma. Council should not support an extension of the detention period. This legislation expands the pool of individuals who are authorized to initiate involuntary commitments, allowing nurse practitioners to initiate an FD12. We don't believe the pool of authorized personnel should be deeper. Police officers are permitted to initiate involuntary commitments despite having no medical or psychological expertise or training. If nurse practitioners are allowed to issue FD12s, they should be substituted in for police. We recommend that council engage in a thorough analysis of the training and educational requirements for anyone authorized to assess someone's mental state and imminent actions. This lack of training leads to FD12s being used to harm our clients. In April, the legal clinic was present at an encampment eviction of a young pregnant woman. She tried to gather her belongings, but a group from MPD and DBH decided she was not leaving quickly enough. They tore her tent apart, handcuffed her, made her relieve herself while handcuffed in front of strangers, and attempted to FD12 her to aid DMHHS. This shows how FD12s are often used for non-therapeutic purposes. Relatedly, another problematic provision of this legislation is a proposal to lower the threshold for probable cause. It makes hearsay evidence admissible to justify involuntary hospitalizations, likely increasing probable cause determinations and reliance on weak evidence. Hearsay evidence should not be admissible. This legislation also unnecessarily ties carceral consequences to mental illness. It allows for warrants to be issued for patients who have escaped mental health facilities or failed to appear at a hearing. This bill ignores the realities of mental illness. Individuals should not be criminalized for actions related to underlying mental illness. Nationally, Black and Latino people are almost twice as likely as white people to be involuntarily committed. Allowing warrants to be issued for patients will only increase the inequity in involuntary commitments in the criminal legal system. Ultimately, we must look to the purpose of the proposed bill and the original legislative intent of current law. Involuntary hospitalizations are not meant to be a punitive process that harms the most marginalized communities in DC. This bill fails to prioritize supporting individuals with mental illness, attempts to reduce protections, and actively increases the severity of harm. Instead, DC needs to prioritize the social determinants of health, stable housing, healthy food, community-based mental health services, good education, and more. We implore DC Council to reconsider the purpose of this legislation, reject punitive measures that reduce legal rights, and oppose the primary provisions of this legislation that further criminalizes DC residents. Thank you.
Thank you. Corinne Meyer.
Honorable members of the council, I urge you to support B25-0692, Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024, focusing on improving continuity of care for homeless patients. This bill, introduced by Councilmember Henderson, ensures individuals can remain inpatient until an appropriate discharge plan is in place. However, our inpatient facilities are overwhelmed, often resulting in patients being discharged back to the streets, creating a revolving door scenario. The shortage of shelter space and delays in the voucher system exacerbate this problem, with workforce shortages hindering follow-up care. Many individuals are left on the streets facing overdoses, infections, and harsh environmental conditions. We need a solution that maintains inpatient bed availability while addressing housing instability. Mayor Bowser declared the opioid crisis as a public health emergency in DC on November 13th, 2023. Under the Disaster Relief Act of 1974 and DC Code Section 72304, the mayor can request federal assistance from agencies like the U.S. Department of Health and Human Services. It's time to establish field hospitals. In 2022, DC had the highest increase in age-adjusted overdose death rates in the United States, with 590 opioid-related deaths, 440 related to illicit fentanyls. This crisis disproportionately affects Black residents, who accounted for 85.1% of these fatalities, and 22.2% of overdose victims experienced housing instability. Despite this, the housing crisis has not been declared a public health emergency. The housing crisis meets the criteria for public health emergency status under DC Code Section 72301, subsection 3I. The opioid and housing crisis are interconnected, exacerbating each other. It is not a lack of funding, but severe staffing shortages that limits DC's response. Homelessness in DC increased by 14% in 2023, and rates of homelessness, overdose deaths, and emergency room admissions are rising. Discharging individuals to the street is counterproductive. The mayor should coordinate with the U.S. Department of Health and Human Services Secretary to deploy the U.S. Public Health Service Commission Corps and establish secured field hospitals. These facilities, managed by multidisciplinary teams, would provide a stable environment for homeless individuals, reducing the reliance on inpatient facilities. This approach would save the district money by leveraging CMS benefits and ensuring continuity of care. Potential locations could include church parking lots and the events parking lot near the RFK Stadium. There is no reason a chemically based public health emergency should be treated any different than any other public health emergency. This idea isn't new. Critics argue that the opioid and housing crisis are not time limited. However, a time limited deployment of the U.S. Public Health Service Mission Corps, sustained through academic partnerships, can provide a necessary safety net. Immediate action is essential. I urge you to leverage public health emergency status. Thank you for your attention.
Thank you. Yavar Gimme. I see Yavar. You're in the witness room. If you could accept our invitation to become a panelist, we could promote you. While we're waiting, might have stepped away. I do see Shannon Lott. Shannon?
Good afternoon, everyone. My name is Shannon Lott. I'm the Director of Clinical Services at the Psychiatric Institute of Washington. On behalf of PIW, I'd like to thank Councilmember Henderson and members of the Committee on Health for the opportunity to testify today. The Psychiatric Institute of Washington, or PIW, provides comprehensive behavioral health services to both adults and adolescents experiencing acute psychiatric crisis or seeking inpatient detoxification. Given that our facility is the only freestanding acute level of care in the district, PIW has been a cornerstone in providing care for involuntarily admitted patients who would not have sought treatment otherwise. Nonetheless, due to legal limitations, it can sometimes be challenging to treat the patients who present with the most significant risk of harm to themselves or others in the community. On behalf of PIW, I'm grateful for this opportunity today to advocate in favor of the proposed Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. PIW has a designated court liaison whose core responsibilities include managing and tracking legal deadlines to communicate with the attending physician, provide status updates to the attorneys, and ensure that patients have access to their public defender appointed to represent them because of this emergency petition. It is our priority to respect patients' rights and to treat them in the least restrictive environment. As such, the court liaison reminds the attending physicians to consider and reconsider requests to sign in for voluntary treatment, which restores a patient's rights to request to leave the hospital against medical advice if they choose to do so. Returning this right to the patient can have a significant impact on treatment engagement, and we've seen this firsthand time and time again. With this in mind, there are occasions where the least restrictive environment remains involuntary admission given the patient's mental state. This becomes especially concerning when the hospital must participate in an in-person probable cause hearing within 24 hours of the notification of the hearing. The process requires that hospital staff, including a physician and psychiatric technician who's responsible for milieu management, are made unavailable for 1 to 2 days with very little notice for the hospital to be able to make coverage plans or manage the treatment environment. Furthermore, it places our staff members at significant risk during transport as they're riding alone with a patient who has been identified to be such a risk of harm to self or others and is unwilling or unable to consent to voluntary treatment. If the patient were to assault our staff member or elope from the vehicle, the staff member's only option would be to contact law enforcement, which places an additional burden on emergency services. I implore you to consider moving toward virtual or remote hearings, taking priority to maintain the safety of our patients, our staff, and the community at large. In cases where this may not be possible, it would be greatly appreciated if the hearing could take place no sooner than 24 hours and no more than 72 hours beyond the request to provide adequate time to plan for the patient's transport, including making additional considerations of coverage needs for the hospital. We would also welcome the courts to conduct the hearing on site at the hospital to avoid the need for transport of an unsafe patient. We would also like to express our support of extending the period of detention to no more than 72 hours. To add context to this issue, in cases where involuntarily admitted patients are transferred from an emergency department or a non-FD12 facility, delays in transportation may result in the patient arriving to PIW shortly before expiration of the detention period. The physician may not have adequate time because of this to evaluate and submit the appropriate documentation to support the continued involuntary admission if warranted. This has, on numerous occasions, resulted in a legally mandated discharge of a patient who is determined to be unsafe. In most cases, it's been inappropriate for the patient to discharge independently given their mental state. And the community response team or the patient's ACT team are notified to meet the patient in the community immediately following discharge, which has often resulted in the patient having another FD12 issued yet again and rehospitalized. For a patient already facing psychiatric crisis, this experience can be incredibly traumatic and significantly impact their commitment to their treatment, their relationships with their community providers, and further contribute to their psychiatric instability. I appreciate the opportunity for us to advocate in favor of this bill today, and thank you for considering these recommendations.
Thank you. Yavar?
Hi, good morning. Thank you, Chairperson Henderson and members of the Committee on Health for the opportunity to present testimony regarding B25-0692, Enhancing Mental Health Crisis Report and Hospitalization Amendment Act of 2024. My name is Dr. Yavar Mogimi. I'm a psychiatrist, Ward 5 resident, co-chair of the DC Hospital Association Behavioral Health Subcommittee, and Chief Psychiatric Medical Officer for Mayor Health Caritas DC, a mission-based Medicaid managed care organization serving more than 100,000 district residents. Central to my role as Chief Psychiatric Medical Officer is ensuring whole person healthcare so that our enrollees have the right care at the right time. This legislation is an important step forward for DC to update its civil commitment laws, otherwise known as the Irvin Act. I applaud the committee's efforts to update these important laws and appreciate the tension that exists between ensuring civil rights and the need for appropriate treatment for those with severe mental illness, particularly when there are issues of safety that are impacting the need for care. The legislation takes important steps in addressing the broadened pool of providers that are involved in psychiatric care and assessments by allowing for psychiatric nurse practitioners to initiate commitments, as these qualified practitioners play an important role in providing care in community-based settings. The legislation also takes important steps towards improving patient safety and staff burden by prioritizing virtual hearings. All hearings were transitioned to virtual as a part of the COVID pandemic, which minimize the risk of transporting patients and reduce pressures on involuntary unit staff to transfer patients. This process should be maintained and prioritized post-pandemic to ensure individuals are able to stay and benefit from being in a therapeutic milieu as long as possible. If there is still an expectation to have an in-person hearing, then hearings should be held on the ground of inpatient psychiatric facilities themselves, as is the process currently in Fairfax County and other neighboring jurisdictions. While the legislation takes important steps to improve the civil commitment process, it can be strengthened in certain areas. There's an opportunity for the language in the FD12 form to be broader in addressing interventions related to grave disability, inability to care for self, or psychiatric deterioration, by more explicitly spelling out criteria for untreated severe mental illness beyond likely to injure self and others. It allows for more clear indications for getting individuals that lack capacity and awareness of their disease to receive necessary care that can be life-saving. Lastly, the legislation could take steps towards improving the monitoring and accountability of the current outpatient commitment process. Outpatient commitments are important legal tools that, when enforced properly, can motivate individuals who struggle with voluntary treatment adherence to stay engaged in effective treatment. The current legislation lacks requirements for those in outpatient commitment to have treatment plans shared with the courts, does not specify which courts petitions should be submitted to, and does not have sufficient teeth to enforce reevaluation for those that have not adhered to their treatment plans. As a psychiatrist, my priority is always to provide care in the least restrictive environment possible, but there remains situations due to safety, grave disability, or risk of decompensation when involuntary commitment to inpatient or outpatient settings is imperative to ensure life-saving treatments are available. This legislation takes important steps in streamlining that process, and with some additional modifications could be further strengthened to create a legal and systems change that would improve the process for consumers, families, and providers. Thank you for considering these amendments to this important piece of legislation and for taking steps towards addressing improvement in our civil commitment system. I'm happy to answer any questions you may have.
Thank you so much. Thank you so much to this panel of witnesses for your testimony. Ashley, if you could, yep, thank you. So I guess this panel actually kind of brings up some of the tension that I brought up before, where I have the hospitals and providers saying that they need more time. And then I have lawyers who are saying, nope, you have enough time. You're just not doing anything about it with the time that you have. So let me start with you, Dr. Rob. Can you talk a little bit about, you talked about some of this in your testimony, that there are sometimes children in your care who you believe is in need of treatment, but there's a delay in terms of getting the assessment done. What is the breakdown in time? Why are you all not able to sort of meet those requirements in the time that's already given?
So thank you for the question. There are two different areas where there's a need for time. Let's say that somebody came into the hospital with a serious Tylenol overdose. They went to the intensive care unit, medically treated for the Tylenol poisoning, and now still depressed and suicidal. And we would like to admit them for inpatient psychiatric care because they've already demonstrated a serious danger to themselves, and they still are untreated for the depression because their liver was healing, and they need inpatient psychiatric care. And the parent says, no, I don't want psychiatric care. Because they're already at Children's National, my team can't fill in the paperwork for an involuntary admission. We have to call the CHAMPS team, who is somewhere in the district, probably taking care of another individual who needs help. And we have to delay the assessment to get them over to the psychiatry unit. If people in my own hospital could do that, I could just get the psychiatrist on the consult service who knows the patient, who knows the story, to do the paperwork and get them to inpatient care. And when it's a weekend and it's busy, it can take hours, if not longer than that. And when the parents are in objection to getting treatment, if the child is and this sometimes happens, afraid of the parent, they will say, oh no, I didn't really mean it. I don't want to kill myself. I'm fine. I'd like to go home. And the team that's been evaluating them on the consult service knows exactly what the entire story was, has the record from the emergency room, and could say this youngster really needs to be treated for depression. And we need to help them so that they don't come back in 2 days with another overdose because the depression hasn't been treated.
Okay, so that I think is a helpful illustration of one of the challenges where the limitation in terms of the pool of individuals who can actually authorize or who can initiate. In this particular case, you have, right, a hospital, but no one in the hospital can initiate after that initial one. Mr. Drumming, in your testimony, you were opposed to expanding the pool, but in the case that Dr. Robb brought up, don't you think that that is a reasonable change?
I think that Dr. Robb's testimony really shows that there are structural changes that need to occur. She said that she currently doesn't have anyone in her hospital that is authorized to do so. So I would question, so she said the CHAMPS team is who she has to correspond with. I would question why there isn't anyone from that personnel that could potentially, have residence in the hospital. I don't know.
This actually brings up, there's a part of the law that says that she can't. Go ahead, Dr. Robb.
Yeah, you can't, in Maryland where I trained, you can well, it's a different law, but you can FD12 to your own facility. In the District of Columbia, except for some very specific people in our emergency room, you cannot FD12 to your own facility. It's against the law. So even though I could be trained, right now with the law as it is, we're not allowed to. So everybody is capable of filling in the paperwork, but I can only FD12 as a board certified child psychiatrist licensed in the district for more than 30 years. I can only FD12 to PIW. I can't FD12 to Children's National. It's against the law.
And I understand that this bill actually places the legal regime more in alignment with Stark law, which would allow physicians to FD12 to their own facility. So I think there are a lot of provisions of this bill that are deeply problematic. I've testified to this. Obviously, many other people have testified to that today. That does not mean that we are against every single provision of this bill. That is an area that I think is pragmatic.
Okay, I think that's helpful. I'm just trying to bring that up because oftentimes I know you only got 5 minutes, but everybody gives us all this is horrible, don't do it. But actually, there are some good components here that we hope we can get to. And I was also trying to bring out in your testimony, Mr. Drumming, you said you didn't want us to be able to expand the pool of who can do FD12, which I thought was a bit of a conflict because this would, but that's neither here nor there. I also wanted to ask a question, Ms. Lott, of what you brought up in terms of wanting to minimize transport if possible. And I think Mr. Palmer brought this up in your testimony as well. Can you talk a little bit about what happened during the pandemic, where I think these hearings were largely virtual, versus the transition now back to the in-person transport?
Yes, thank you. So during the pandemic, everything was completely virtual. So all of the probable cause hearings, if called, were conducted with the patient being set up on Zoom or on WebEx, actually is what the court uses. So on WebEx, they were happening, and our court liaison would come facilitate those meetings and allow the patient to have time privately with their attorney beforehand, or as they request, either via phone or either via Zoom video visit. And they would be able to participate fully virtually. Now that we've transitioned back to in-person hearings, those have kind of been in the hands of the patient and their counsel to determine whether the hearing would occur virtually or in person. So the attorney for the patient has been calling either an in-person hearing or a virtual hearing. Now, on occasions, we can advocate for it to be moved to remote, but often our motions that are filed by OAG on behalf of DBH and PIW, that is often denied. We've only actually had one granted since we've started moving back toward in-person visits. So often it creates particular challenges when our patients that we're going to these probable cause hearings for are particularly aggressive or assaultive toward patients, other patients or staff members on the unit, and we're trying to safely manage their behaviors just on a locked unit. And now we have to arrange transportation for them, but obviously this is still someone we would want to pursue a probable cause hearing for because they are unsafe.
Okay. And I know I'm over time. If you just permit me one more question, Councilmember Parker. Dr. Mahimi, I wanted to ask, you sort of see it from a different perspective around, you see the claims data around someone who might have gone in and then, might have had subsequent visits. Can you talk a little bit about what you are seeing, or are there patterns in place that give you pause or that you think are working?
Yeah, thank you. Yeah, if you look at DC Medicaid readmission claims, by far behavioral health readmissions are the #1 drivers of hospitalization readmissions across all diagnostic categories. So schizophrenia, bipolar, depression, all those conditions. So I do think there is part of the challenge, and that's multifactorial. We can't say this is all related to the civil commitment laws or not, but I do think there's a way where both the treatment that's happening in the inpatient side that sometimes may be involuntary, as well as that could be happening on the outpatient side, where sometimes the commitment could still be carried forward in an outpatient setting. And if it had more backing behind it, could ensure better treatment adherence throughout, getting better care while hospitalized and getting better care in the community as well. And I think that could play a significant role in reducing the amount that DC Medicaid is paying around multiple BH hospital readmissions, for sure.
Okay, thank you. Councilmember Parker?
Thank you, Councilmember Henderson, and to those of you on this panel. I just would start by framing my interest in this legislation. It came after an individual suffering a mental health crisis viciously attacked early childhood educators in Ward 5. And immediately I was thrust in this tension that is very evident with this panel and that Councilmember Henderson was alluding to, where there were many concerned, rightfully so, about the mental health of this individual. At the same time, there were many parents and neighbors who were frightened and worried about this individual being back on the streets and the concern for what might happen next. With that framing, and I would just say it made clear where there are current loopholes in our existing system. As I was on the phone with Dr. Bazaran, Councilmember Henderson, and other officials, it was clear that we could not sufficiently provide the care that this individual needed at that time, nor could we guarantee neighbors that they were going to be safe. And I just want to frame my questions around how do we emphasize safety both for neighbors, but these individuals in these moments of crisis. I want to start with you, Ms. Lott. You talked about the need for lengthening time because by the time a patient arrives at PIW, your window of time for evaluation or treatment might be running out. Obviously, this legislation expands that time. Is the expansion encoded in the legislation sufficient, or would you encourage us to go even further or to land on a different window of time?
I do believe it's sufficient. I wouldn't want to further extend, as some of the attorneys pointed out, to, at the risk of infringing upon patient rights. I do understand that that is of concern as well. I think on the other side of things, that would allow for sufficient time because often, as I mentioned in my testimony, people are arriving shortly before the detention expires, and which extending it only even a few hours would allow us the time to be able to evaluate and get that necessary paperwork Often it's not delays due to the care providers. Sometimes it's a delay due to transport providers or something, and it's beyond the control of the physicians. And so just to be able to kind of mitigate some of those transportation delays, or as Dr. Rob mentioned before, bed availability delays, then we can just extend for a few hours so that we could be able to adequately evaluate and write the necessary documentation that needs to support the continued involuntary admission.
That is helpful. Thank you for that. Mr. Makimi, I want to come to you. You mentioned a need to expand criteria. I would love for you to elaborate on that. And you also suggested that we need to have teeth to the reevaluation plan if there is evidence that an individual is not progressing in the way that we would hope. Can you just speak to those two things a bit more?
Sure. And yeah, I mean, I'm from the Bloomingdale neighborhood, so I'm very familiar with the case that you're referencing and very familiar with that individual. And I think his case actually highlights really the priority for someone like him to get treatment is only once they've committed a crime and once they put the risk of the community or themselves at risk. Whereas my experience of that individual as someone in the community is that they truly lack capacity of their awareness of their mental illness. They were barely coherent most of the time when you see or run into them. And it's really a travesty that in our society that we sort of have made that an okay issue, that folks can sort of suffer silently in this way until they commit a crime and are then basically put under a higher level of treatment support. So this is not a problem unique to DC. This is obviously a problem with how we've sort of migrated folks from, institutions to now the street and then, mostly the legal system. So I don't think this one piece of legislation is going to solve that whole crisis that we're in, the mental health crisis in America that is being presented here. But I do think there are ways that in other states where they have made it more likely for folks to be put into care, not just based on these very kind of vague criteria of risk to self or others. They've added additional language to civil commitment that highlights disability, highlights inability to care for yourself, or psychiatric decompensation that makes it a more broader interpretation of when somebody would benefit from a higher level of treatment. And then those same kinds of criteria can be applied on an outpatient commitment level too, where there is, again, there are states that I think have allowed for a broader definition and understanding of when somebody has the inability to kind of care for themselves and how can we prioritize their treatment.
Thank you for that. I am at time. I'm going to ask Councilmember Henderson if I could have an extra minute.
Sure.
Yes. I wanted to come, Mr. Drummond, I do get the concern, really. This is a tension, and I've had conversations with Councilmember Henderson. I think it's fair to say we recognize and appreciate the tensions that exist here. You talked about a need for structural changes. We probably won't have sufficient time to do it justice here. But a question I would be asking is, are there ways with the legislation as drafted now that there could be certain checks and balances that might address some of the concerns that you lifted up? If you want to take a few seconds to just reflect on that and or follow up with the committee, I welcome that.
Yeah, I would definitely want to take more time to reflect on this. The very short answer is there's always more room for checks and balances. I think that it's just important to prioritize people's rights, including their federally mandated rights, which some legislation as of late does trample upon. I think that's extremely important, and I think utilitarian actions for all DC residents. The fact that someone has an underlying mental illness, the fact that someone is unhoused, that should not be
sufficient reason. It seems like you're Seems like your connection is breaking up, but
decrease their due process rights, for example.
Your connection is breaking up, but I think I made out, and your point is well taken. I also just want to thank you, Ms. Robb, for that illustration. I think that was really helpful to kind of point out an existing loophole in our system. So thank you, Councilmember Henderson, for the additional time.
Thank you. And thank you to all the witnesses. Again, please make sure we have your written testimony for the record that you can upload very easily on the council website. All right, we're going to our last panel of public witnesses. Rhonda Hamilton, Catherine Belize from Washington Psychiatric Society, Lindsay Popolinski from Washington Psychiatric Society, and Michelle May. Okay. So folks are coming in. Okay, I see Dr. Hamilton. Dr. Hamilton, when you're ready, if you're speaking, you're on mute, by the way.
Thank you, Councilmember Henderson. I appreciate the opportunity to speak before the Committee on Health, and I most importantly thank you for holding this very important forum and conversation. I am a staunch advocate for preserving our citizens' rights. I am an on-the-ground advocate, have been for the past 8 years, almost coming up on a decade now. And while much of what my colleagues have spoken on and testified to today addresses the general sense, I'd like to offer a more specific representations of what we see on the ground daily in the district, and the reality of the breakdown of a fractured mental health system is pretty much making it a challenge for us to understand whether or not we should view this as a criminalization of folks with serious mental health challenges, as opposed to the breakdowns we see on the community every day from the myriad of social barriers and determinants that they are challenged to represent. Our advocacy seeks to be able to help DC citizens that are struggling with advanced mental health challenges to be able to find stabilizing opportunities to be able to succeed in society. The reality is that many of them are lacking access to healthcare overall, and what we understand in the reality of for example, the Unity healthcare crisis, where we've just witnessed over 25 physicians walk off, where the Unity healthcare system provides healthcare for over 80,000 citizens in the district. The reality that we have open air drug markets that obviously produce 98% fentanyl, as well as mind-altering drugs, and many citizens suffering from depression and anxiety that are resorting to substance use and abuse. We as advocates see the challenges on both sides, and we support the arguments on both sides. However, I appear before you today in support of Bill B25-0692, Enhancing Mental Health Crisis and Support and Hospitalization Amendment Act, simply because we have so many societal stigmas and we lack empathy for the often challenged implementation of smart mental health legislation. We've heard many of the folks testify that we do have a fractured system, and I believe that if the council would consider an overhaul of DBH's current operations, we might begin to get at the core of the problems we're seeing. Citizens that have severe mental health challenges that are left to voluntarily leave facilities that could otherwise help them to maintain and have access to services is a problem. Helping citizens to stabilize, one of the biggest components is that is being able to help them to have accountable behaviors so that the public safety challenges of the community to themselves as well as the community surrounding are not challenged. One of the biggest components that we wrestle with is the reality that in the district, we have so many children being raised by unhealthy adults. And so when we see the exasperation of truancy and the public safety failures, we understand it wholeheartedly. I watch grandmothers who struggle to maintain housing and not able to complete recertification processes because they're spiraling. The constant failure of district services and resources lead them to have distrustful understandings of a mental health system that is supposed to be in place to care for them. Why I support the bill is because the reality of being able to not have to drive the streets to look for citizens that are in crisis mode, who have been on the radar, where we don't have a universal observation system that allows us to be able to track these citizens, it makes it a challenge. Citizens would rather sleep at bus stops in these crisis modes instead of being housed because they have been repetitively failed by our system. And so while I do not support criminalizing, what I do support is that perhaps the council could have stronger motivations and concentrations, and perhaps legislative fixes that insert advocates. We build lifelong relationships. Many of these citizens don't have comprehensive systems of support. Many of the agencies that they're referred to don't have the proper oversights in place. So my teenagers that would rather house their belongings in a laundromat and sleep on the street rather than go to a shelter or submit to an assessment process because of what they are experiencing in those processes. And because they wear the label of having severe mental health challenges, they are oftentimes not received in a manner that respects their rights. And so while we're concerned that this bill would actually compromise a citizen with severe mental health rights, we see citizens with severe mental health in our system every day whose rights we feel are compromised, so much so that as their advocate, we've advanced these concerns to the Office of Administrative Hearing and to the chair for the Health and Human Services, because we realize that as long as our mental health system remains fractured, our system, our citizens' rights are compromised daily. And so the reality of this bill and the fact that we would have an opportunity to oversee these extended observation periods gives us hope that the citizens will receive the comprehensive care processes that they need in order that they can stabilize in the community. The one word that we are often trying to help our citizens arrive to is accountability. But someone in crisis and someone spiraling can't really understand or speak to their rights because they're simply trying to stabilize. And we're concerned because many of them oftentimes spiral into realities of suicide.
Thank you.
And so when we argue about rights, and while we are concerned that we are not allowing them the opportunity to exist freely, we need to understand that many of them don't exhibit the abilities daily to be able to understand the difference, and they do need help. And many of them don't ask for help or seek help because of their lack of trust.
Thank you, Dr. Hamilton.
Thank you.
Dr. Baseless?
Good afternoon, Chair Henderson and Council. My name is Catherine Basleys, and I'm here with Dr. Lindsay Poplinsky. We are forensic psychiatrists working within the District of Columbia. We are here today to represent a broader organization, the Washington Psychiatric Society, or WPS. WPS represents over 900 psychiatrists who practice in the district, Maryland, and Virginia. One of the many missions of WPS is to advocate not just for practitioners it represents, but for the patients cared for by psychiatrists within the district. WPS endeavors to promote legislation that ensures mental health treatment is delivered equitably, ethically, and to the high standards our patients deserve. WPS supports the proposed amendments and wishes to provide one suggested consideration, specifically to propose changes to DC Code 24-531.06. We would like to state that we are employees of the Department of Behavioral Health, or DBH. However, our testimony today does not necessarily reflect the views and positions of DBH, nor are we testifying as DBH employees. DBH will also testify today, and we direct you to their testimony for the official DBH position. Civil commitment, or the legal process whereby an individual is involuntarily ordered for either inpatient or outpatient psychiatric treatment, is a universal phenomenon in psychiatry. It is arguably the greatest tool we possess to keep patients and the broader community safe in the face of psychiatric crisis. Civil commitment occurs approximately 10 times per 1,000 individuals with serious mental illness nationwide. Dr. Poplinsky and I have had the opportunity to encounter civil commitment within multiple jurisdictions during our training. Much of my training occurred in New York, which employs an emergency commitment statute similar to that proposed by the current amendment. It allows for a 15-day period of commitment before a decision on discharge or further commitment is made. In my experience, I've seen subtle illness emerge, suicidal thoughts be disclosed, and lingering effects of illicit substances resolve over the course of this time. In psychiatry, there are no blood tests or imaging that can confirm a diagnosis or tell us if somebody is at risk of harm. It's our observations as well as the patient's words and their actions that drives our decisions. And if there's anyone present who has lost a loved one to suicide, you'll know that oftentimes it's patients who need the most help that can hide their pain the best. In the throes of mental health crisis, time can be our greatest ally in formulating an appropriate treatment decision. I'm going to turn it over to Dr. Poplinski, who's going to complete our testimony on behalf of WPS.
Thank you, Dr. Baslis, and thank you, Councilmember Henderson. My name is Lindsay Poplinski. The new bill also extends important considerations to maintain due process in a safe and dignified manner by allowing for virtual hearings in appropriate circumstances. The American Psychiatric Association formally supported the use of teleconferencing civil commitment hearings in their 2016 position statement on location of civil commitment hearings. The teleconferencing of hearings maintains a patient's dignity by avoiding the use of handcuffs or restraints in transport and minimizes the potential for extended wait times for their case. In our experience of patients who have gone through various court-related procedures, they often cite these additional necessities as distressing, and avoidance of them, when possible and appropriate, is reasonable. Finally, WPS would like to offer one suggestion for the proposed amendment to DC Code 24-531.06. There are unique aspects of mental health care, including that each patient's needs may vary, and psychiatric units can be uncomfortable or distressing places for some patients. We would like to reflect the proposed amendments. The amendment takes the discretion away from the treatment team by mandating ongoing commitment for, quote, no less than 15 days. Treatment teams know their patients and their needs. For some patients, a mandatory additional 15-day stay may pose undue risk, especially on units with acutely ill patients who require significant staff attention. Indeed, in one study out of our neighbor state, Virginia, approximately 1 in 20 individuals found incompetent had intellectual disabilities, a disorder which may not benefit significantly from inpatient treatment. Such an unfamiliar environment can worsen anxiety and induce behavioral problems. In these and other rare cases, the treatment team may recommend discharge sooner than 15 days, assuming the patient has stable providers and support in the community. WPS would ask this council to consider putting treatment team discretion into the statute to allow the treatment team to consider individual circumstances. WPS would like to thank you for the opportunity to testify today and for the thoughtful amendments proposed to the current statute. We're happy to answer any questions.
Thank you. And finally, Michelle May.
Greetings. My name is Michelle May. I am the Executive Director of Deaf Reach, a small nonprofit organization serving deaf and hard of hearing adults experiencing severe behavioral health concerns. Deaf Reach provides community support, counseling, day services certified by DBH. Thank you to the Committee on Health for proposing this legislation, which addresses many aspects of the Urban Act. And thanks to everyone else interested in this important topic. I worked for 16 years at the Department of Behavioral Health, operating mobile crisis and outreach services, developed and implemented the current officer agent certification program, offered training to behavioral health providers, police officers, FEM staff, APS, and others, had oversight for many years of the civil commitment monitoring process at DBH, helped access assertive community treatment, and consulted in numerous cases with DBH providers, inpatient facilities, CPEP, family members, and other concerned providers. I support many aspects of the legislation. I support the extension of the time of the emergency detention to up to 15 days. Many of the individuals my team and I worked with were highly symptomatic and in multiple kinds of intertwined crises, including psychiatric, health, and addictions. A psychiatric illness or a mental illness is an illness of the mind or the brain, and it takes time to recover. Many of the clients I worked with, especially those living outside, were covered in their own feces, urine infested with lice, scabies, septic, had untreated diabetes and other circulatory conditions, skin conditions, malnourished, inappropriately dressed for the weather, and at various stages of alcohol or drug addiction, all intertwined with their mental illness. When a person in this condition refusing all care comes into the hospital under an involuntary FD12, a hospitalization of up to 7 days is often not enough time for the person to recover and then to participate in treatment so that the hospitalization is worthy. They often leave prematurely and then come in again and again and again. In fact, recidivism is one of the hugest issues we face. A small number of people responsible for a large portion of FD12 interventions. It would be my hope that the additional time, when needed, will reduce the need for additional involuntary interventions. I would remind everyone that people have a right to treatment when they are too ill to care for themselves and accept it. Psychiatric hospitalization helps many people voluntarily or involuntarily. I've seen it all many, many, many times. I do support virtual hearings for all the reasons everybody else said. The addition of NPs to the pool of individuals who can write an FD12 by statute. So, the pool of people who can already write an FD12 is huge. It's absolutely huge. Anyone with arresting authority, all DC licensed physicians, all DC licensed clinical psychologists, and officer agents trained by DBH. I don't necessarily support anyone by statute being able to write an FD12 without training. Okay, the FD12 needs to contain facts. It needs to be written well the first time so we don't have to write it again and again and again. Many clinicians are trained to write opinions using fancy clinical jargon, which is not acceptable here. I have reviewed many, many FD12 documents for quality frequently as part of my job, and officer agents certified by DBH, especially those working in crisis teams and ACT teams, and then many police officers tended to write the better FD12. Okay, NPs currently working for DBH certified providers and hospital systems, I think could go through the officer agent training and have really good training and write good FD12s. An FD12 is not a piece of paper. It's an intervention from start to finish. We want to maximize the use of it so we don't have to keep doing it again. Okay, I would suggest we could also add to the pool licensed graduate clinicians already working for a DBH provider network. Most importantly, I'd like to see us write good FD12s and maximize the first involuntary hospitalization to reduce all the recidivism. Virtual training, I support this. It was my experience that all aspects of the Urban Act and the filing even of guardianships was so confusing for providers, advocates, and family members that they often did not make good informed decisions on when to implement these techniques. I support the change in the request for probable cause hearing from 7 to 15 days, and I support hearings being held between 24 and 72 hours for the same reasons everybody else has already said. I support the right of a person to stay in hospital voluntarily on outpatient commitment so that they get appropriate services on the back end. And I do believe, I am concerned about warrants for noncompliance, but I believe if you're going to do a civil commitment order, you do need to have some way of ensuring some kind of compliance.
Thank you. Thanks so much. Thank you to the group of witnesses for your testimony. I think you guys brought up some of the issues that are tension points in terms of support versus not. Dr. Popolinski and Dr. Basley, I think you guys can sort of see too, there was some testimony from folks earlier who were in opposition to extending the timelines. What would you say about what we're seeing on the ground in terms of the ability for folks to get the necessary evaluations done and connections to treatment?
So my current position within the district doesn't allow me to see that here in the district, but I will say that in New York, under similar circumstances, at least in my experience, sometimes it was really hard to gather the necessary data to come up with that final decision about treatment. For instance, getting in touch with collateral, meaning families, getting to know what really was the issue going on. Sometimes that was patients wouldn't consent or give us phone numbers. We had to track down, what was actually going on in the community, and they were hiding some of what was actually going on. I remember having a woman who came in she looked okay. She talked okay. You wouldn't have known something was wrong, except she, over the course of a couple of days started talking about her family messing with her money. And we finally got her to agree to let us talk with family. And it turns out she was sleeping on a park bench, had given away all of her belongings, was incredibly paranoid and lost contact with everybody in her life, lost her job. She wasn't telling us any of that. And it took us time to find that information and really understand the depths of her illness. I've also seen people agree to voluntary treatment within those 15 days. It takes time for a physician to build rapport or that connection with the patient, especially when they're paranoid, when they're sick, when they're scared. And the more time we have to establish that rapport, we can get them to agree to treatment. People don't come into the hospital agreeing to medication necessarily. It takes time. And sometimes they'll agree to it voluntarily. Sometimes we have to pursue involuntary, but time is really important in those situations. I don't know if Dr. Poplinski, if you want to add anything to that.
Yeah, I would second all of that. I think you brought up really good points already. In my capacity working as a psychiatrist in the district, I see the patient on the front end. And so they come to me. I don't know anything about the patient, presumably, if I haven't ever seen them before. Some patients are very good at hiding their illness. So it is just time and data points that I need to come up with a clear diagnosis. So diagnostic clarification takes time. Care coordination takes time. Obtaining collateral information takes time. And so as a physician, our ethical guidance is, doing what's in the best interest of the patient and first do no harm. So that's always our number one priority. So as we highlighted in our testimony, there are some circumstances where additional time in the hospital is not what a treatment team may be advocating for and may not be in the best interest of the patient. And therefore, that's why we would like to see treatment team discretion. However, on the other side of that, I do appreciate that there are circumstances that just need additional time.
Right. Okay. Well, I want to thank you all for your testimony, and we'll certainly review your in testimony, which I feel like is certainly more comprehensive. I'm going to turn to Councilmember Parker.
Thank you. And really fascinating. I wanted to come to you, Ms. May, and again, apologies. I see some of you are titling yourselves doctor, and so therefore I can call you doctor. Some don't, and so I'm just going by what I see on the screen, just FYI. You spoke about recidivism and the likelihood of increasing recidivism if we don't get it right on the front end. Can you elaborate on the rates of recidivism that you are aware of in the district, and what makes it more likely that an individual will get the care and treatment they need and not return in your experience?
When I was running the team, there was a small number of people that we were bringing in. It could be, a month, a couple of times a month. It could be monthly. It could be, 10 times in a year. We worked hard to write a really good FD-12 so that we had all kinds of longitudinal information from members of the community who might have witnessed certain behavior to the treatment team trying to work with the person and to a family member. And we would write an FD-12 that included as much of that information as possible. Okay. And so that's why I say, having more people isn't necessarily the best thing. Writing a good FD-12 with as much legal evidence as you can possibly have. And then, as some of the doctors have said, you got a lot of information in this document, and then they don't have to maybe pull as much information, And so that was one of the things that we thought was very helpful in our collaboration with the emergency departments and the inpatient hospital. Then they can kind of start and get the treatment going as soon as possible. The other thing thing that helps a lot is going to the hospital and working with the person after you've written the FD-12, making sure the linkage is happening. A lot of times a new treatment team doesn't have that relationship. But if I can look at someone in the face who I've now put in the hospital and said, listen, we discussed how concerned I am about how you're doing. You know, your hygiene was very poor. You weren't really eating very well. You told me you weren't feeling good. And now look at you today. You seem to be feeling better. Do you agree? These things are important and they really support someone getting better. So those are the things that I think are helpful. The numbers change all the time. I think that DBH can probably share those numbers with you. But we had really kind of a list of people that we were constantly worried about and looking for, who often left the hospital too quickly. Sometimes documents don't get filed in time, as you know, although that's been better lately over the last few years. So those are the things that I saw. A lot of times a doctor who only has up to 7 days isn't necessarily going to do something because there's only a couple of days left. And then the other comment I'd like to make is to bypass the idea of the emergency detention of 15 days, up to 15 days, to do a 1-year civil commitment filing doesn't seem to make sense when you're really wanting to support the rights of the person. You kind of would like to give the person the first hospitalization to get better and not really go for a full 1-year civil commitment. At the outset, you'd like to, you know, try to work the first way first. So that was another comment I had from some of the other people.
No, thank you for that. And the other question I just would throw out to anybody is around the training modules and what concerns, if any, might we have for there to be a virtual training module around this FD-12 policy and expanding authority for other people to engage in that process? Like, are there things we should be mindful of on the front end, should we move forward with that aspect of the legislation?
I think for just training, my experience of training in general and having to go through many, many trainings in various capacities, I would encourage even if it's virtual, hands-on or multiple examples for people to engage in. It's one thing to hear the information and kind of passively listen. It's another to put it into practice. So if that's possible, that training modules could also include a participatory or practical application aspect. I think that would be really, really helpful for people.
I would say the officer agent training now is interactive, and we really wanted to get people to look at scenarios, look at judgment calls, write a few FD-12s, you know, get the information for, you know, a fictitious case and write a couple so that you weren't scared to write it on a piece of paper, think it through, and then just general scenarios. What would you do in this case? What are the things you think about? So for the certification training, you know, you're right, it's very important, but you know, the civil commitment process is a big process. It's not an FD-12. And often providers would call me and say, my person's being let out. I don't know what to do. And I would start saying, well, what's their legal status? Oh, I don't know. Well, how can you find that information? What does that mean? And all of these things are very important, you know, because if you haven't filed it early on, then the person's voluntary, which may be fine. But the providers need to understand what to ask for and what can happen.
Understood.
Mm-hmm.
Dr. Hamilton, I'm not sure if you were going to jump in.
Yeah, I was just going to add to the fact that I concur for the interactive necessity, the reality that many of the professionals here referenced that some of them don't have access or knowledge to what's going on the community level, and the fact that the citizens are able to, as we say, interview well and not be able to disclose all that is going on. I think that's very important to stress that we have training that helps professionals to understand and take that into account. Thank you, Council Member.
No, thank you. And thank you all for your testimony.
Yes, thank you all for your testimony. Thank you to all of the public witnesses. We're going to move to the government witnesses at this point. As we do that, there are a number of people who are currently on the Zoom whose title is MC. If you all can rename yourself, I'm going to give you a couple of minutes to do so. And if you don't, we're going to remove you. Just I want to make sure that we don't have any interruptions as we move forward. So if your Zoom is labeled MC, please rename yourself so we know that you're here and supposed to be here. So our government witnesses today, we have Wayne Turnage, Deputy Mayor for Health and Human Services, Dr. Barbara Bazaron, who's the Director of the Department of Behavioral Health, Gregory Pace, who is the Assistant Chief of Mental Health Section and Public Safety Division of the Office of the Attorney General for the District of Columbia, Katarina Simonova, who is the Special Counsel for the Director of Public Policy at the Public Defender Service for the District of Columbia, and Elena Settenberg, who is the Special Counsel for Policy and Legislative Affairs for the U.S. Attorney's Office. All right. Just so things can kind of be clear here, we're going to start with the Child Dashboard Bill. And correct me if I'm wrong, OAG, USAO, and PDS are not testifying on that piece of legislation. I see nods. Okay, great. All right. So then I will go then either Deputy Mayor Turnage. Is he here? I don't see him. He was here. Maybe he's coming back.
Good afternoon, Chairwoman Henderson. Deputy Mayor Turnage stepped away and I will be sitting in his stead right now.
Okay, thank you, Director Byrd. Okay, I'm not sure who wanted to go first on this particular bill. Dr. Bazaron?
Yeah, I'm here to answer any questions that you may have.
Okay.
Not to provide testimony on this bill. I will provide testimony on the second bill.
Okay, all right. So, Melissa?
I also have no testimony to provide orally except here, and happy to take any questions about the dashboard.
Okay. I think this was unusual. So what is the executive's position on this bill if no one is providing testimony on this piece of legislation?
Well, I can certainly say that, we welcome the opportunity to have an interactive, up-to-date dashboard on children's services. I believe that that we do have a static system now, the Behavioral Health Resource Link, but that does not give you the just-in-time information regarding what slots might be available for a young person that a parent is seeking services and supports for. So we really welcome that opportunity and would look forward to really working to help develop it and plan the structure with family members and other people from the community. I think that it is extremely important for us to establish ease of use and relevance for the end users, and that's where we need to start. And then look at how we build it out. These dashboards, and I do have some experience working with this based on the time I spent in Maryland, are fairly complicated tools to develop. And you really do need someone with expertise in IT business intelligence. And so one of the things that I would share is that if we don't have that in-house within government, we really need to make sure that there are consultant services available to help us develop a platform that could provide that kind of real-time data. Okay. Also, I think to look very closely at determining whether or not there are other existing templates that could be used to support the dashboard rather than starting, absolutely from scratch. There are lots of tools out there in the environment. And a couple of the questions that I think we need to answer is determining which agency or entity would be responsible for the day-to-day management of the centralized system, because it needs to have staffing and it needs to be updated on a consistent basis. What my experience was in Maryland is that was one of the biggest issues. And I think that some of the presenters earlier talked about the fact that if the data is stale and isn't up to date, it's not going to be very useful. And so we have to plan for that on the front end. The other thing that I think we should think about is all of the agencies that need to be involved. In reading the legislation, it was noted that DYRS and CFSA are not listed as required participants. They also have a variety of resources that our children, youth, and their families should be able to use and do use. And so I think that they should certainly be there. I think that one of the critical elements will be to develop a clear fiscal impact statement so that we have the appropriate resources to develop this. I think that a couple of people also talked about the fact that we do have Access Helpline, which does provide some real connection for individuals. Access Helpline is not going away, oh, by the way. And we do plan to continue to provide that kind of linkage service and supports for families who are seeking services for their youth. So I hope that's helpful.
Yeah, thank you, Dr. Bazaran. Ashley, can you put a 10-minute clock on? Thanks. Okay. I do have some questions. So, Dr. Bazaran and Dr. Bird, I'm hearing from your testimony that there is no opposition to doing this dashboard. And I'm trying not to be frustrated because I know this is not the first time that we've had a conversation about the necessity of needing a dashboard. And yet you all haven't made any movements towards doing so. I'm just a little confused here. Are you saying that if you think this is a good idea, why then do we need legislation in order for you all to move forward?
Well, I think that, and certainly Director Bird can speak to the fact that, in fact, we haven't talked specifically about a child behavioral health services dashboard, but we are looking at how we might have a dashboard to capture some of our services and incorporating that into CRISP, into our HIE. So I'll let
and let me clarify, you're correct. We perhaps have not had a specific conversation around a dashboard around child behavioral services, but I have certainly asked for a dashboard on the number of residential beds available in mental health facilities before.
And so that's what we've been working on.
Sure, and that's Chairwoman Henderson, that's what Director Bazaran was just referring to. So our agencies have been working together along with the district's Health Information Exchange, CRISP DC, to start the planning process for essentially having a behavioral health bed board, for lack of a better term, available at least to providers through CRISP. We just recently submitted our funding request to CMS because this is technical and HIE related. We can often get 90/10 funding for that, but it has to be approved in advance. So that just went into CMS. I think I signed off on it last month, June, I think. And so that work is ongoing. Again, that's really focused at making sure that on the provider level, there is some easier access to understanding what bed availability is open and where across the district when needed for folks to transfer to a psychiatric bed.
Okay, so that's great in terms of for hospitals, in terms of discharge and coordination planning. But we heard some testimony today around, for the public facing part of things to make it more user friendly for folks. And maybe Dr. Bazaran, you can clear up some things. So Children's Law Center, or was it Children's Law Center? No, hold on. Someone testified. I'm going to say somebody. I can't remember who it was at this particular stage. Testified about some changes to the Access Helpline, and maybe it was Eva Richardson, around they said this used to be something where if a family used to call Access Helpline to say, have a family member who's in crisis and we're seeking help and support, that there was someone at the Access Helpline who can sort of navigate them through the system. And that there has sort of been a transition that has happened on that. And now that's not the case. Can you talk a little bit about the status of the Access Helpline today?
Well, certainly, first of all, if someone calls Access Helpline and they need help with support, they can get it. It still is 24/7. What we did do, however, as we were planning for the transition into Medicaid, and that migration process, we did develop some gap policies to kind of during that period of time. Before we knew that it was going to be extended for a longer period of time based upon some budgetary factors. And so there is a system, particularly around some of the administrative functions for our community providers, where they are using an email system to get some of those tasks done. And people do have the opportunity to either leave a message or they can use a live person. It's up to them in terms of what they'd like to do to help them connect to service. But the Access Helpline is still very functional. We are, as you know, also standing up our crisis services, our 988 service, and that also resides within the Access Helpline.
Okay. But in terms of the Access Helpline, part of the testimony was that you'll call and they'll give you a list, and then it's the responsibility of the family to call through to see who has availability.
I'll follow up on that, but I do know that people, to the best of my knowledge, certainly, and have the ability to talk to a live person and get the help that they need.
Okay. Director Bird, can I unpack a little bit in terms of what you all submitted to CMS in terms of what you envisioned for the dashboard work that you all are going to be doing for providers?
I'll do my best, but I suspect the best will be following up with any additional details. But right now, currently, we submit an advanced planning document to CMS to help fund. We're, I think, the first jurisdiction that was able to get approval from CMS to leverage their 90/10 matching funds for a health information exchange. So that's why the request is going through there. It will have, it is really just when we are adding any new element that's going to create or cause the need for design and development and implementation, and it's related to the CMS funding, we put that request forward to them to secure the funding and make sure they have no questions. They will look for elements of how this supports the Medicaid program, and generally how we have been able to leverage the Medicaid support is in part because of the overall concentration of Medicaid coverage that we have in the district. But the actual kind of like, what will it look like? All the data elements, I don't believe that we go into that detail with CMS. It is more of like, here's our use case. This is what we're going to endeavor. And through your financial support, this will be the outcome. But I'm happy to pull those details and share with your office.
Okay, because one of the things I think that folks wanted to have, was some information about wait times, for instance, and then, some other pieces of information. And so while I think anytime we can get the federal government to pay for a portion, let's do it. But I want the tool to have some utilization that can meet some of the needs and concerns that we've heard from folks in the community.
I do just want to be clear with CRISP, it will be provider facing on the hospital bed piece. And so getting to what I think is more of the intent of the dashboard is having stuff that's more publicly available for anybody, whether it's a resident, a patient, a family, or a provider accessing that information can have that too. So that the work right now is really to be provider facing.
Okay. Can you guys do both at the same time? Is this a situation where you could work on something that's provider facing and public facing at the same time? Or are you going to tell me you got to do one first?
I don't know. If I got to make all the decisions here, I'd want to be as efficient as possible. CRISP is largely set up to be provider facing. It is a provider tool, right? It's not, it doesn't have the same kind of public function in part just because of the privacy expectations, right? You don't want everyone to be able to go in and pull information. For this piece, because it is more about access to a particular service, I will talk with my team and see what opportunities we have. Is there that kind of functionality existing within CRISP now that can open it to a public component? But I don't think that's something we've done today. But I will certainly follow up, and I appreciate what I suspect is, again, we want to be efficient with our time and resources, and how can we not have to start from scratch to make something publicly available, I presume is your hope or desire.
Yeah. So, I mean, on that, let's talk about it from the MCO standpoint, right? We pay our MCOs a great deal of money. And, you know, they have providers for whom they are connected with. To what extent have we checked to see, right? I gave the example before of like, if I'm looking for a dentist and I go to my insurance company's website, they have filters that I could say, you know, I'm looking for somebody in this particular area, and I'm specifically wanting to see who is accepting new patients. And then they are able to populate a list that at least slims down the number. Do our MCOs have that capability on their websites as it pertains to specifically behavioral health services?
Sure. Well, a couple of things. First is going to depend on which kind of behavioral health service, since the more intensive services are carved out of the managed care plans, right? So if we're talking more general counseling, diagnostic assessment, you should be able to find those provider types through the managed care plan provider networks. What I don't know off the top of my head, Chairwoman, is whether or not you have that ability to search and with those kind of filters out of who's accepting new patients. I know everything's available online. And then Leah from the Children's Law Center earlier referenced the new requirement for Medicaid agencies to have provider directories available online by July of next year, and those have a minimum requirement of a quarterly update. But I will say too, one of the things that we hear of like a chief complaint, and it's not unique to the district, is having that kind of real-time understanding of who is and is not accepting new patients when they go onto the Medicaid provider directory. So I will follow up in terms of how real-time and the ability to filter that information is with the managed care plans now.
Yeah. I mean, the conversation just is like, if only we had done that behavioral health carve-in like we planned for years, because that could have made this a bit more seamless, but now we have to have separate programs until we get back to sort of doing that. But, you know, when we talk about reducing the barriers for folks to have entry in terms of services, one of the biggest barriers, or where people just get frustrated, is just trying to find a provider, right? And I think that is a little bit of what Councilmember Parker was trying to get at when he introduced this legislation. It sounds to me as though you all aren't opposed to it, but it also sounds that one, you guys are going to say there's going to be some significant cost concerns here, and then two, there's going to need to be some significant time in terms of implementation. But we can get into that further. I'm over my time. Councilmember Parker.
Thank you.
I was just going to say that it should be noted that we do have information on the specific services that are offered within each ward, and offered by which of our providers in the behavioral health resource link dashboard, but it is not the kind of as interactive as what we're talking about here.
I'm sorry, you said the behavioral health resource link?
Health resource link. It is a dashboard that we have on our website now. Okay. And so you can go to dbh.dc.gov and go to the children's page, and you'll be able to click on the behavioral health resource link, and that does have information on the services and supports. And that particular document was really, or tool was developed in response to the South Capitol Street Act, and included DHS, DDS, DHCF, and the Office on Aging and the Mayor's Office on Veteran Affairs. And so we all work together on that. But here again, it doesn't meet the requirements that are in the law, which I support.
Yeah, I'm on the website now, and even from the you know, what are you looking for? That's such a broad question, I guess, for anyone to be able to type in things, but it might be helpful to have like even just a drop down of like substance use, mental health, you know, those types of things. But Councilmember Parker.
Yeah, no, I'm looking at this as well. It's great to know this exists, Dr. Bazaran. I didn't. And this certainly could serve as a jumping off place for the type of dashboard this legislation is calling for. And as was already mentioned, the goal here is to simplify process for families who are desperately seeking out care and are sifting through website after website, calling numbers, not getting information. So thank you for this. I will follow up just with more questions. And how frequently is this dashboard or tool updated?
It's updated every 90 days, and we do have a provider who is responsible for that, who's under contract with us.
Got it. Okay. Director Byrd, I want to come to you just quickly following up. So the request that was submitted to CMS, it sounds like that is provider facing. It wouldn't meet the needs of the dashboard called for in this legislation. But what is the timeline for that provider dashboard?
I don't know off the top of my head. Usually these things take at least a year or so, but I will follow up and get that detail for you, sir.
And that is, I'm assuming, a dashboard that you all are absorbing. In other words, you're paying for?
The local funds, yes. So we can get, it's utilizing the Health Information Exchange for the district, CRISP-DC, and we do support that through a mix of local and federal funding through Medicaid.
If there was a world where, and Deputy Mayor Attorney, it's good to see you. Okay, you can't hear me. And this may be a question for you. If there was a world where funding was allocated for this type of dashboard, assuming you can't absorb it, the legislation calls for this office, your office, to manage this type of dashboard system. What team might be responsible for that, or where might that live within the Deputy Mayor's office?
You know, we presently do. First of all, let me say I think the dashboard is a great idea.
I didn't hear you.
Let me say at the outset that I think the idea of this dashboard is a very good idea, a great idea. It is no right-thinking administrator would you know, have a problem with a vehicle that stands to increase transparency of available resources in the community and make it efficient for persons who need those resources or people acting on their behalf to access that benefit. There are a number of issues that we would have to contend with, and as always, even with great ideas, that sometimes the devil is in the details. There are design issues. You all want this to be in real time, which would considerably separate it from what we have in place now. So if I understand what you all are asking for, would be at any time of day or night, somebody could get onto this dashboard and see precisely at that moment what beds are available across the city. That will take some expert business intelligence work. We don't have such a person in our office. There may be, you know, as I think about this, we may consider partnering with some of the agencies that would be involved or would have some impact on this, and sort of piggybacking on existing resources, and maybe hiring, you know, one or two IT specialists to both design and then maintain the system or the dashboard once it was put in place. So that's something that we would have to consider. And I also think, and a lot of the witnesses touched on this earlier today, we need to have a clear indication on the design front in terms of what the community expects to see when they log onto this dashboard. So that will require, and that's something we can handle at a program level, outreach to the stakeholders and the community about what it is that would be most useful to you if you logged onto this dashboard anytime, day or night, seeking information on beds. What information do you need? And if from that we can work with our business IT folks to build a system that addresses the kinds of needs that you all have identified.
Yeah, no, I think that's exactly right. And I'm actually glad to hear you say that. I welcome the opportunity to work with Councilmember Henderson and you all to get the ball rolling on this. For me, if everybody thinks this is a good idea, we shouldn't have to wait to next October for funds to become available to make this type of thing exist. And while maybe funding is necessary to make a real-in-time dashboard possible, even if we could have a blueprint or begin having conversations with Octo now and moving that way, I think that would be welcome news.
Yeah, I think that's very possible. I think what we would probably need to do in one step before going to Octo is have Dr. Bazran and Director Byrd, convene some of the stakeholders and some of the residents around a potential sort of pragmatic design of this dashboard. And then once we have some comfort that we understand what the community expects, then we can go to Octo and say, hey, look, we want to do this. We wanted just to have this functionality. Tell us the technical requirements. And then we can start looking at what additionally will cost, if anything. Can we piggyback on the existing IT resources in the agencies in the HHS cluster, or do we need to bring in an additional person to oversee the entire project? Those are the kind of things that can come after we do those first two steps.
Yep. Okay. Dr. Bazran, I will follow up and see if we can get the ball rolling on that. You've been a great partner thus far, and so we're going to just add more to the docket.
I look forward to it. I think
Yes.
that this is really, a great tool. That
Yes.
really helps families.
I imagine there is much more to talk about with the other legislations. So it seems like we're more aligned here. I can yield back time, Councilmember Henderson, so we can move on to the next piece.
Thank you, Councilmember Parker. I just want to ask another question in terms of this bill from a process standpoint. Director Turnage, I like the idea of there being sort of conversations with users around what they want to see and desire before you have a conversation with Octo. But from a process standpoint, I can't move this legislation forward because at some point, the CFO is going to ask for a fiscal impact statement. And then when they ask your agencies, how much is this going to cost, before you all even have a conversation with Octo, I'm going to get, we need 5 FTEs and $6 million. So, I mean, how would you suggest sort of moving forward here? Again, I feel like if everybody is aligned, I don't necessarily think that legislation is necessary for you all to begin these conversations. Would you agree with that?
I would agree. I think you can hold us accountable for what we just described in this public testimony, and that is a commitment to work first with the existing resources that are out there to see what this dashboard could possibly look like, and then take those ideas to the residents and stakeholders to see what additional they would, what additional bells and whistles this dashboard could have. And then once we do that, talk to Octo, talk to the IT experts in different agencies. We have some here at DHCF, and then submit a document that lays out, how we would propose that this be done sooner rather than later.
Okay, that sounds good. I will also just say for the record too, this isn't sort of a novel concept per se. I think the only novel piece is that it's public facing, but FIMS clearly has a beds dashboard for all of the emergency rooms in the city, right? So they know how many beds are open or full at any given time, and they can make adjustments in terms of how they discharge ambulances to ERs. So there is precedent for this. The question is, on the public facing side, what information do people really need? Yeah. And some might say a parent doesn't actually need to know how many beds are available. They just need to know, are you taking new patients or not, right? It could be a different thing versus the level of information that perhaps a provider who is either trying to coordinate care for a discharge or to make a referral for outpatient services might need. So
No,
All right.
I agree. And I think one of the first things that we will do, I had forgotten about the FIMS system that is very good, is that we could sit down with the chief and his team to get a sense for what was involved and them getting that up and running. And I would also ask the question about how it's managed on a daily basis and what the cost is. So there are a number of things that we can do before we get to the point of needing a fiscal impact statement to move something forward. But you have my word that we will not allow this to go dormant because there is no legislation behind it.
Okay. So, Councilmember Parker, if it's okay with you, we could follow up with the three directors here in the fall to kind of see where they are on this.
We will have a lot of progress by the fall.
Okay.
Yep.
Is that okay, Councilmember Parker? Yeah.
That sounds great.
Okay, cool. All right. Okay, so we'll go on to the government witnesses for the next piece of legislation. I don't think that includes Director Bird. She was like, nope, not me. And
Councilmember, I have
and I don't think it includes you either, Director Turnage.
no, it doesn't. These are all experts on a very, very important issue of which I am not one. But Dr. Bazron will be here, and she is much more capable than I in addressing this really complex and important subject.
Okay. All right. Well, for the remainder of our government witnesses, if you could raise your right hand. I don't think I swore you guys in. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia is the truth, the whole truth, and nothing but the truth?
Yes.
Yes.
Great. All right. We are going to start with Mr. Pace from OAG.
Good afternoon, Chairperson Henderson and council members. I am Gregory Pace, Assistant Chief of the Mental Health Section in the Public Safety Division of the Office of the Attorney General. I'm grateful for the opportunity to testify today on B25-0692, the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. With me today to assist in answering questions is Matthew Dobson, who serves as an Assistant Attorney General in the Mental Health Section. OAG's Mental Health Section has a unique vantage point of the district's mental health system. As legal counsel to the Department of Behavioral Health in the areas of emergency psychiatric treatment, civil commitment, guardianship proceedings, and extreme risk protection order matters, our team understands how existing law intersects with delivery of mental health services. We routinely interface with stakeholders in the mental health system. This includes the clinicians and law enforcement personnel who initiate involuntary hospitalizations, the psychiatrists and psychologists who provide care, the outpatient providers who contract with the department, and district residents who contact our office seeking help in navigating the mental health system. Unfortunately, in recent years, we have seen an uptick in the number of district residents who are in need of emergency mental health treatment, with many requiring inpatient emergency hospitalization. In 2022, our mental health section filed 2,493 petitions for emergency hospitalization on behalf of the Department of Behavioral Health. By 2023, that number had grown to more than 2,900, and we are on track to see a similar or greater number this year. This marked increase in mental health system involved residents has underscored the deficiencies in our antiquated statutes. It is time for us to modernize our laws to better serve our community. We support Chairperson Henderson's bill and are proposing additional changes which are informed by our day-to-day experience with this statute. For several years, OAG's mental health section has had an active committee tasked with exploring and drafting proposed amendments to the Urban Act, which governs the civil commitment process in the district. We believe the proposals that we've arrived at align with Chairperson Henderson's goals and reflect input from the department, district providers, and family. We have previewed our proposed changes with Councilmember Henderson's office and sent our proposed legislative language and red line to her office yesterday. We are happy to have further discussions with council staff. Our proposals are drafted with three goals in mind. Number one, to make process improvements that will reduce risk of harm to individuals under treatment and to the public. Number two, to eliminate statutory ambiguity that can lead to longer involuntary hospitalization or premature and unsafe discharges. And number three, to facilitate faster delivery of services and hospital placements by expanding the pool of healthcare professionals authorized to complete required documentation. The Irvin Act needs to be updated to address outdated processes and procedures that threaten to disrupt patient treatment. Courts frequently require in-person hearings. This results in disruption of clinical treatment as potentially vulnerable or unstable patients are removed from a clinical setting to a public building. Our proposed amendments will allow virtual hearings to mitigate this risk to health and safety and allow patients to receive the maximal benefit of acute hospital-based therapies. Additionally, reducing the amount of time that doctors are called away from patients to travel to court appearances reduces the burden on DC's overtaxed hospitals and allows more time for patient care. The current statute also mandates a form of service that is inefficient and inappropriate for persons involved in the mental health system who are also unhoused. Codifying the department's ability to serve a patient with their legal documents in person rather than by registered mail would help ensure patients receive notice of their legal proceedings much more quickly and efficiently. Additionally, registered mail is an antiquated form of service that involves unnecessary costs to district taxpayers. The changes in the bill seek to modernize and streamline the notice process and will result in cost savings for the district. These and other proposals submitted by OAG update process under the Irvin Act in ways that enhance patient well-being and deploy district resources more efficiently. Second, OAG aims to bring needed clarity to the Irvin Act on critical issues that impact the length of involuntary hospitalization and patient readiness for discharge. One of the fundamental elements of the Irvin Act is the protection of an individual's right to a brief and time-limited period of involuntary hospitalization prior to judicial review. However, ambiguity in how the statute is drafted can frustrate that purpose. For example, the law currently does not clearly establish when psychiatric admission as opposed to medical admission begins for purposes of triggering the timing protections set forth in the Irvin Act that limit the length of an involuntary stay. In many of these cases, the patient's formal psychiatric admission was delayed due to an unnecessary medical evaluation and/or the need for emergency medical treatment, potentially extending the length of the involuntary stay. Confusion around when the clock starts running could lead to longer periods of emergency and involuntary hospitalization. Conversely, this ambiguity has led to court orders for the immediate release of psychiatric patients whose doctors believe pose a danger to self and others when those patients had first received emergency non-psychiatric treatment. By clearly defining when the period of emergency psychiatric observation and diagnosis begins, as the proposed amendments do, we can establish clear parameters for district emergency departments while preserving a patient's right to the timing provisions of the Irvin Act. Additionally, OAG's proposals reflect efforts to modernize language where necessary, including degendering references to professionals and patients, as well as updating agency titles to reflect current names. OAG endorses Councilmember Henderson's proposal to expand the pool of professionals authorized to author certain documents under the statute to include advanced practice registered nurses, otherwise known as APRNs. The district has limited mental health resources that are often stretched beyond capacity to serve patient need, and adding more qualified professionals would expedite patient processing. OAG has collaborated with APRNs in its work for the district and recognizes their utilities in the mental health field. APRNs are well positioned to support the district psychiatrists and psychologists, facilitating more timely delivery of outpatient and other mental health services. In conclusion, OAG endorses Councilmember Henderson's bill and respectfully proposes additional amendments for the council's consideration. I want to emphasize that these proposals preserve all of the Irvin Act's fundamental patient protections. All consumers, if these changes are adopted, would retain the right to the Act's timing provisions, an attorney, a probable cause hearing, a hearing before the Commission on Mental Health, the right to a trial to challenge the Commission's finding, the right to treatment in the least restrictive setting, and the right to a periodic review of their commitment. I'd like to thank the council for the opportunity to testify, and I look forward to answering any questions.
Thank you so much, Mr. Pace. Ms. Suttenberg? Oh, Ms. Suttenberg, we cannot hear you.
Can you hear me now?
Yes.
Great. Chairwoman Henderson, Councilmember Parker, members of the council. My name is Ilana Suttenberg, and I'm the Special Counsel for Policy and Legislative Affairs at the U.S. Attorney's Office. I'm joined today by my colleague, Jennifer Micah, who is the Pretrial Mental Health Coordinator at USAO, to assist me in answering questions. We thank you for the opportunity to appear at today's public hearing to share the office's views on the proposed legislation. USAO strongly supports Bill 25-0692, the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. This bill will enhance the procedures relating to how the civil and criminal systems address the treatment and commitment of people with mental illnesses when they are dangerous because of that mental illness. This bill will streamline processes and provide more tools to treatment providers and the courts, both to address a person's mental illness and to protect the community. This bill is a crucial tool that will help to address the overlap between mental health, civil commitment processes, and criminal justice. USAO is committed to addressing mental health issues that intersect with the criminal justice system, with the dual goals of connecting people with mental health treatment and protecting the community. Our office participates in a robust mental health community court within DC Superior Court, where we divert certain individuals charged with certain low-level crimes away from the traditional criminal justice process with the goal of addressing their mental health issues and reducing recidivism. We support pre-arrest diversion, and we're pleased that the recently enacted Secure DC Act created a pre-arrest diversion task force to spearhead pre-arrest diversion in the district. Our office, led by Pretrial Mental Health Coordinator Jen Micah, is an active participant with the CJCC's Substance Abuse Treatment and Mental Health Services Integration Task Force. Ms. Micah also has served as part of the district's delegation to the federal SAMHSA's Policy Academy on Competence and continues to collaborate with both Superior Court and DBH to improve the processes for addressing mental health in the criminal justice system. In addition to the changes proposed by this bill, we support other changes to several key statutes related to people with mental illnesses who present a danger to themselves or others. We've worked closely with OAG to develop jointly proposed additional changes to these statutes that are aligned with the goals of this bill and that will further enhance the processes in these situations. We have also consulted with DBH in developing these proposed changes. We look forward to collaborating with the committee on this bill and additional related changes. As background, there are several key sets of statutes in the DC Code that relate to people with mental illnesses who present a danger, with differing government agencies responsible for addressing those issues. First, DC Code 21-551 and following statutes relates to emergency hospitalization of people who are believed to have a mental illness and because of that illness are likely to injure self or others, commonly referred to as FD12. Several groups of people are permitted under this statute to take a person into custody, transport them to a hospital, and apply for their hospital admission for purposes of emergency observation and diagnosis, which we've discussed today. OAG is responsible for addressing and as appropriate litigating whether a person remains hospitalized under this emergency hospitalization authority. Second, DC Code 21-541 and statutes that follow relates to civil commitment of people who are mentally ill and because of that illness are likely to injure self or others if not committed, commonly referred to as Irvin Act. This is a non-criminal process whereby the Commission on Mental Health makes a recommendation about civil commitment, and if the commission recommends civil commitment, also recommends whether it should be on an inpatient or outpatient basis in line with the least restrictive alternative consistent with the best interests of the person and the public. A civil commitment order lasts for 1 year but can be renewed annually. OAG is also responsible for addressing and as appropriate litigating whether a person should be civilly committed. Third, DC Code 24-531.01 and the statutes that follow relates to the evaluation and treatment of criminal defendants whose competency to stand trial is called into question. In its current form, this process was created by the Incompetent Defendants Criminal Commitment Act of 2004, known as the IDCCA. A criminal defendant is competent to stand trial when they have a sufficient present ability to consult with their lawyer with a reasonable degree of rational understanding and have a rational as well as a factual understanding of the proceedings against them. A court may hold hearings and order evaluations conducted by DBH to determine whether or not a defendant is competent to stand trial, and if they are not competent to stand trial, whether they are likely to attain competence in the foreseeable future. A court may also order a defendant to participate in competency restoration efforts on either an inpatient basis at St. Elizabeth's Hospital or on an outpatient basis at either the DC Department of Corrections or in the community in programs developed and run by DBH. This process is based on the requirements of a number of Supreme Court cases stemming from the Supreme Court's decision in Jackson v. Indiana in 1972. When there's a question as to whether a person charged in a criminal case prosecuted by USAO is mentally competent to stand trial, USAO is responsible for addressing and as appropriate litigating whether or not a person is competent to stand trial. A person charged in a criminal case also may be civilly committed, and USAO works closely with OAG, who handles any related civil commitment process. Civil commitment may proceed before, concurrently with, or after the criminal case, and the IDCCA sets out how the criminal competency proceedings relate to civil commitment proceedings. Given that USAO's role in these processes primarily relates to the IDCCA, we will focus our testimony on the IDCCA provisions in this bill and in our additional set of proposed changes. We appreciate the bill's desire to improve the transition from civil commitment to civil commitment from criminal cases. In addition, there are several other issues with the IDCCA that we propose remedying. First, there's a lack of clarity in several definitions in the IDCCA. We propose several definitions that are consistent with national case law and other DC laws and regulations. Second, the final drafting of the IDCCA inadvertently created ambiguity about the burden of proof for competence and restoration. We propose clarifying that the burden of proof remains with the party asserting incompetence and/or unrestorability. Third, there is a lack of clear guidance in the IDCCA as to the process when DBH is unable to provide an opinion about competence and/or restoration. We propose new language permitting a judge to order an additional period of treatment for clinicians to form and provide such an opinion. Fourth, there's a lack of clear guidance in the IDCCA on a judge's authority to keep a criminal defendant at St. Elizabeth's Hospital after being found competent to proceed to trial. We propose new language permitting a judge to place a criminal defendant at St. Elizabeth's Hospital if recommended by DBH. Fifth, the IDCCA's articulation of the transition from criminal proceedings to civil commitment proceedings and the standard for keeping a criminal defendant at St. Elizabeth's during this transition requires additional clarity after the DC Court of Appeals decision in 2023 in Payton v. United States. We propose new language articulating the standard for determining whether a criminal defendant should remain at St. Elizabeth's, both pending a determination about civil commitment and between when a petition is filed and a hearing is held before the commission. In addition, we propose new language establishing a rebuttable presumption in favor of continued admission at St. Elizabeth's for criminal defendants charged with certain dangerous or violent crimes, new language giving a judge explicit authority to order a criminal defendant to attend civil commitment evaluations, and new language ensuring the parties in the criminal case receive updates under seal on the civil commitment case. Sixth, there's no guidance in the IDCCA on access to records essential to litigating contested issues of competence and/or restoration in the criminal case. We propose new language providing both parties in the criminal case access to DBH records for criminal defendants undergoing competence evaluations or restoration treatment. Seventh, the IDCCA's dismissal provision is inconsistent with the time permitted for outpatient competency restoration. We propose reconciling the two inconsistent provisions. We appreciate the Council's commitment to addressing the intersection of mental health and public safety with the goals of treating people who are suffering from mental illnesses while protecting the community. We look forward to continuing to work with this committee and the Council on our shared goals of ensuring that the statutes governing both the civil processes and criminal processes are enhanced to better accomplish these goals. We thank you for your time, and we'd be happy to answer any questions.
Thank you, Ms. Suttenberg. Ms. Simonova?
Good afternoon. I'm Katerina Semyonovich, Special Counsel to the Director on Policy and Legislation at the Public Defender Service. Kimberly Clark, Chief of PDS's Mental Health Division, and Lucas Barnicow, longtime attorney in the Mental Health Division, are with me today to answer questions.
Ms. Semenova, before you continue, is it are you all hearing an echo? I'm not sure if somebody in your room is logged on too.
You're not.
Okay. Okay, you could go ahead.
Is it any better?
Not really.
We are connected to, we could disconnect from that also. Is that better?
Yep, go ahead.
We could disconnect and just do it on the laptop.
Oh, no, whatever you guys just did, you were clearer than you were before.
Thank you. Can I, by way of
Just need to speak up. Just
yes.
be louder.
Okay. By way of background, in addition to representing adults and youth in the criminal and juvenile legal systems.
Okay, hold on. Sorry. We can't hear you. So whatever mic you're using is too far from you. No. Yes. Okay, so we will go to Dr. Bazaran while you guys continue to work on that. Dr. Bazaran?
Oh, good afternoon, I guess, at this point. Chairperson Henderson, committee members, and council staff. I am Dr. Barbara J. Bazaran, Director of the Department of Behavioral Health. With me today, I have Matthew Kaspari, who is our Chief Counsel, as well as our Chief Medical Officer, Dr. Jonathan Shepard, who are available for questions. I want to thank you for the opportunity to discuss Bill 25-0692, the Enhancing Mental Health Crisis Support and Hospitalization Act of 2024. Under the leadership of Mayor Bowser and the guidance of Deputy Mayor Wayne Turnage, DBH supports healthier and stronger communities by working to prevent the onset of mental health and substance use disorders and by providing a range of community-based services and recovery supports for residents of all ages. DBH also provides crisis services, operates an adult and child urgent care clinic, and manages St. Elizabeth's, the district psychiatric hospital. A mental health or substance use crisis can be devastating and have long-term and sometimes tragic consequences for individuals and their loved ones. During the last few years, DBH has focused leadership with investments by Mayor Bowser to strengthen our crisis services with more trained crisis counselors to answer crisis calls. We have expanded our mobile crisis capacity and diversion of certain behavioral health related crisis calls from 911 from an automatic law enforcement response. And we have opened the first DC Stabilization Center. We have received technical support from SAMHSA and the Harvard School of Government as we have made these innovations possible. We continue to partner with certified behavioral health providers to ensure the incorporation of crisis planning and treatment plans to avoid psychiatric crisis episodes and to reduce the severity and duration of these events. Inadequate crisis care can lead to missed opportunities for self-management, treatment and recovery, avoidable emergency department visits, and longer hospital stays. A comprehensive integrated crisis network can offer hope and support sustained recovery. DBH is steadfast in our commitment to protect the rights of individuals to make their own health decisions and to provide care in the safest, least restrictive environment. DBH works to avoid involuntary commitment, as we know it can be a frightening and traumatic experience and discourage continued care. At the same time, we must offer compassionate, high-quality care when people are at their most vulnerable and due to their mental illness are unwilling or unable to seek voluntary treatment. Involuntary commitment, also known as civil commitment or involuntary hospitalization, is the legal process through which individuals with severe mental illness are admitted to a psychiatric hospital or facility for treatment against their will. The law recognizes individual rights by restricting this authority to cases where a clinical judgment is made that an individual is deemed to pose a danger to themselves or others due to their mental illness. The DBH Chief Clinical Officer, Dr. Jonathan Shepard, provides clinical guidance to our crisis services and manages the training of officer agents to ensure they are competent to determine whether an individual meets the criteria for involuntary commitment. The proposed bill supports and strengthens these efforts. As you know, DBH operates the district's emergency crisis facility called CPEP, and all community acute care hospitals are required by law to offer emergency crisis services. The average length of stay at CPEP is 24 hours, and 70% of patients are discharged to treatment with a community-based provider following their stay at CPEP. When a clinical judgment is made that additional involuntary hospitalization is required, the Office of the Attorney General represents DBH, as was said earlier, in involuntary commitment proceedings before the Commission on Mental Health and DC Superior Court Family Court Division to continue stabilization and treatment at a community hospital. DBH contracts with 3 community hospitals, and this includes United Medical Center, the Psychiatric Institute of Washington, and Washington Hospital Center to provide treatment for uninsured and non-DC residents. We've had many conversations with the OAG, the DC Hospital Association, and other partners about improvements in involuntary commitment procedures that will support increased quality of care and better health outcomes. We appreciate that the proposed bill includes many of the changes that we support. In reviewing the requirements of the bill, let me first say, we welcome the addition of advanced practice registered nurses and nurse practitioners to the clinicians who can execute involuntary commitment and petitions for civil commitment. These healthcare professionals have expertise in mental health assessment and are well qualified to initiate involuntary commitment procedures. We support the proposed changes to the administration of probable cause hearings. The current 24-hour requirement often requires community hospitals to transport patients, the staff, and doctors to court with little notice, which can disrupt care to the patient being transported and other patients on the unit. Extending the time to 72 hours and allowing the court the flexibility to continue a hearing or authorizing virtual attendance will minimize disruption to their therapeutic treatment and reduce the potential safety risks to individuals and clinical staff. DBH also supports extending the time for emergency observation and diagnosis from 7 to 15 days. This change gives healthcare professionals more time to conduct thorough observation and diagnostic tests to determine whether civil commitment is clinically necessary. In addition, we support the provision in the bill that allows hospitals to start treatment prior to the formal civil commitment process, as long as principles of informed consent are met. DBH supports the warrant authority to require compliance with treatment when the court has ordered treatment. In these cases, we must be able to support people who are unwilling or unable to seek voluntary treatment and to address the safety and well-being of the community. DBH supports the provision that would allow physicians to involuntarily admit patients to their own facilities. Every day, emergency room doctors admit thousands of patients with emergency medical conditions to the hospitals in which the doctors are employed. However, the district's civil commitment laws contain an outdated provision that prohibits a doctor from admitting a patient with an emergency behavioral health condition to the same hospital. This provision can create unnecessary delays to care, as the emergency room doctors must call the community response team or MPD to travel to the hospital to execute the involuntary commitment. DBH appreciates the opportunity to work with the committee during the summer on additional changes to the law that we believe will further strengthen crisis services within our broader, transformed behavioral health care system. We know that crisis support is for anyone, anywhere, anytime. We are guided by the principles that are the foundation of a solid, mature crisis service system. Someone to talk to, someone to respond, and a place to go. Thank you, Chairperson Henderson, and I look forward to our continued work together to support people with behavioral health disorders to ensure that they live healthier and longer lives.
Thank you, Dr. Bassaran. Ms. Semenova.
My testimony, and we are ready for any questions you may have.
Thank you.
Good afternoon. I'm Katerina Semenova, Special Counsel to the Director on Policy and Legislation at the Public Defender Service. Kimberly Clark, Chief of PDS's Mental Health Division, and Lucas Barnicow, longtime attorney in the Mental Health Division, are with me today to answer questions. By way of background, in addition to representing adults and youth in the criminal and juvenile legal systems, PDS is the only legal services provider that represents individuals facing involuntary hospitalization or commitment in the mental health system and represents hundreds of clients each year. As a result of PDS's deep knowledge of the mental health system and the needs of individuals living with mental illness, PDS is testifying in strong opposition to many portions of this bill that would, without justification, seriously undermine the core protections for individuals with mental illness that have existed under the Urban Act for more than 60 years and thereby cause unnecessary harm to many of the district's most vulnerable residents. The Urban Act safeguards the rights and liberties of individuals who struggle with mental illness but who have not been accused of committing any crime by ensuring that they are not involuntarily detained for lengthy periods of time without meaningful judicial review. Many of the proposals in this bill prioritize the convenience and bottom line of for-profit hospitals over the well-being of patients and the community. The bill would be the first time the Urban Act has been amended to restrict rather than to expand the rights of the mentally ill. It would reverse decades of law and do serious damage to the Act's core protections by vastly expanding the duration of emergency confinement, jettisoning basic due process, and severely restricting individuals' ability to obtain timely and meaningful judicial review. Lengthy involuntary hospitalizations without adequate judicial checks will deter people from accepting voluntary treatment, and it will produce worse clinical outcomes. The legislation will not increase community safety or strengthen treatment. Under existing law, the district can already involuntarily hospitalize individuals for as long as they remain too dangerous to release, whether that be for weeks, days, or even months. The gaps in the district's mental health system exist because of a lack of capacity for quality hospital and community-based services, failures in discharge planning and community follow-up for individuals being discharged from psychiatric hospitalization, and DBH's failure to use and expand housing services. Under existing law, an individual can be FD12, that is taken into custody without a warrant and involuntarily hospitalized if there's reason to believe that they are likely to injure themselves or others due to mental illness if not immediately detained. An individual who is FD12 can be automatically detained for 48 hours without any court involvement. That deadline is extended if it falls on a weekend or holiday, potentially turning 48 hours into 5 days. If the hospital determines the individual needs to be detained beyond the 48-hour period, it must file in Superior Court a written petition authorizing continued detention for emergency observation and diagnosis for a period not to exceed 7 days. The court then reviews the petition without a hearing to determine if probable cause exists. The court must rule on the emergency petition within 24 hours after it is filed. However, that deadline is also extended if it falls on a weekend or holiday. The court nearly always grants emergency petitions. In 2023, emergency petitions and 7-day orders were issued in 99.7% of the nearly 3,000 Urban Act cases that were filed in Superior Court. The proposed legislation would do more than double the initial period of court-ordered detention from 7 to 15 days. And critically, individuals who are detained at the hospital are already there for at least 3 to 5 days before the 7-day period even begins. Any extension of these detention periods is extremely worrisome because the individuals are detained in untherapeutic, chaotic, dangerous facilities that often worsen clinical outcomes in the short term and deter individuals from seeking treatment voluntarily in the long term. The most troubling of these facilities, PIW, takes far more involuntary hospitalized individuals than any other facility. Multiple investigations by DRDC have found that PIW patients are exposed to sexual and physical abuse, serious injuries, and in addition to feeling unsafe, are left traumatized and distrustful of the mental health system. Moreover, 15 days of involuntary hospitalization, which really amounts to 20 days or more, will result in the loss of jobs and housing and deep disruptions to family and community support, all of which will make long-term outcomes worse. While the proposal to more than double the initial period of detention will be extremely detrimental to patients, it will do nothing to increase community safety or further treatment. Under current law, the hospital already has the authority to continue detaining an individual beyond the 7-day period if it believes that they are dangerous if they are released. A doctor simply fills out a certificate, often a handwritten paragraph opining that the person meets the criteria for civil commitment. The hospital then emails the certificate to OAG, which attaches a petition for commitment and files it with the court. These petitions are not reviewed by the court, and they extend the detention authority until a hearing before the Commission on Mental Health. The proposed legislation would also change probable cause hearings and negatively impact the due process rights of patients. Under current law, at any time after the court issues a 7-day order, the respondent has the right to request a probable cause hearing to challenge the legality of their detention. Unless delayed further by a weekend or holiday, if requested, a PC hearing is held within 24 hours. The proposed legislation would eliminate a respondent's right to be present for their hearing and would require the court to accept virtual testimony by witnesses anytime a party requests to present virtual testimony. These changes appear to be driven by a false narrative about the burden of PC hearings and the claim that they disrupt treatment. In all of 2023, there were 2,905 FD12 cases. Out of those 905 individuals who were involuntarily hospitalized in FD12 cases, only 277 people requested PC hearings. In 250 of those 277 cases where PC hearing was requested, OAG filed a notice of intent not to proceed, meaning it chose not to go forward with the hearing. In such cases, a respondent is then entitled to be released from the hospital, or they may choose to remain there on a voluntary basis. Thus, in all of 2023, there were only 27 PC hearings held. Respondents can already elect between a virtual hearing and an in-person hearing, and only 8 people in all of 2023 elected to have an in-person hearing. This amounts to a minuscule burden on Superior Court, hospitals, and on the treatment needs of individuals. Nonetheless, this legislation would strip this small group of individuals who are suffering from mental illness, who are involuntarily hospitalized and requesting a hearing, of the fundamental right to appear in person at their hearing. For the limited number of respondents, that right is critical. Appearing in court legitimizes and engenders respect for the judicial process, alleviates distrust of the system, and allows people to feel their grievances have been heard. PDS has had countless clients over the years who've been very upset about their involuntary detention, have demanded a PC hearing, have lost that hearing, but have nonetheless then felt as though they've had their day in court, been fairly treated, and been heard, allowing them to return to the hospital and begin focusing on their treatment. Some mentally ill individuals are particularly distrustful of technology, especially video technology, and therefore may have very negative feelings about proceeding only by video. Finally, the potential risk to safety referenced in the proposed legislation is not a reason to deny individuals of the right to appear at hearings. Currently, hospitals transport patients to court using Uber. Hospitals have the flexibility to use ambulances, soft restraints, and additional personnel. They can also bill DBH $650 for each person transported to court. The solution cannot be denying this small group of individuals the right to appear in court. The bill would also require the court to admit virtual testimony by witnesses. Again, there's no other context in which judicial discretion is removed in this manner, and the right of the individual to see the witness against them is abolished. In-person appearance by witnesses in the limited number of in-person hearings is essential to evaluating credibility and to cross-examination. Currently, a party must seek judicial authorization to present virtual testimony, and the court evaluates whether there is good cause to do so. In multiple cases in the last 2 years, the court has permitted virtual testimony, for example, because of staff shortages or other important meetings. Automatic virtual testimony should not be mandated by the council in all instances. The council has not forced these same limitations on due process in other civil cases, and it should not do so now. The proposed legislation also amends the timing of PC hearings, requiring a hearing within 72 hours instead of 24. Again, given the minuscule number of hearings, the important rights at stake, and the fact that parties have managed this burden for more than 60 years, there's no reason for the council to mandate this change. The legislation also allows the use of arrest warrants for individuals struggling with mental illness if they fail to appear for any hearing. This is an inappropriate expansion of current law and would criminalize individuals with mental illness. Under current law, respondents are only compelled to attend their examination by commissioned doctors prior to a commission hearing. If an individual fails to appear, the commission will issue a writ of attachment. These processes already exist and function. The rarity of the use of writs of attachment shows that there is no need for the proposed legislation. The court did not issue a single writ of attachment in any of the 2,905 FD cases that were filed in 2013. The proposed amendments would also allow the use of arrest warrants when a respondent fails to appear. Again, the Urban Act provides a mechanism for addressing it, and these changes are not necessary as shown by the rarity of their use. Finally, the bill also proposes changes to the competency process that inappropriately limit the ability of judges to make individualized decisions based on the complex facts before them. Under current law, when an individual is found incompetent to stand trial in a criminal matter, the court must release the individual or, when appropriate, can order treatment for up to 30 days. The bill would require that treatment be mandated for not less than 15 days, essentially creating a mandatory minimum period of treatment. Judges do routinely order 30 days of treatment, but judges should maintain the flexibility rather than having a mandated standard by the council. Finally, our testimony does not address, nor did any of the public witnesses' testimony address, the deep changes to separate statutes that were proposed and shared by the USAO for the first time this morning. Thank you for the opportunity to testify, and we welcome any questions.
Thank you again to all of the witnesses. This, I think, I don't want to diminish anything that we have discussed so far today, but of course, I think this bill is probably the meatier of some of the other bills that we talked about. So I'm going to walk through some questions about things. Let me start on the virtual hearing portion. So this is kind of an interesting situation where, I have PIW, I have the hospitals who are saying, yes, virtual would allow for, to give us some flexibility here. I have the attorneys saying, yes, virtual allow for some flexibility. And then I have PDS saying that's not really necessary because so few people are doing virtual. How do I sort of reconcile the two? I don't know if OAG or USAO, you want to speak to this?
Thank you for the question, Chairperson Henderson. We would emphasize that your proposed change to the probable cause statute does not mandate a shift to virtual hearings at the exclusion of in-person hearings. It gives the court discretion and suggests that the court should prioritize the use of virtual technology. Since COVID, our office has conducted probably the majority of its hearings via the court's WebEx technology. The district has implemented access centers, so folks who may not have access to the technology could get to a place where they could participate in proceedings. And I think since COVID, we've seen the technology stress tested. The clinicians and the behavioral health techs who have to set up the connection by the patient, all these parties are getting more familiar and more comfortable with the use of the technology. It's reliable. We're conducting this important business through similar technology today. And we also support the reasoning that we heard from other parties with regard to not taking doctors off the units of these hospitals that care for so many vulnerable people in the district.
Okay. So for PDS, are you opposed to the prioritization of virtual? It doesn't require virtual. It just says prioritize.
I mean, I guess it depends on really what that means. But I think the bigger point is that, as we pointed out, in all of 2023, there were only 8 in-person hearings that went forward. And so the idea that this creates a big burden is just not true. It's 8 in 1 year. But for those folks who do request an in-person hearing, it can be incredibly important. It can be incredibly important for them to be able to come to the courthouse and feel like they've had their day in court and been heard. And I think another important point that was included in our written testimony, at least, was that these would be the only litigants in any type of case in all of Superior Court who do not have an automatic right to come to the courthouse to have their case heard. I mean, again, since it's such a small number, this is an incredibly small burden to the hospital, to the courts, to the government, attorneys, everybody.
Okay. The legislation proposed to broaden the pool of individuals authorized to initiate involuntary commitment process, including or incorporating psychiatric mental health nurse practitioners who are recognized for their expertise in this area. I didn't, and correct me if I'm wrong, I did not hear any opposition from any of the agencies on this.
Speaking for PDS, no, we do not oppose that. I think we actually support it. I think that's a good idea. I think the nurse practitioners are certainly well qualified to do that. I do agree with the testimony. I believe it was from Michelle May, who pointed out that there should at least be some training in the process. So we would support, an amendment to include some type of requirement for training, but certainly we do support expanding the pool to allow them to do that.
Okay. Dr. Bazaran, are there any other professionals who we feel like should be authorized to initiate this process or should be taken out of the list of pool of individuals who should be authorized to initiate this process?
No, and I'll also turn to Dr. Shepard, who runs the training program. We do support having the advanced practice nurses included in this process. And currently other professionals who go through the training, LACSWs and so forth, are able to do FD12s. Dr. Shepard.
Hey, good afternoon, everyone. I support what Dr. Bazaran just said. There are no additional persons that I would recommend at this time.
Okay. The Treatment Advocacy Center, which is a national organization advocating for reform on how society serves people with severe mental illness, issued a report card on involuntary commitment laws for all 50 states, including the district. DC received an F. We're not the only ones. Don't worry. But one of their recommendations is that the district amend the code to allow any authorized adult to petition for an emergency evaluation. What are your thoughts on this broad authority? I'm not saying we are. I'm just asking your opinion.
You cut out a little bit. Could you repeat that?
Oh, sure. The Treatment Advocacy Center, which is a national organization advocating for the reform of how society serves people with severe mental illness.
And anybody.
No. Can you guys hear me? Okay. Sorry. They issued a report card on involuntary commitment laws for all 50 states, including DC. And we received an F. And one of their recommendations was that we broaden the pool for who can petition for emergency evaluation. I was wondering what your thoughts were on that. recommendation. Not that we just we're curious.
I go back to what Michelle May and others have said. I think that, training is required to ensure that process is handled appropriately and clinically appropriately. And so I would personally not be in favor to just anybody just being able to do that process. And I also do think that the training is needed. Dr. Shepherd, I don't know if you have anything to add to that.
No, nothing else I would add.
Okay. All right, just making notes for myself here. Okay, so I think the biggest source of conversation and back and forth was around the extended observation period. But perhaps let's start with something. So Mr. Pace, when you testified, you talked about there being some confusion around like when the timeline or when the clock actually starts in terms of an observation period. And it made me think of the testimony from Dr. Robb from Children's National and the example that she gave. And I'm not sure if you were on at that time, but basically she said, let's say, for instance, they have a juvenile patient who comes into the ER with a Tylenol overdose. They are treating the young person for that in terms of, pumping the stomach, et cetera, and getting that young person stable. But then they also believe that the young person needs to be treated for the underlying depression that led to them ingesting all of the Tylenol, et cetera. In terms of the clock for evaluation, did the clock for evaluation start when the young person entered the emergency room for the Tylenol? Or does the clock for evaluation start when a physician now says we want to do an assessment in terms of the mental health?
Councilmember Henderson, one thing I think is important for me to clarify before addressing your question is that our office does not currently have an arrangement with the Department of Behavioral Health to represent their agency in juvenile cases. So unfortunately, I wouldn't be able to address your specific scenario regarding the scenario brought up in earlier testimony. I can, however, speak to an analogous scenario regarding how the court might interpret admission if the patient was an adult. And I think I'm going to turn to Mr. Dobson to kind of flesh that out a little more.
Similar components, but yes, let's say the patient is an adult versus a child. When would the clock actually start in that scenario?
I think that's a key piece of the additional proposals that OAG submitted. We've had some rulings from the trial court that suggest that time has shifted in recent years. So OAG's standing guidance to clinicians was that the clock started when you were admitted to the psychiatric unit, when a psychiatrist or your physician said, it's time for you to go over to the psych ward, or let's transport you over to PIW because they're better equipped to handle your unique psychiatric needs. The rulings that I'm referring to, I believe from 2020 and 21, shifted that starting gun, so to speak, and said, hey, if your medical treatment has features of psychiatric treatment, we will start the clock then. And in one of the rulings, the judge said that it's really difficult to tell and it will be a case-by-case analysis. That's made it difficult for OAG to give guidance to area emergency departments, to department clinicians. And that's why we propose starting that 48-hour window at a reliable, defined place, which the law currently does not do. We recommend starting it when your physician has triaged your medical needs, ruled them out as part of your psychiatric presentation, and then makes the order for your admission to the psych ward or to another facility that can treat your psych symptoms.
Okay. I'm over my time, but I want to just sort of wrap on this for a little bit longer, Councilmember Parker, if you would allow. That's not currently in the law as drafted. So this is a recommendation from OAG that this be included. I was curious if USAO, PDS, or DBH have a response to this.
So from PDS, Mr. Dobson's correct that right now it's essentially a fact-based inquiry that the court makes. The parties make arguments about when exactly that 48-hour clock started ticking. I think that our position is probably tentatively that it may not be a bad idea to include some clarification in the law. It depends on what there was, and we haven't seen the language that OAG has proposed.
Okay.
And from USAO's perspective, we defer to OAG on this because they typically handle these situations, but we do support their proposal.
Okay. Dr. Bazaran or Dr. Shepard? Anyone from DBH?
No.
Okay. All right. Councilmember Parker?
Yeah.
Thank you all.
We do, I mean, it sounds like a great idea to look at it. Something to look at.
We'll have to see the language, obviously, but okay. Councilmember Parker?
I think I heard Dr. Bazaran say they don't want to make legal
No.
determinations.
That's
I heard it loud and clear. Mr. Pace, I wanted to come back to you on that same question just very quickly. It seems clear why we would want a clearly defined time period for that 48-hour window to begin. If we were to take your recommendation, couldn't it be argued that that triage period by the doctor could be any amount of time, or that window is undefined? And so for a doctor to make the determination, whether that is within hours, days, how do we put parameters there if we are only to start the clock for 48 hours once the determination has been made?
We've tried to build in some clarity around this issue, and I understand that we plan to circulate the language. I think that OAG would agree that there has to be some limit on the time, right? We can't dress up a psychiatric admission as purely medical. That would not be credible. But as Council Member Henderson's scenario outlines, a lot of folks who come in for these interventions do have underlying medical needs, and sometimes they don't move on a legal timeline. And so it's difficult to assign a specific period of time, because an ingestion case, and we're not clinicians, we'd have to defer to subject matter experts on specific medical interventions, but not all are equal. So if someone had a superficial attempt at cutting or ending their life that could be treated relatively quickly, that person could be ordered to a psych ward much more quickly than someone who, say, ingested a medication that was causing significant internal injuries. So it's very difficult, not being a clinician, to assign a time frame, but I appreciate the spirit of the question.
Thank you. I wanted to come to PDS. There was concern or pushback on the clause that would allow warrants to be issued for non-compliance or individuals that did not show up for court appearances. If we were not to enforce there, what might be an alternative that you all would put forward, since you seem to push back here?
There is already a mechanism for the court to issue a writ of attachment to bring someone before the commission for evaluation. As the statute is written, the only compulsory meeting that the respondent is required to attend is that meeting for the commission where they meet with the doctors. And when necessary, the commission has exercised its authority to issue a writ of attachment that would order the marshals to go and bring the person before the commission. The rest of the statute does not compel a respondent to appear, and there are ways to effectuate a civil commitment if someone was in that posture without issuing a warrant for their return. Similarly, if someone is outpatient committed, there is a full section of the statute, 21-548, that concerns how you bring someone back to the hospital if they have decompensated. And so the OAG is well aware of the procedure. They file those notices of rehospitalization when someone meets the standard to be rehospitalized. council is notified. And so there is a judicial proceeding if someone is outpatient committed and they deteriorate and need to be re-hospitalized. There's no need to issue a warrant for that person, and it would only criminalize their mental illness. And so we want to avoid that, because having these arrest warrants and subjecting people who are in mental health crises to law enforcement involvement only further stigmatizes mental health, and it makes people more wary of consenting to voluntary treatment, which is one of the highlights of the Irvin Act, to encourage voluntary treatment. And the statute is already well equipped to deal with people who have decompensated.
Thank you for that. Dr. Basran, I wanted to come to you. I'm going to ask you about recidivism. That came up earlier. I imagine you may not have those numbers at your fingertips, so I'm kind of giving you a heads up. I'm going to ask another question and come back. Around recidivism, it was flagged earlier. I think Ms. May brought up that the importance of getting this right on the first time is that we might be able to cut down on the high levels of recidivism that we're seeing across the district. And my question is, what are the levels of recidivism that we're seeing in the district? While your team probably, or do you know that off the top of your head?
No, I don't have that data off the top of my head, but I do agree with what Ms. May said in terms of the fact that original write-up really is the beginning of the treatment process, and the degree to which we can really do that well will make a difference.
Well, if somebody there could pull those numbers, I'm going to ask another question about training. So this legislation would enforce or compel DBH to produce these virtual learning modules. I will tell you, I'm skeptical, not that I don't have faith in DBH, but I'm just skeptical about the quality of virtual modules and how we enforce and ensure quality around that training. Part of the feedback that we heard from some of the medical professionals on a previous panel is that those modules should be interactive or hybrid of sorts.
Right.
What criteria does DBH use to create any type of learning module, and what might you use to create these types of learning materials?
Well, first of all, this particular training, and certainly Dr. Shepherd can speak to it, is in person. And there's some reasons for that. Because you're looking at scenarios, because you're really helping people to develop practice skills. And it's
but the legislation would require online training materials. So would you push back on that and suggest that it be in person or interactive, as we heard before?
Yes, I would.
Okay.
And we have some data that might be helpful that I was just given, and that is in terms of the number of individuals with 3 or more FD12s. And FY 23 was 364, and year to date it's 159. And those are people who, we saw multiple times.
And I'm sorry, you said 364. What year was that?
FY 23, fiscal year 23.
FY 23. Love it. Love it. Shout out to your team, because that was pretty quick for them to pull that. I wanted to come to the USAO. I missed a part of your testimony as I'm jumping back and forth, but what cautions might you give us as we're just thinking about the system as a whole? And I'll ask the Attorney General's team a similar question, but I'll start with the USAO.
Sure. So broadly, we support this bill. We also have, just to quickly recap, we have some additional proposed changes that we think are in line with this bill, and that particularly go to the part of the statute that we interface with the most, the incompetent criminal defendant, IDCCA. But I will turn to my colleague, Jen Micah, who really is our subject matter expert in this area, for any thoughts she might have.
I would just echo what we've heard from a number of other public witnesses, that we have seen a large increase in the number of people with serious mental illnesses that are not only interfacing with the civil commitment process, but also with the criminal justice system. And we are not unique in that regard. That's something that we're seeing nationally. And what we have aimed to do in our revisions, and we would encourage the council to consider, is that it's important to resolve the fundamental issues of, eliminate the inefficiencies and to clarify things in the statutes to ensure that we can get to the root of the issue, the root of the question, which is either, is somebody a danger to self or others, or in a criminal case, whether somebody is competent to stand trial. And so we think that the revisions that are proposed help address those other ancillary issues so that we can get to the heart of the issue and get directly to those questions, and then either address somebody's need for mental health treatment or their need to move forward in the criminal justice system.
Thank you for that. And then the Attorney General's team.
Thank you, Council Member. Just briefly, I would add, because it does seem that there's been this sort of running narrative throughout today's hearings that the new legislation would automatically extend the time of initial detention for a respondent or an individual brought in on an emergency hospitalization to 15 days. And that's simply not the case. The language, as we've read it, is that the initial order ordering the emergency detention would be issued for up to 15 days. And there is already a built-in protection in the statute under DC Code 21528 that compels the Department of Behavioral Health and the clinicians who are treating these individuals who are hospitalized to immediately release them from their detention or sign them in as voluntary patients if there's a determination made that they are no longer likely to injure self or others if they are detained. And we believe that, although this may be a discussion for later in the summer, but we do believe, based on information we've received from the Department of Behavioral Health, that this will in fact result in less petitions for one-year commitment being filed, because we've heard time and time again from the clinicians that we work with that if they only had a few more days than the initial 7 days, that there would be no need to file a petition for a commitment. So I do think it's important to emphasize that point.
Thank you. That is a great point to end on. I'm over time. Thank you, Councilmember Henderson.
Thank you, Councilmember Parker. Dr. Bazran, I just want to go back to you really quickly because you rattled off some numbers fairly quickly and I was trying to write them down. Councilmember Parker had asked you about recidivism. And then I hear...
I can repeat those, Council Member.
That'd be great.
Okay, and so this was the number of individuals with 3 or more FD12s, which means that there was a repeat process.
Okay.
In FY23, there were 364 individuals. In FY24 year to date, there's 159. And I really, do want to note that less than 5% of the people we serve really experience an emergency petition.
Right. But, I think, to Councilmember Parker's point, as we think about the impact on the community, and some of the cases that we have seen where it's, the same individual over and over. Sure. What then would you all say, like 3 or more FD12s in a year? That's a lot. So what then was the breakdown?
It could be the nature of the person's illness. We do, for example, have assertive community treatment. So there is a team that works with that individual 24/7 and try and keeps up with them. But in some instances, because of the person's illness, they may have times when they decompensate and at that moment need to go into the hospital. Their teams are then contacted immediately and they work with them in terms of not only discharge planning, but also readjusting their treatment plan.
Is there any concern or have there been any complaints raised around overuse of FD12, given that anyone in law enforcement can initiate the process?
I have not heard that.
PDS, USAO, OAG.
I've not heard that, so.
Well, I mean, I do think there are certainly times where people are FD12 and they may not, meet the criteria, or it may not be a case where an FD12 was needed. Another situation we often see is where FD12s were sort of inappropriately used in cases where somebody was actually willing to voluntarily go to the hospital or engage with treatment. But when those cases happen, that is why it is extremely important that when the lawyers get involved, we be able to get into court to challenge those detentions quickly. And that's one of the main reasons that we oppose the extensions of the timelines regarding to probable cause hearings themselves, which would extend up to, there would be times where, depending on the day that a PC hearing request was made, somebody would have to wait up to 4 or 5 days just to have that hearing. So that these are the types of situations where we would be calling in a PC hearing to say, like, look, something clearly didn't go right here, and we need to be able to get into court and point out that this detention was not really valid, and that needs to be able to happen quickly.
And council member, I'd like to really kind of circle back to what we said earlier, and that is the reason why training is so important, to make sure that when an FD12 is actually executed, it's executed within the criteria, the appropriate criteria. And we really work very hard in terms of the training in making sure that people are armed with those skills, so people are not inappropriately FD12.
Well, so let me ask this. Dr. Bazran, is your agency the one that's responsible for overseeing or collecting patient complaints regarding FD12 or?
Regarding whatever happens, we do have a hotline. We do collect complaints. We do have an ombudsman who works to resolve issues that are brought to us and does follow up on any issues that come related to behavioral health.
So have you all, in 2023, how many complaints have you all received around FD12 or improper involuntary commitment?
On that, but I have not heard of any specific complaints, but we can certainly look at our database and see if there's anything there, because we do keep a record of those complaints.
Okay. I'm trying to sort of thread the needle of balance here, because on the one hand, I hear PDS and I understand completely in terms of, you want the ability to represent your clients and to make sure that they're not being held unnecessarily or longer than they need to. But then I also hear the hospitals who are saying we need more time. How do we reconcile this?
So, as we have explained in our testimony, I think there's a few things that are important to remember. It's important to remember that there will always be at least 3 to 5 days of detention authority before the 7-day period begins, because there's that initial 48-hour period of detention, and there's the 24 hours that the court has to rule on the emergency petition. So that's 3 days there, and depending on the day of the week that those happen, they can turn into 5 days. And that means that by the time the 7-day period expires, there's always going to be at least 10 to 12 days of detention authority. But as we've pointed out in our written testimony and Ms. Sendinova's testimony earlier today, if there is ever a point where that 7-day period is coming to an end and the doctors believe that the person is still too dangerous to release, there is never anything about the statute as it exists that would prevent them from continuing to hold the person. And we've included in our written testimony literally a screenshot, a sample of the certificate that the doctor would have to fill out to get extended detention authority for weeks, if not months. And it's literally just a few sentences the doctor has to write down on a piece of paper. They send it to OAG, who files it. These are not reviewed by the court. The court doesn't have to approve it. Just by doing that alone, they get extended detention authority all the way up until when a commission hearing happens. There've also been concern expressed that, well, we shouldn't have to sort of trigger those formal 1-year commitment proceedings. But as the statistics show, that's not what's happening here. In 2023, the doctors filed those petitions for commitment in 605 cases. So in 21% of the FD12 cases, they decided we need more detention authority. This person is not safe to release yet. They filed that petition and they automatically got that additional detention authority. But that didn't mean in those 605 cases that there had to be more proceedings or that there had to be a commitment hearing or all those formal things, because then in 93% of those cases, they got that extra detention authority, and maybe a few days or a few weeks later, the person recovered enough that the doctors determined they were now safe to release. In 93% of those cases, that's what happened. Then they're released and the government dismisses the case. So there are no more proceedings that happen after that.
Okay. Are you not concerned about then doctors filing the certificate for this longer period of time when they don't need it? Or they may not need it?
So that is a concern, but that is how the law works. It's how it has always worked for 60 years, that just by filing that petition for commitment to get the extra time, that they do get the extra time. If there is a case where they do that and we believe they're then continuing to hold the person, we can then call on a probable cause hearing. But that ends up rarely being the case. I think the amount of times that we call in probable cause hearings after that initial 7-day period is, I can only think of 2 or 3 in the last maybe 4 or 5 years. It's rare.
Okay. One other thing that you guys, or not you guys, but has come up is around the portions of the legislation that speak to the use of a warrant, or if someone does not appear. And I heard in Ms. Semenova's testimony, she talked about the writ that can be done. I might be confusing the two, might be confusing the terminology. But then she said that—
I'm sorry, I don't know if others are having put out after.
Sorry, can you hear me now? Okay. You want me to repeat everything? Oh no, they froze. Is it us? Is it me?
Oh, we're back.
Oh, okay. I was like, is it me? Is it you?
The same argument told us it was us.
It's okay. I guess my question was, there was some conversation before around the use of warrant or the additional authority if someone does not appear or someone does not go through the particular treatment. And I think Ms. Semenova in her testimony said that there is already something that the court could issue if a person fails to appear, and that it doesn't happen. But I want to get some clarification. Is it that it doesn't happen that no one appear, or that someone does absconds and doesn't appear, which I think is false? Or is it that we are simply not taking that initial step to exercise the options that are already on the books for someone not appearing? I want to get clear.
The court, for many years, if somebody doesn't appear as required for judicial proceedings in an Urban Act case, they'll issue what's called a writ of attachment or an order of attachment. And we've reviewed literally every single Urban Act case that was filed in 2023, and that's where we got all these stats. There were 4 writs of attachment filed in 2023. All of those were in a separate type of case that we're not talking about here. They were in what we call private petition cases. Those are cases that don't involve the detention provisions we're talking about here. They're cases that are filed by like a family member to try to get their family member committed. And in 4 of those cases, when the respondent didn't appear for their examination by the commission, the commission judge issued that writ of attachment immediately upon their first non-appearance. They ordered the U.S. Marshals to go get them. So the court does have this authority and is absolutely willing to use it. But what Ms. Semionova was saying was that even though there were 4 in 2023, they were all in those other type of cases we're not talking about here, of which there are a very, very small number, just a couple dozen. Of the 2,905 FD12 cases that happened last year, which is something like 90-some percent, 95% of all of the overnight cases. In none of those was a writ of attachment ever needed. And so that's why there were none issued in any of the FD12 cases, because there was never one needed, there was never one asked for. In 2023, in those FD12 cases, there were 2 times where an individual eloped from a facility. And in that case, the court doesn't issue a writ of attachment because there's already a different provision, 21-592, that allows the government to ask for an order of return. We summarized both of those incidents in a footnote in our written testimony, but basically there were 2 people who were initially detained during that 7-day period. Both of them, I think, were taken either to another facility or another unit in the hospital for medical treatment, and they eloped. It happened 2 times. Immediately, the government asked the court for an order of return. The court immediately issued such an order, and the U.S. Marshals were ordered to go out and find the person. In one of those cases, the Marshals did. They found the person the next day and brought them back. And in the other case, the government dismissed the case for other reasons just a couple of days later. So the court has the authority and it will certainly use it. It just hasn't been needed.
Okay. And so, I mean, to USAO and OAG, how would you respond to sort of this idea that this change that we have in the proposed legislation is not needed because it's rare that there are failure to appears?
We do believe that the change is needed. I'd say the primary reason why the existing mechanisms are used so sparingly is because they only apply in a very, very limited subsect of cases. The writ of attachment is a remedy that's available to a magistrate judge to issue to have someone appear for the Commission on Mental Health hearing, the initial commitment hearing that occurs at St. Elizabeth's Hospital. Well, that traditionally occurred at St. Elizabeth's Hospital. But it's important to note that the way that the DC Superior Court manages its mental health calendar is that there's one magistrate judge and 2 associate judges. And we are not aware of any authority that would allow an associate judge to issue a writ of attachment for the 5 or 6 other hearings that a respondent in a mental health case may or may not encounter. So we're talking about probable cause hearings, revocation hearings, trials, status hearings. I guess I'll stop there, but in none of those hearings, at least per our interpretation of the law, do we see a mechanism that would allow an associate judge to issue a writ of attachment. And the other mechanism that PDS mentioned that I believe appears in 21-592 is again extremely limited. It's a mechanism that allows OAG to ask the DC Superior Court for an order to return. Basically, the language says something along the lines of a mentally ill patient who escapes from the hospital. So again, we're talking about someone in a very limited situation. There's no mechanism to say enforce someone who's not complying with their outpatient commitment order. There's no mechanism to enforce compliance from someone who's just under an emergency detention order. So I think it's not entirely accurate to say that we have this wide range of mechanisms that are utilized. The reason they're not utilized is because they're extremely limited.
Okay.
And I'm sorry, I need to respond to that if that's okay. So
sure. I just wanted to give USAO because you might want to respond to both. So I just want to give them opportunity to.
Thank you. We support the addition of the arrest warrant authority, in part because, especially in cases that civil commitment cases that are related to criminal cases that are not able to go forward due to a Jackson finding, a finding that somebody is incompetent and unrestorable, it's important that at the very least, the community can be assured that the person is getting the mental health treatment that they need. And if the court currently does not have the ability to seek those people out and ensure that they are engaging in the process, then that diminishes the value of being able to transition a case from the criminal justice system to civil commitment. So we support that, that provision for that reason.
Okay, go ahead, PDS.
So 21-592 that Mr. Pace said was extremely limited. It currently says that anybody who's detained under the Urban Act and is confined in a hospital or any institution, if they leave it without authority or if they fail to return as directed, they can be subject to an order of return. So there's anybody who is being detained under the Urban Act. If they leave and they're not supposed to, this statute allows for the order of return. He also talked about how the writs of attachment are only used by magistrate judges in commission hearings. And specifically, it's actually magistrate judges presiding over a case where somebody, respondent, doesn't appear for the examination part of that hearing. And that is absolutely true, but that's because, as we said, that is the only part of these proceedings that an individual is compelled to attend. He mentioned PC hearings. Well, probable cause hearings are never going to be an issue because by definition, a probable cause hearing is for somebody who is already in detention. And at trials, at the trial stage, if somebody, a respondent, gets a recommendation for commitment at their commission hearing, the next stage is that they can request a trial. They do not have to show up for that. The way the statute works is they have to affirmatively show up and request a trial if they want one. And so if they don't show up and do that, then the statute says the court is supposed to look at the commission's report and issue an order based on that. So if they don't show up for that trial stage, if they don't show up for that status hearing, then the court just issues an order civilly committing them. And that is how it has always been. That's how the statute was designed. Lori Davis, who presided over the amendments to the statute in 2002, discussed exactly this in her written testimony about how if somebody doesn't show up, then they just get committed by default. And I've seen as recently as just a couple weeks ago, I've seen a judge issue an order in an Urban Act case where somebody was pending the trial stage and that person had requested a trial. One of the other parties raised concerns that, oh, well, they're not going to show up. They said they're not going to show up. The court issued an order that says that's fine. If they don't show up, they lose. They will be civilly committed. And in the end, the person actually did end up showing up.
Okay, I'm well over my.
If I could just respond to that really quickly. I think the concern that I just want to reiterate from the USAO's perspective is that if orders for civil commitment are being issued and the person is not there or not engaged in the process, there are concerns about their engagement in the services that are going to be ordered through that civil commitment order. And then again, it seems like it's a futile process then for people to be going through this process if they're simply not going to engage. And then we're going to continue to have people who are not engaging in mental health services in the community. And we're going to have the issues of recidivism that we've discussed already.
And so that's certainly a fair concern. If it's just a separate concern. And like we said, again, there's it's a very comprehensive portion of the statute that already exists, 21-548, that says exactly when and how somebody can be taken into custody if they're not complying with their treatment. That always exists. It has always existed since outpatient commitment became a thing many, many, many years ago. And it says that if somebody's not complying with treatment, it lays out a whole procedure. They can be, after 12, taken back into custody, held. They can have their outpatient status revoked by the court and be held as an inpatient then. So if somebody's not complying with treatment, the statute already covers exactly what can and should happen then, and it involves taking them into custody.
At the fear of embarrassing myself, but I'm still going to ask it anyway, because I'm not a lawyer, so I'm going to ask. And perhaps some people who are watching who are not lawyers are confused too. what then is the difference between a warrant and an order to appear?
So a warrant would allow for law enforcement to take someone into custody, and then they would either have to be returned to a jail or some type of cell block. And the reason why we are opposed to that type of posture is because it does criminalize someone's mental illness. And our statute specifically says that respondents that are committed or subject to the proceedings of the Irvin Act should not be jailed or shall not be jailed. And we think that the framers were very cognizant of the fact that they did not want to criminalize someone's mental health status, and then were able to arrange other ways to bring someone back into custody if that was necessary. So for instance, an arrest warrant would not allow a police officer to take someone to St. Elizabeth's. That's not what arrest warrants authorize law enforcement to do. They would authorize law enforcement to take that person to some type of penal place, either a jail or to the cell block.
But let me just ask. So if a judge though issued an order to appear, are you saying that the U.S. Marshals would only execute on that during regular business hours? No.
The order to appear, the marshals will go out if it's a writ of attachment, and I've had it happen in my cases. I've seen it. The court issued a writ of attachment. The marshals went to where they believe my client was. My client was there. They brought him to court. We had the hearing that day. And so what didn't happen was that my client was held in the jail for several days waiting for the hearing to happen. The writ of attachment authorized the U.S. Marshals to go out that morning, get my client, and bring them to court. And that's exactly what they did.
And just to be clear, I think the framers back 60 years ago knew warrants were inappropriate. If you look at the provision of the statute 21-521 that talks about FD12s, the way they describe it is they say somebody can be taken into custody if they're mentally ill and dangerous. Without a warrant, they can be taken into custody. It explicitly says that. So the framers knew warrants were not appropriate under these circumstances.
Okay. I'm well over my time. Councilmember Parker, this is going to have to be the last round.
Yes, and I'm not going to even take up the whole time. This was a really fascinating exchange. I learned a lot, and I appreciate you all sharing. I want to come back to where I started in my introduction to the topic of FD12 and this entire process. Due to an incident in Ward 5 where an individual suffering a mental health crisis savagely attacked educators as they walked with young people from a nearby daycare. And I am really sympathetic to the rights and interests of that individual. I'm also really concerned about the communication and safety of neighbors who, after that incident, had a lot of questions. They were unclear whether or not he was gonna return after 48 hours and 7 days. The daycare had to completely revamp their operations. And I just lift that up because there's another side to this, that none of this exists in a vacuum, and I'm sure we can all appreciate that. And sometimes, unfortunately, communities are caught up in this process. It's also worth noting that individual did, in fact, return to the community, even though there was a stay-away order issued, and I believe had to be recommitted. And there is a separation between what I can know and what's been told to me. But I do know he violated the stay-away order in another act of threatening behavior to neighbors. So that is not to demonize and fearmonger, but it is to say that there is a need for us to address these very real loopholes. And that is why I, continue to believe and support moving this legislation forward. Today, I think we've heard some ways in which we can make some tweaks. Dr. Bazran, I appreciate you pushing on the need for any training to be interactive or in person. I agree with that. I think there may be some tweaks to like the detainment periods. I appreciate Mr. Pace, this clarification and clear definition of when the clock starts for that 48-hour clock. And there are many other things that we heard today. To our friends at PDS, I think you've given us a lot to think about, like how do we have checks and balances within this legislation, within the system, so that we can protect all of our neighbors, including those that may be suffering from a mental health issue. So I'll end there, but I want to thank you, Councilmember Henderson, for hosting this very important conversation. I know Ward 5 neighbors are tuned in and paying attention, and I want to thank you all for sharing today. Thank you.
Thank you so much. Councilmember Parker, the Committee on Health is supposed to have a markup immediately following this. If you could check your text, that'd be great before you.
Okay.
That'd be great. In terms of this hearing, I want to get this right. And also council recess is about to start. So it's not as though we're marking this up next week or in the next few weeks. And so I hope that all of our government witnesses will be open to communicating with my office so we could try to strike the right balance here. I think we're in agreement on some pieces. There's some disagreement on some other pieces. And this is just part of the legislative process, our ability to sort of talk through these things and try to move forward in the best way possible on behalf of district residents. I want to thank all of the witnesses who spoke today. The record for Bill 25-0692, the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024, Bill 25-759, the Child Behavioral Health Services Dashboard Act of 2024, and Bill 25-696, the Advancing Range of Reproductive Options for Washingtonians Amendment Act of 2024, will remain open until 5 p.m. on July 25th for public to submit testimony. You may submit written statements via the council's hearing management system on the council website at dccouncil.gov/hearings. We also have a number of public witnesses for whom we want to follow up with once we have their written testimony. And I hear from all of you, all of our government witnesses, that your written testimony is much more involved with footnotes and all the things than what you presented here today. So we'll certainly review all of that. The Committee on Health will hold an additional committee meeting immediately following this. We will be marking up nominations to the Board of Social Work, the Board of Pharmacy, the Board of Dietetics and Nutrition, the Board of Medicine, and the Board of Dentistry, as well as the Certified Nurse Aid Amendment Act of 2024, which is a bill in terms of long-term care. Just for folks who might be watching on that, we have to conclude this Zoom and then we will start a new Zoom for that particular markup. But it should only take a few minutes in order for us to get in order on that. There being no further business before the committee at this time, the time is now 3:08 p.m. and this hearing is adjourned. Thank you all so much for your attention to this matter and for your willingness to be here and discuss. Thank you.
Thank you.
Thank you. Thank you.
Thank you.